Right. So as I say, this is going to be the third study day we've run over the last 12 months. And we originally designed this study day to kind of run internally for UCLH staff. But we realized that there's probably a lot of teaching we're going to be doing that people across the NHS might find interesting. And, as educators, which both Tassie and I are, it's important, I think, from our perspective that we think, these study days should be free and easily accessible. It's expensive to keep our practice up to date and get enough CPD. So we want to make sure that that burden isn't added to with this study day. So we're really pleased everyone can join us today. We have a wide range of people we know that are going to be joining us to learn today. So that's based on feedback from previous study days, where we have people obviously working in the hematology area and oncology, and then of course critical care. But we also know there's a number of people who will be listening in who do critical care outreach, emergency department, and acute medical. So hopefully everyone will have something that they can learn from this study day and brush up on their knowledge, because I'm sure we're all aware that, hematology patients by and large can be a pretty complex group of patients with a lot of knowledge needed to kind of look after them. So some of the people joining us are going to be quite new in their career to healthcare. Some people might have been in it their whole career in a specialty. And we know from previous study days, we've got a good mix of sort of professionals who are in today. We've got definitely a good number of nurses and doctors, a pretty even split, and also a number of AHPs from across the spectrum. Obviously, it would be great if we could have you all on camera and on microphone, but with this many people, that's going to be really difficult. So we're going to use the chat to field questions from you all. And so whenever you want, at any point in the presentation, before, during, after, you can type in a question and we'll either get the question answered by the speaker, or we can have them join the chat afterwards and answer more questions in depth to you directly. So just to kind of give ourselves as the hosts a little background, my name's Gavin Cooper. I've been a nurse educator in hematology for 10 years. But in the last 3, I've been working in the dedicated hematology ICU at UCLH. And my co-presenter is Taciana Amaral.
Hi, everyone. Good morning. Yes, my background, I've been working in ICU for the last 10, 11 years as well. And for the last 2, almost 3 years, I've also been one of the educators in ICU in UCLH.
Thanks, Tassi. So we're kind of mostly predominantly working in this building here. Grafton Way building is now where we cohort our hematology patients, both from the inpatient wards, but also the critical care unit. So they're not kind of spread out throughout the hospital anymore. And we have about 100 inpatient beds there for adult patients receiving hematology care and a 10-bedded intensive care. So we see a lot of patients from across the spectrum of hematology disorders, a lot of teenage and young adult patients. We even have some private patients, but a lot of stem cell transplants and CAR T cells, a large group of sickle cell patients who need care, and an ever-increasing number of immunotherapy patients who are coming in. So lots of different things that might make someone sick and might need an intensive care bed, and this is where we would care for them at UCLH. So we've got speakers from across our hematology and intensive care department to give their insight into these really acute problems that can make hematology patients deteriorate. So we have 5 sessions on the main topics we think would be really useful for your learning. We're going to run another study day in May, and that one will have all new topics. So we'd really like your feedback later on in this when we ask for it, for recommendations for topics that you'd like to hear on in the feedback section. So there will be a form that will send a link out to you at the end of the study day. And when you complete that, it'll just take a minute. You can fill in your name and your email address, as well as giving us the feedback, and we'll send you a certificate of attendance. But we're not able to give feedback. Sorry, we're not able to give certificates to anyone who doesn't provide feedback. So we'll reiterate that later on, just in case anyone's not aware. You might also notice everything's being recorded, and we'll do an edit of this study day, so it's all the kind of the relevant stuff, and get rid of any gaps and send that out in a few days. So hopefully that all sounds good. This is going to be the layout of the day. So this is these are our presenters. We're going to start in just a minute with Dr. Matt Stubbs talking about thrombotic thrombocytopenic purpura. After that, I'll be talking about tumor lysis syndrome, and following nicely from that, we'll move straight into AKI with Dr. Nish Arulkumaran. After the break, we'll have 20 minutes to break just to get your cup of tea and coffee and refresh, and then we'll move on to yet another long hematology named presentation, Haemophagocytic Lymphohistiocytosis. Again, another rare condition that kind of straddles rheumatology, hematology, which Dr. Sat Gohel will talk about. We are then moving into post-transplant complications with Dr. Kate Stringaris. We've always, the last two study days, we've actually kind of missed out an opportunity to have this session. So we've asked Dr. Jim Down to talk about actually one of the most difficult and important things when it comes to ICU care for, cancer patients and hematology patients is, do we have the right discussions, and do we set the right ceilings of care before patients are getting unwell, and also when they're already unwell. So he's going to tackle that big subject. So I think I've just shared my screen. Or Tassie, can you see my screen? I've just pressed the button by mistake.
Yeah, we can.
Still see it. Okay, cool. And then we'll have a break. And then we'll have acute complications of sickle cell disease with Dr. Perla Eleftheriou. And then finally, CAR T-cell complications as well with Dr. Mike Northend. So hopefully that will be a really good amount to go through. We've asked everyone to keep it nice. These are 30-minute sessions with 10 minutes of question time. So anything you want to learn on top of it, please type in the chat. And we've asked our speakers to really try to focus on information that's really helpful at the bedside, keep it really relevant to our everyday practice. And I think that's really the main things I wanted to cover right now. So I'm going to unshare my screen, and I'll just see whether our first speaker, Dr. Matt Stubbs, is ready to begin his session.
Thanks, Gavin, and thanks for the invitation today, and everyone for listening to these presentations. I hope this content is useful. Just to give a brief overview of the things I'm going to be talking about today. So I'll start by talking about thrombotic thrombocytopenic purpura and the other thrombotic microangiopathies in terms of background, differential diagnoses and investigations. I'll then talk about immune-mediated TTP, one of the two main types of TTP. I'll talk about the emergency acute management and the evidence that underpins that, and then also the outpatient management and follow-up for these patients to try and keep them well and prevent acute episodes. I'll then talk about congenital TTP, the other more rarer form of TTP, and then I'll conclude by again discussing some of the other thrombotic microangiopathies and updating what's been going on with TTP in England over the last few years with the formation of TTP specialist centres. So by way of background, TMA or thrombotic microangiopathy is an umbrella term really referring to these two central features where there's thrombocytopenia and microangiopathic hemolytic anemia. And those two features are necessary for a diagnosis of TMA and TTP. TTP is one of the main types of TMA, and this is what's going on from a pathophysiology perspective. Panel A shows us what's happening in normal physiology, with VWF shown by the black strings secreted from the endothelium. And the role of ADAMTS13, which is central in the pathophysiology of TTP, is to cleave these ultra-large VWF multimers. Panel B below shows us what's happening in TTP, where there is either an acquired, such as an autoimmune deficiency in ADAMTS13, or an inherited congenital deficiency, congenital TTP, where there's low levels of ADAMTS13. And what that results in is build-up of these ultra-large von Willebrand factor multimers, which are highly prothrombotic and form platelet-rich microthrombi. And it's this microthrombi that leads on to the characteristic pathophysiology and the multi-organ involvement in TTP. So if I just take a step backwards and talk about thrombotic microangiopathy more generally, as I say, this is an umbrella term that covers a wide range of different disorders that I'm trying to cover here, with TTP being the number one on the worry list and one certainly not to miss. But it's very difficult to tell the difference between these disorders, and there's often significant overlap both in clinical and laboratory parameters between these conditions. I'll briefly talk about some of the clues when we're trying to make this clinical diagnosis up front, but certainly there can be significant overlap between these disorders. When considering a potential diagnosis of TTP, the most important and first thing to consider is the clinical history of the patient. As I said, there are lots of different disorders that can present in a similar way, and I've listed some of these disorders along here. So really having a good grasp of the background and the clinical history of the patient is really important. It's possible to get TMA, thrombocytopenia, and MAHA with these different disorders, and important differentials include things like metastatic malignancy, extensive valvular heart disease, liver failure, as well as all these other conditions listed here. Particularly wanted to mention autoimmune disease, because autoimmune disease can be presented either as a new diagnosis of TTP in a patient with existing autoimmune disease, but TMA can also present in other non-TTP autoimmune conditions such as lupus nephritis and scleroderma. The British Society of Haematology published updated national guidelines for diagnosis and management of TTP in 2023. The central recommendations I've just put down here on the left-hand side, particularly important from an ITU perspective, but TTP is a medical emergency and the treatment is time critical, and these patients require an immediate transfer to a specialist centre for dedicated treatment. This should be done in a specialist centre, of which there are 9 centres over the 11 sites within England, and often involves patients being managed in the critical care centre. As I mentioned, the emergency treatment is time critical, and these patients should be ideally starting plasma exchange within 4 hours from referral to the initiation of plasma exchange. And we know that for these patients, time matters. So any delay, whether that be delay in diagnosis, delay in transfer, delay in line insertions, or starting plasma exchange, can have significant consequences for these patients. I've just put there as well the platelet transfusion should be avoided. I'll mention that later, but that's just a particularly important point within a critical care setting, because often these patients require VAS cap insertions and they're often significantly thrombocytopenic. But as this disorder is prothrombotic and platelet transfusions can worsen the condition, platelet transfusions are contraindicated. In terms of investigations that are useful when we're trying to make a diagnosis, routine parameters that will be available in most hospitals will be things like full blood count, showing usually a moderate to severe anemia, thrombocytopenia, markers of hemolysis, such as a raised reticulocyte count or LDH. There's usually blood film features such as red cell fragmentation, polychromasia. Patients often have a normal coagulation of fibrinogen with a negative DAT. Often there's a raised bilirubin, renal impairment. About 50% of people have a positive troponin. There's association of TTP with HIV, and also hepatitis status is important for subsequent treatment. And also pregnancy is associated with TTP as well as other TMAs. One of the major mimicking conditions of TTP is HUS or atypical HUS. So testing for sugar toxin producing E. coli can be very useful in these patients if suspected clinically. I mentioned down below the specialist testing, but this is really to confirm the clinical diagnosis. So patients should be being triaged based on the likelihood of TTP and managed appropriately. But once they've been transferred to a specialist centre, then specialist testing with a confirmatory ADAMTS13 assay will confirm the diagnosis of TTP. And following on from this, autoantibody testing for anti-ADAMTS13 immunoglobulins can help support the diagnosis of immune-mediated TTP. ADAMTS13 is a very reliable test in terms of making the diagnosis of TTP. We can see on this graph some of the mimic conditions such as HUS, sugar toxin, HUS, or other secondary TMAs can be associated with a low ADAMTS13, but severe deficiency is mnemonic of TTP and helps us differentiate between these other conditions when there's clinical ambiguity. I'm just going to talk a little bit now about immune TTP. I'll start by talking about the acute management and the evidence that underpins that, and then talk about some of the outpatient management and pathophysiology. So this slide really goes right back to the beginning of TTP therapy. As I mentioned, suspected TTP is a clinical diagnosis, and this requires discussion with a specialist centre and transfer usually to a critical care unit within that centre for the initiation of the emergency treatment. And there are really 4 pillars for the management of acute immune-mediated TTP, that being plasma exchange, steroids, rituximab and capitalizumab, and I'll talk through those therapies over the next few slides. This figure here, published in 1991 by the Canadian apheresis, so this was really a game changer in terms of TTP. And for those of you not familiar with this graph, this is a Kaplan-Meier survival curve, where the percentage of patients alive at a particular time point is tabulated. And what we can see, patients that were treated with plasma exchange compared to plasma infusions, there was over a 20% survival advantage when patients were treated with plasma exchange. And this was really a monotherapy back then, but these patients were treated with plasma exchange had a significant survival advantage compared to plasma infusion. And the rationale for that is plasma exchange is really enabling us to give to these patients a large dose of ADAMTS13 to replace the ADAMTS13 that's been destroyed by the autoimmune process. As I say, for many decades, plasma exchange has been the mainstay of treatment of TTP and remains the gold standard treatment for immune-mediated TTP. But it may be possible in the next few years for patients to be managed without plasma exchange. There have been some case series looking at Jehovah's Witness patients who've declined plasma exchange, who've been successfully managed without plasma exchange in the modern era, although typically milder disease phenotypes. There's also been a small cohort of the Austrian-German study looking at 14 patients during the COVID pandemic that were managed without plasma exchange with the use of capitalizumab. And then if we look at some more modern randomized studies, the Mayari study was a recent RCT looking at patients being treated with capitalizumab without plasma exchange, which is now closed. There's also been the phase 2A and 2B study where recombinant ADAMTS13, so fully man-made recombinant ADAMTS13 has been used for the treatment of TTP, both in the phase 2 study in addition to plasma exchange, and we've been recruiting patients currently for the phase 2B, where we're randomizing patients to receive recombinant ADAMTS13 versus plasma exchange. And hopefully this may be the future of TTP management if these trials go well. The next pillar of acute TTP management is really rituximab. And again, there's another survival curve here really to show the proportion of patients in remission. And what this shows us is patients that were treated historically without rituximab, shown in the dotted black line, compared to patients in the solid black line that were treated with rituximab. Patients that received rituximab were much more likely to remain in remission following their acute episode. And giving patients rituximab early within the first 3 days was shown to reduce the number of plasma exchanges that patients needed, the length of stay in hospital, and also the time it took to achieve remission. So a very important treatment in the first few days of TTP management. The relative new kid on the block for many years now has been capitalizumab, which was licensed in the UK in 2019. And this is really the hallmark paper, the Hercules study, phase 3 randomized control study, looking at capitalizumab in immune-mediated TTP. And what this drug does, it's a nanobody, so a partial antibody against the VWF multimer. And this leads to a interaction and interference between the normal interaction of platelets and the ultra-large VWF, thus breaking the pathophysiological cycle in these patients. So whilst it doesn't do anything to address the underlying autoimmune process, it prevents the multi-organ thrombosis that occurs in these patients. And when we look at the time to platelet count normalization, this graph here shows us how much quicker patients normalize their platelet count, shown in black, compared to historic patients that didn't receive capitalizumab. So an improvement in the time to platelet count normalization. And whilst the reduction from 6 days to 4 days may not sound like very much, these are 2 critical illness days where patients are at high risk of morbidity and mortality during this time. So a significant improvement for these patients. The UK in 2022 published the largest national real-world experience of captacizumab, similarly showing reductions in the number of plasma exchange and improvements in the time to platelet count normalization. This was real-world data, so non-selected data, and there were 5 deaths reported during this period. This next slide here looks at those 5 deaths and really has some important lessons for us in terms of managing TTP, which I think have already been learned from. But if we look at the time to patients receiving captacizumab either within 48 hours or less than 48 hours within diagnosis and compare the survival status, 4 out of the 5 patients received their captacizumab more than 48 hours after diagnosis. And what this typically resulted in these patients was establishment of a established stroke and secondary hemorrhagic transformation of that stroke, which when we give the patients captacizumab early is usually presented. And during this follow-up period, we did see that there was a trend to an improvement to the time for captacizumab administration, with the majority of patients now receiving within 12 to 24 hours. When we talk about the follow-up of immune TTPs, this is when the patients are better and discharged from hospital. This is a kind of summary of the usual treatment course for patients with an immune-mediated TTP. We can see shown in blue, the platelet count, so severe thrombocytopenia at the beginning and at diagnosis, with also in red a severe deficiency in ADAMTS13. Patients are treated with the 4 pillars of TTP treatment, so rituximab, steroids, plasma exchange, and captacizumab, and that usually leads to quite a brisk improvement in the platelet count. Over the following weeks, and usually now in the outpatient setting, we monitor the patients for a normalization of their ADAMTS13, and the majority of patients we would achieve an ADAMTS13 remission, meaning a normal ADAMTS13 activity. These patients are all offered outpatient follow-up within every 3 to 6 months to monitor for a subclinical relapse, and around 30 to 50% of people will have that. But by monitoring these patients' ADAMTS13 in the outpatient setting, we can offer them elective therapy with elective anti-CD20 therapy, such as rituximab, to prevent them having an acute episode and all the associated morbidity and mortality with that. We published 2 years ago the largest follow-up of immune-mediated TTP patients, which was 443 patients over a 10-year period. We identified around 30 to 50% of these patients had a relapsing pattern requiring elective treatment, with 6% having a frequent relapsing pattern within every 6 years. But what we did see when we followed these patients up is elective anti-CD20 therapy was very effective in normalizing ADAMTS13 and preventing relapse, and didn't seem to lose efficacy over time. With TTP being an autoimmune disease, we do see slightly higher rates of reactions to rituximab than other indications, such as malignant indications, with around 5 to 10% of patients having some kind of severe reaction to rituximab. And that can either be in the form of an immediate anaphylaxis or a delayed serum sickness type reaction. But recently published, we've now shown that alternative anti-CD20 therapies such as obinutuzumab or ofatumumab are highly effective in normalizing ADAMTS13 and also preventing relapse in these patients. When we think of the pathophysiology of immune TTP, there have been genetic associations identified with TTP risk, both HLA and non-HLA. And HLA-DRB111 has been shown to be a risk factor for patients developing immune-mediated TTP. And HLA-DRB104 has been shown to be associated with decreased risk of developing TTP. In addition, within the TTP cohort, when we compare patients that have a relapsing pattern and a non-relapsing pattern, HLA-DRB115-01 has been associated with a frequently relapsing pattern. So that's a summary of patients with immune-mediated TTP. I'm now just going to talk a bit about congenital TTP and some of the updated evidence and publications that support our management for this. So a few years ago, the UK published the largest national cohort of congenital TTP patients at 73 patients with both a mix of homozygous genetic variants and heterozygous variants. There was a peak seen of diagnosis in childhood and also during pregnancy. And the genetic variants occurred throughout the ADAMTS13 gene. What we saw is these patients frequently had recurring non-overt symptoms, but these often improved when the patients were established on regular prophylaxis. And historically, that's been to replace ADAMTS13 either in the form of FFP or BLP8Y, which is an intermittent purity plasma-derived coagulation factor that contains ADAMTS13 in addition to factor 8. We also saw that the incidence of stroke reduced significantly from 17% to 2% when patients were started on regular prophylaxis. So this next slide is a recent publication showing us what we think is happening in these patients' blood vessels. I talked about the microvascular thrombosis that's occurring in these patients. But what this is looking at is TTP patients' blood over time. And what figure 1 shows us is a normal patient's blood, whole blood, passed through a tiny artificial microfluidic channel designed to replicate a blood vessel. And what we see over time, as you can see in figure 1, is slowly platelet-rich thrombi adhere to the channel, and there's increased levels of thrombosis. What panel 3 shows us below is a congenital TTP patient, same congenital TTP patients at the same time point. On the left-hand side, when they haven't received their prophylaxis before their plasma infusions, and secondly, after their prophylaxis. So showing the difference in microvascular thrombosis that's happening in these congenital TTP patients. So really meaningful differences in their thrombosis. This most recent publication has been published in the last few months. So a New England Journal paper looking at recombinant ADAMTS13 in congenital TTP. So this is a phase 3 study in congenital TTP patients, a crossover study owing to the rarity of the disease. And this is now for the first time a fully recombinant, non-human source of ADAMTS13 for congenital TTP patients. And what we saw in this study was these patients were achieving much higher peaks of ADAMTS13 when they received recombinant ADAMTS13 compared to plasma or VLP-8Y, and that's shown in the red, so much higher peaks towards 100% ADAMTS13 activity. But during the course of the week, the patients maintained an ADAMTS13 level above 5% until 7 days. There were low rates of adverse events in the recombinant ADAMTS13 arm, no events of hypersensitivity, and importantly, when we compare this recombinant product to other recombinant coagulation factors such as factor 8 or factor 9 seen in hemophilia, there were no incidences of anti-ADAMTS13 antibodies developing during this treatment period, which is great news for these patients. So I'm just going to move on to my next slide to talk about some of the other conditions that may mimic TTP, such as hemolytic uremic syndrome. So hemolytic uremic syndrome and TTP are similar in lots of ways, presenting with MAHA, thrombocytopenia, and organ dysfunction, typically neurological involvement, renal involvement, and cardiac involvement. But the pathogenesis is different, and I'll talk about that on the next slide. There are some common misconceptions between HUS and TTP, which I'll just run through here. People often think that aHUS only affects children. This patient is an adult and thus it can't be aHUS, but that's not true. And we see around 40% of patients diagnosed with aHUS are adults, and this often happens in the postpartum period. Another common misconception is this can't be aHUS because the patient has neurological involvements and thus it must be TTP. But actually nearly 50% of patients with aHUS do have neurological dysfunction, and that can be severe and potentially life-threatening in these patients. So that isn't unique to TTP. People often assume that clinical symptoms can differentiate between aHUS and TTP, but again, that isn't the case. And actually, there have been cases where we've been surprised, even in the specialist centres, that the diagnosis is TTP or aHUS. And the most reliable way to differentiate these conditions is between ADAMTS13 measurement to confirm or refute the diagnosis of TTP. Here's a brief summary of the pathophysiology that's going on in aHUS. But what we often identify in these patients with aHUS is they will have genetic variants within the complement proteins, and that can either be gain of function variants within the complement proteins, such as complement factor C3, or loss of complement regulator variants, such as complement factor H. Patients with variants within the complement factors typically have a worse outcome, and a high number of these patients will have mortality or end-stage renal failure without treatment. Fortunately, now there is good treatment for these patients with aHUS, initially in the form of plasma exchange as per TTP, and this both replaces complement proteins and removes any autoantibodies that may be present in these patients. And following on from that, complement blockade with firstly eculizumab and now more recently ravulizumab has been very effective in these patients, with the majority of patients being able to discontinue dialysis and achieving hematological normalization of their parameters. I want to just mention specifically pregnancy-associated TMA, as this can be a very difficult cohort to diagnose, as there's often significant clinical overlap between these conditions. And I would strongly recommend, if you have a patient with who's pregnant with TMA, I'd recommend discussing this case with a TTP specialist centre, as they're often very difficult to diagnose. There are some common threads shown here in a publication from 2016, which can be useful, but as I say, I would strongly recommend that this case is discussed between whether the local team is specialist obstetrics and haematologists specialising in TTP and TMA to make a management plan for these patients. So just to come full circle, as I mentioned, that TTP is one of a group of conditions called thrombotic microangiopathies, and these can present in very similar ways. It's important to take a clinical history to try and elucidate if there is an underlying diagnosis, and also laboratory testing and discussion with a specialist TTP site to make a diagnosis of TTP. As of 2022, England has now become the first country in the world to have a nationally commissioned TTP programme. And what that means is there are now 9 specialist TTP centres across England, over 11 different sites, and they will be the first port of call for discussion of any suspected TTP cases within your area. And they should be able to facilitate the emergency treatment of patients with immune TTP, but also the follow-up and monitoring of patients with TTP. I've just put a specific slide in here, which really relates more to London and the South East, but one of the major delays of patients being transferred to a specialist centre can be the ambulance transfer. For those of you not familiar with the ambulance service recommendations, Category 2 is a critical transfer, which is where a patient needs immediate transfer to a different healthcare facility for immediate life-saving treatment. This is the same category as a STEMI, where they would need to go to a PCI centre or an acute stroke thrombolysis call. And so when a Category 2 ambulance transfer is requested, the patient should ideally be collected within 20 minutes from their local hospital. And I would always recommend a senior clinician with knowledge of TTP contact the ambulance service, because you'll be able to better advocate for the clinical urgency of the transfer, and that's sometimes lost when done by a non-specialist. So just to conclude on this final slide, so as I mentioned, TTP is one of the disorders within the umbrella term of thrombotic microangiopathies. Any patient with MAHA and thrombocytopenia with an absence of an underlying cause, TTP should be considered, and I'd recommend discussion with a TTP specialist centre if there's any diagnostic uncertainty. It's always more appropriate to assume the patient has TTP and discuss and refer these patients. As I mentioned, the management is time critical, and there can be significant morbidity and mortality when there are delays in diagnosis. The management is urgent plasma exchange, which should be commenced within 4 to 8 hours of referral as per the most recent BSH guidelines. And just to reiterate, this is a hematological emergency and it should be treated as such. So I'd like to thank my colleagues, haematology consultants, haematologists, referring sites, our colleagues in ITU, AFRIS, and nursing colleagues, and the research unit at the laboratory for all help and support with our TTP patients. I'll stop sharing my slides now, and I'm happy to take any questions before the next speaker joins.
Hi, Matt, thank you. We have a few questions in the chat for you. So our first question is, could you please clarify how and when we should test for atypical HUS as a differential? This is tested for in Newcastle, thanks.
Yes, so it varies between regions, but you're right, Newcastle is the national aHUS centre. Locally at UCH, we take patients for both suspected TTP and aHUS, and obviously the emergency treatment with plasma exchange is the same. So usually overnight we would manage these patients with plasma exchange. We ourselves would run an in-house ADAMTS13 the following day, and obviously if it's TTP, we would commence down the TTP treatment route with capsizumab, rituximab. And if the patient does not have TTP, has a normal ADAMTS13 assay, then typically these patients will be discussed with a AHUS centre, and renal genetics will be taken. But also, there's no immediate diagnostic test for AHUS. It's really a diagnosis of exclusion. So the genetic testing often takes several weeks. It's not like TTP where you can do an ADAMTS13 within a few hours. The genetic testing does take time, and so there's really an exclusion of other diagnoses. So you'd want to exclude TTP with a normal ADAMTS13. You'd want to exclude typical HUS with a PCR for sugar toxin producing E. coli, and also all the other conditions that I mentioned, that TNA umbrella terms, such as malignant hypertension, sepsis, malignancy, and then manage the HUS patients following on from that.
Lovely, thank you. We have a couple more questions. So the next one is, how long do we carry on with the plasma exchanges for? Is there a target to aim for?
In TTP, we would usually continue plasma exchange until the patient achieves a normalization of the platelet count. In the historic era, before patients were treated with capsizumab, we would often continue plasma exchange for 2 days after they, or 48 hours after they normalized. But now patients are on capsizumab. Usually we would stop this when the patient achieves normalization of ADAMTS13, normalization of their platelet count, not ADAMTS13, sorry, that's later.
Thank you. Our next question. So in Yorkshire, it seems a little odd that immediate transfer to a specialist centre is now recommended as Plan A, rather than initiation of plasma exchange where the patient is. Do you have any comments on this?
There will be variability between different geographical regions depending on what apheresis services are available locally. Obviously, for the patients, the important thing is that they are timely managed with plasma exchange. Obviously, with rare diseases, the incidence of TTP we see roughly for the entire of London and the southeast around 1 case a week. So I think there is a benefit to patients being managed in specialist centres so that they can, when unusual things happen, there's more knowledge of this. But certainly the idea of the national service is that treating centres have a network to discuss cases, and we all gain and learn from each other's experience. And there are now established MDTs to discuss TTP cases, to try and all of us to benefit from shared knowledge in these cases.
Thank you. I think that you've already answered our next question. So the next question is, what clinical and laboratory parameters will guide you to whether continue or stop plasma exchange? And I believe you've already answered that one. So I'll skip to the next one. So in terms of stroke exclusion in this context, how low a threshold is there for intracranial imaging? For example, might you image them even in the absence of neurological symptoms?
Yeah, that's a great question. And the answer to that is yes, we image all our, at UCH, we image all our patients, not usually acutely, because it's not going to change what we're doing. We're giving plasma exchange and capsizumab unless there's a clinical concern that they've had an intracranial hemorrhage. We would usually want to undertake an MRI scan to look for white matter changes or any silent infarcts during the acute admission. And a lot of patients will have subclinical neurological involvement, even if we can't see that on clinical grounds. So yes, we would want to image all patients with an MRI to establish any neurological consequences of the acute TTP episode. We also do both memory screens, both acutely and in follow-up, and also a psychological assessment for mood disturbances, because those are very common complications of TTP.
Thank you. I think our next question, I think we have time for a couple more. So my next question is any enzymes involved in AHUS?
So as I say, AHUS is a diagnosis of exclusion. So we want to obviously exclude a deficiency in enzyme ADAMTS13. We monitor patients for, we would screen patients for low levels of C3 and C4. during the acute episode, and they're often low, but not universally, and so they may not be low. So that's one thing to check for. But really, there's a check for a genetic panel across all the complement genes, which is done in the National Centre up in Newcastle. So we would send genetic tests and serological tests to Newcastle for them to do diagnostics across all the different complement genes, both regulators and complement enzymes.
Thank you. I think that our next question is actually two different questions. Well, not two different questions. I have two different messages for the same question. So in the setting of anemia, uremia, low platelets with features of sepsis, cultures shows Haemocytophagobacteria, gram-negative, and I'm sorry if I'm mispronouncing this, and cystiocytes. Would this count as a typical TTP or atypical HUS? Or TMA secondary to infection? I think that this was on a patient, and it says that unfortunately Adams 13 was not tested. The patient improved discharge from ICU and only had vasopressors and antibiotics. The patient did not start Plex.
Yeah, so I would say based on that information, that sounds like TMA secondary to infection. I wouldn't use the phrase atypical TTP. And other kind of common less useful terms are things like cancer-associated TTP, transplant-associated TTP, and those are kind of historic terms. And I would really say the modern term would be cancer-associated TMA, transplant-associated TMA, because when we check Adams 13 levels on these patients, they don't have a low severe deficiency in Adams 13, so that they aren't TTP, they are TMA secondary to infection, TMA secondary to cancer, TMA secondary to transplant. So that's the nomenclature I would use. I wouldn't say things like atypical TTP or transplant-associated TTP. Those are slightly outdated terms and not technically correct in the current era.
Lovely, thank you. Just a couple more questions. That's all we have time for. So the next one is, how long will a patient with TTP have rituximab? And what treatment options are there for them when they relapse? Can they be then restarted on the same treatment?
Yeah, it's a great question. So the majority of patients will receive 4 doses of rituximab, and we use the standard dose regime of 375 milligrams per meter squared. We start twice weekly, so usually kind of 3 to 4 days apart. Most patients will complete their plasma exchange now within a week. And so what that would usually mean is to say if a patient presents on a Monday, we'd hope to give them the rituximab on Tuesday, then maybe on Friday, then they'd probably have another dose the following Monday, and then probably the Monday after that. So they'll have 4 doses really over about a 2 to 3 week period. The thing that would determine whether the patient requires more rituximab is what's happening with their Adams 13 activity. If they've had a brisk normalization or an improvement of their Adams 13 activity above 20%, we wouldn't give them further rituximab, but we can give further doses, and we often give up to 6 doses in patients with immune TTP. A minority, probably 10 to 20% of patients, require further immunosuppression, either in the form of mycophenolate or plasma cell-directed therapy, such as bortezomib, but that's the minority of patients. In terms of relapse, so that treatment I mentioned will be to get the patient into an Adams 13 remission, or at least partial remission, so a good level of Adams 13. But when their Adams 13 falls in the future, provided that they're being monitored electively and there's no evidence of acute TTP, and by that I mean they've got normal platelet count, normal hemolytic markers, this is really an elective treatment. The majority of patients, 95% of patients, will be able to be treated with monotherapy with anti-CD20 such as rituximab. Interestingly, what we do see in these patients, and this is not a diagnostic test, but we monitor patients' CD20 percentage within their blood. And often what we see is there's a lag, and they normalize their CD20 after rituximab therapy. Now, after they've normalized their anti-CD20 levels, then their Adams 13 starts to fall some months afterwards. So that can be a useful parameter to guide their treatment. And it's very unusual for somebody to have another relapse before they not normalize their CD20. And as I say, rituximab or alternative anti-CD20 therapy is highly effective in preventing clinical relapse in these patients, as opposed to the elective therapy that I just mentioned, which is for an Adams 13 relapse. So meaning the patient doesn't need to come into intensive care, have VASCAT plasma exchanges, outpatient rituximab monotherapy, which is fantastic for these patients.
Lovely, thank you. And our last question is, are the centers only for patients older than 16?
Yeah, so it depends slightly on different centres. So at UCLH, we have a TYA unit, so we'd be happy to take teenage patients as well. Obviously, there are paediatric centres that usually take patients up to the age of 12. Obviously, the area between 12 and 16, 18, I think varies between trusts and hospitals. But ideally, they'll be managed in a TUI specialist unit, but there would be discussion and liaison between the various different haematologists. We work very closely with Great Ormond Street Hospital for children with congenital TTP, but I should mention immune TTP in childhood below puberty is very unusual. People used to say it didn't happen, but there have been a couple of cases over the last few years, so it's not impossible, but it's very rare. It's more common that immune TTP patients present in teenagers after puberty. Often they are kind of adult size and can be treated largely the same as adult patients. Children have particular challenges.
Thank you so much, Matt. I think that this is all the time we have for questions. There is one more, there's one more in the chat, if you please won't mind just replying to that directly. Thank you very much.
Thank you. Thank you.
Great, thank you, Matt, on our behalf and everyone else's here. So we're going to talk about tumor lysis next. I think this is quite an interesting subject for people who work in intensive care, because it is kind of puts us outside of our comfort zone a little bit. So we'll just start with a definition first. A life-threatening complication that comes about when the cells in a cancer break down quickly and release excessive quantities of cellular contents into the systemic circulation. So this is a condition where AKI and kidney injury can develop quite rapidly. So our aim today is to really talk about the prevention, because once AKI develops, it can be a very difficult problem to fix. And it is a particular problem for ICUs that take in hematology patients, because, as with a lot of hematology conditions, the patients can need quite specific care, and a lot of new knowledge is needed for the clinicians who look after those patients. And in tumor lysis, it's a good example of some of what we are asked to do is kind of the opposite of what we would want to do. So patients might need lots of IV fluids, whereas in ICU, we often try to de-escalate fluid administration. We like to top up electrolytes in ICU, but in this case, that would be potentially harmful to the patient. And sometimes there's a lot of misconceptions that can come about with things like tumor lysis syndrome. So you'll hear people refer to the patient having had tumor lysis prophylaxis, a drug like allopurinol or respiricase. But actually, these drugs only act on a certain part of the syndrome and won't cure it completely. So patients are still at risk if you're under the misapprehension that the patient is now covered. And it's also a condition that can crop up quite unexpectedly. That might even be a patient who's in ICU for a non-hematology condition, something like a patient who's got suspected HLH, which we'll hear more about later on today. Starting them on steroids might actually be enough to knock them into tumor lysis syndrome. So if we're not aware of the risk, we might not have done the prevention and might not be doing the monitoring. So I'm going to talk about this from a kind of nursing and hematology perspective a little bit more. But in the session after, we've got Dr. Nish, who's going to be talking about acute kidney injury and hematology patients in general. And so he can kind of maybe add to what we've talked about from an intensivist and nephrologist perspective. So let's just try to kind of break down the disease into and sort of start describing it. So we've got here, sorry to go back to basics, we've got our intracellular and extracellular sort of plasma electrolytes and ions, cations, and we'll relabel the intracellular now as the cancer cell, Maybe this is a leukemic cell in the peripheral bloodstream, and obviously between it and the plasma is a cell wall. So now we give the patient some chemotherapy and the cell wall breaks down, and all of these intracellular electrolytes are going to be flooding into the plasma. And this will be a problem only if we have a large amount of breakdown very quickly of the cancer cell. So what electrolytes and what changes are we going to actually see when someone's starting to develop tumor lysis? Well, the amount of potassium in the cell is very large compared to the bloodstream, so that's going to rise when the cells break down. The phosphate is similarly quite large, but this actually underestimates it. Cancer cells often have in excess of 4 times the normal amount of phosphate. So we have a massive amount of phosphate that's now going to be released into the bloodstream as well. So we're definitely going to see that potentially rise. The magnesium might change a little bit upwards, and there's not very much calcium in the cell, and there's quite a bit in the plasma, so that might actually drop. So in these at-risk patients, we've got these sort of main problems that we need to kind of address. We've got potassium increases, which will lead to potentially arrhythmias. We have phosphate increases, which will find any free calcium and formed calcium phosphate compounds, and which can then crystallize in the tubules of the kidneys, causing a nephropathy. And we also have the release of DNA from the cells that are broken down. And as that's being broken down further, you ultimately get the formation of uric acid. And uric acid is quite liable to crystallize in the kidneys as well when in high concentrations. So hyperkalemia with arrhythmia, and calcium phosphate and uric acid causing crystallization and AKI. The sort of one extra element we have is tumor lysis does have a sort of inflammatory and cytokine release aspect, and that's mainly interleukin-6 and tumor necrosis factor. So this can cause some other systemic inflammation. We get organ impairment, and that could include the kidneys as well. So this is what we're going to try to prevent with our management. In visual form, this is what uric acid crystals are looking like, and we can imagine these crystallizing in the kidney distal tubules and causing a nephropathy. So for a while, it's kind of tumor lysis has been defined in 2 distinct ways, an early stage, a late stage, a sort of less serious and more serious condition. So laboratory TLS is, as it sounds, it's evidenced in blood tests, and it's high uric acid or urate, high potassium, high phosphate, or low calcium, and 2 or more of those would indicate laboratory TLS. Clinical TLS, you still have those laboratory symptoms or laboratory numbers that are deranged, but then it's starting to cause end organ injury and damage and ultimately failure. So AKI, which might be evidenced by the patient being anuric, but probably more easily seen by a rising creatinine, the kidney starting to struggle, a cardiac arrhythmia, a seizure, or sudden death. Now, luckily, the seizures and arrhythmias are quite rare when we're managing tumor lysis syndrome, so it's really kind of the AKI we're on the lookout for. Now, every patient is unique in terms of their disease and their own ability to cope with the breakdown of this cancer. But we expect in these high-risk groups of patients that tumor lysis on a laboratory side, so the blood tests that show changes in electrolytes, could be anywhere from 15 to 45%. Whereas clinical TLS, the more severe form, is only 6%. But of course, in some patient groups who are very high risk, that might be as much as 30%. And this is the life-threatening version. And just to sort of pull aside the reference below, a lot of the subsequent references that have been used are all based off international guidance that's been written with kind of expert consensus, and there really is a small amount of high quality research that's happened in tumor lysis. So, unfortunately, these are big decisions that need to be made to keep patients safe, but a lot of it is based on pretty flimsy evidence, unfortunately. So, in terms of risk factors, we need to, we know that AKI will develop if the tumor lysis continues, and the situation will rapidly worsen. So we need to identify these patients and give them different management early on so that we can prevent that from happening. So, from a patient perspective, having a more advanced stage of cancer, so, stage 4, for example, lymphoma, would put them more at risk. Having a bulkier disease, again, that might be a large abdominal mass or lymphoma, maybe greater than 15 centimeters. If they're leukemic, it might be bone marrow involvement where there's blast cells filling the bone marrow, 90% blasts. Could be a mediastinal mass in a Hodgkin's patient that's pressing on, some of the vital organs within the chest cavity. And again, leukemia, high white cell count in the peripheral blood as high as 100, 200, 300 or more, puts a patient at very high risk of tumor lysis, as does tumor involvement in the spleen or liver. If there's evidence of a tumor that's so aggressive it's already starting to break down, as evidenced by potentially a high lactate dehydrogenase, and really just a high potential for rapid cell lysis, which we'll come on to in a minute to describe what that means. So that's the kind of the disease side. In terms of the patient side, so we're going to summarize that as a large amount of cancer that will break down quickly. From patient perspective, how can they handle the prophylactic treatment we want to give them so that they don't develop TLS? So if they have impaired organs because of old age, if they have renal impairment we know of, if they're dehydrated, and they have concurrent medications, maybe nephrotoxic drugs or uric acid increasing drugs, all of these things will make their kidneys struggle to excrete the electrolytes they need to get rid of. If they have any sort of, the cancer is having any sort of effect on the kidneys directly, it's infiltrating it, obstructing it, clearly that's going to play a part. If the patient, lacks a kidney or has had a kidney transplant, if their heart and lungs are not going to be able to tolerate the large amounts of hydration they're going to need, then that's also going to be a real risk factor. So it's the cancer, but it's also how can the patient handle the treatment we want to give them. The potential for cell lysis probably used to be a lot easier, and in the future will probably be quite a bit more complex and individualized. So many types of cancers might be found at quite a large size, if they're more advanced in their development. But also similarly, a lot of them might not respond particularly quickly to chemotherapy, but that's going to change a lot in the modern era as we have more and more immunotherapies directed against solid cancers. All of a sudden, we've got therapies that can break down otherwise quite slow-growing, slow-to-treat cancers quite quickly. So from a kind of, classically, you would say the fast-growing leukemias, ALL, AML, and the high-grade lymphomas like DLBCL and Burkitt's, that proliferate maybe with a sort of a doubling time of the cancer within the space of a few days. They're going to be very much high risk for tumor lysis. But now that we have more sensitive approaches, so a good example would be the use of venetoclax in a chronic leukemia. All of a sudden, these chronic leukemia patients are now at risk of tumor lysis syndrome where they weren't before. And how strong is the initial treatment we're going to give them? Are we giving them actually intensive treatment up front? So the literature is, full of case reports of patients who have received targeted therapies for cancers you wouldn't expect to have tumor lysis syndrome, but they have then gone on to develop it. We need to take a personalized approach in the future, thinking about the patient, the disease, and the treatment we're going to give them. So we try to do this. I mean, this is the UCLH approach, but there's many different ways to try to do this. And so what we try to do is actually think about the patient's disease, think about the patient's blood values, and think about whether they've got any renal dysfunction. And so if the patient, looking down in this first column A, we've got a number of different diseases the patient might have, leukemias, lymphomas, etc. But if column A shows us their baseline risk, so some patients are low risk, some will be intermediate, some will be high. But if the patient comes into, they're diagnosed with a high uric acid, potassium, or phosphate level, immediately their risk factors and how we're going to treat them goes up. And if they already have an AKI, then it's even more so. So we wouldn't normally expect the patient to start developing these high phosphate, potassium, uric acid problems up front. That would be something you'd expect to happen in the sort of first 12 to 72 hours after treatment starts. So why would this be happening at the beginning? Well, unfortunately, some hematology patients will get spontaneous TLS, where the cancer growth is extremely aggressive but starts to tail off as the patient's getting closer to diagnosis, because the patient themselves, their body can no longer support the number of cancer cells that are being grown. And so these new cancer cells are still trying to replicate, but they're finding there's insufficient oxygen and nutrients to actually survive. So as they're growing, they're also dying. And we're going to see that maybe evidenced by a high lactate dehydrogenase. So above 1,500 is considered quite a high risk in the hematology population. It might also just be a high lactate level measured on a blood gas. So these cells are dying before the chemo's been given. They might already then be causing tumor lysis syndrome. The patient might already have derangement in their electrolytes and an AKI. And certainly things are only going to get worse when we give them chemotherapy because they've got a very aggressive disease. So how do we prevent this TLS and treat it as a prophylaxis before any of these problems get sort of fully entrenched? Well, we've got three main things we need to address. We've got our hyperkalemia, we've got our calcium phosphate crystallization, and this nephropathy. We've got our urate problem as well. So if we hydrate the patient well, that's going to potentially solve all of these problems. Our kidneys will excrete the potassium phosphate and the uric acid without too much hassle. We just need to have a really good urine output. So that might be the patient drinking really well and maybe some supplemental fluids on top. Now we do have some medications that can help us in the process, but their use, is limited to one particular problem. So we have allopurinol, which is able to stop the formation of uric acid from xanthine. So if there's a normal uric acid level, we can stop it rising as we start chemotherapy by using allopurinol to prevent that rise. If we think the patient's very high risk, or if the patient already has a high uric acid level, we can use respiricase, which is an enzyme. It's something that we, most mammals have, is an enzyme to break down uric acid, but humans lost that ability quite a while ago. So this is a recombinant form. It breaks down uric acid into the harmless byproduct allotonin. So with uric acid, we can actually kind of fix that problem. We're not actually very worried about high urate. So that leaves us hyperkalemia and high phosphate. Well, high potassium, we can temporarily sort out. We can give salbutamol and insulin infusions, and we can increase the cellular uptake of potassium and drop it in the plasma. So we're not as concerned about hyperkalemia. We can keep that under control. So really, it kind of comes down to the high phosphate level. That's the one that's going to be the trickiest problem when it comes to managing patients with tumor lysis syndrome. We haven't got any miracle drug to fix that problem. There are drugs called phosphate binders, which can lower phosphate, but not in sort of a quick enough way that they could be clinically useful in TLS. So just sort of final thing about the respiricase. its administration rapidly speeds up the time in which we can give chemotherapy. So with allopurinol, you really need 24 hours of its activity before you could give chemo for it to be effective. With respiricase, you can give it and potentially give chemotherapy 4 hours later. That's how rapidly it works. It's an expensive drug, so that's the kind of the sort of downside of it. We're talking, potentially hundreds of pounds a day, maybe even as much as £1,000. But it does a really good job at preventing AKI. And so it can reduce the need for renal replacement therapy by between 5 and 10 times. So that dramatic reduction in the need for dialysis or renal replacement therapy will, save a hospital in the long term quite a bit of money. So it's definitely a useful drug to use. We need to kind of identify these patients. We've identified them into risk groups from the previous few slides ago. They're going to either be low risk, intermediate risk, or high risk. And what this means is the chance of the patient in low risk going into clinical TLS is less than 1%. Intermediate is between 1 and 5%. And high risk is greater than 5%. And as we said, it might be as high as 30%, depending on the patient and the disease. So how we manage the patients is quite different. We're talking an oral tablet of allopurinol, daily bloods, and oral intake of hydration. If they're intermediate, it's a bit tricky because they will need, still daily bloods, maybe some IV fluids, and there's certainly some risk there. We might start to see the bloods change, so we need to be able to escalate their treatment, rapidly. With the high risk, it's a bit more straightforward because we know the risk is there. It's very evident. So we'll start with a stat dose of respiricase to drop and prevent the rise of uric acid. And that needs to be at least 30 minutes before SACT. But as we said, 4 hours is better. We need to do some pre-hydration for 24 hours to get the kidneys working well. And then we're going to continue with 3 liters of IV fluid a day. And the TLS bloods monitoring, the sort of most important bit is actually looking for deterioration on the blood test, will be at least every 12 hours. One important thing to say about respiricase is not everyone can receive it. So there are some people who have G6PD deficiency, and they need to be tested for. If they have that deficiency, we shouldn't give them respiricase because it can cause a hemolytic anemia. So the monitoring is really the kind of the crucial bit of all this. We're putting in place what we think is an appropriate amount of medication like allopurinol, respiricase, an appropriate amount of hydration. And really what we need to then see is that the patient's passing good amounts of urine so that they can excrete the byproducts. Now, the only way to know that this is actually happening in real sort of at the bedside is then to do the blood tests. So looking for changes in potassium phosphate, creatinine, LDH, and urate. We want to make sure we give them enough fluid. That might mean escalating our hydration if the patient starts to become unwell, if they start having a rising phosphate, rising potassium, rising creatinine. That might mean making the hydration between 2 to 3 liters per meter squared per day. So in simple terms, that might be 4 to 6 liters of fluid per day, and that might be enough to stop them developing worsening of their symptoms. Of course, fluids come with their own risks, so we want to, use enough to prevent AKI, but we don't want to use too much to cause other problems, such as fluid overload. But it's a fine balance sometimes with the higher risk patients. In terms of what fluids to use, there's kind of 2 things to bear in mind. I mean, obviously, Hartmann's is the preferred choice for hydration for the majority of patients. The downside to Hartmann's solution compared to saline is it contains potassium. So, we're adding to one of the electrolytes we're trying to prevent from rising. So that's not ideal. And Hartmann's is a little bit more towards the neutral in the pH, whereas saline's a little bit more acidic. And the reason that matters is under acidic conditions, calcium phosphate crystals are less likely to form within the kidneys. so that there might be some benefit to a slight pH change. So some of the things to kind of think about, we want to make sure that the prehydration phase is not missed when we're starting treatment for patients. We would really like to avoid giving electrolytes to the patient. So that's, in particular calcium. So if the patient has a high phosphate level and we start administering extra calcium because the calciums deplete, it's just allowing that phosphate to form more calcium phosphate crystals and worsen the potential for AKI. So unless they're symptomatic, tetany, seizure, real world examples of low electrolytes, we would try to avoid administering calcium, potassium, etc. We need to think about how we're going to actually administer our cytotoxic drug regime. Are we going to give all 4 of the drugs on the first day, or are we going to give 2 today and then 2 the next day? Maybe we can lower the dose if a patient is very high risk. If they do something targeted, like a monoclonal antibody, maybe give that on day 3 or 5 or 7, so that again you're kind of spreading out when the cancer cells are being broken down and not making it all happen on one day. In a sort of pediatric setting, the acute lymphoblastic leukemia patients often have a week of debulking, so they're giving steroids to reduce the amount of leukemia they have prior to starting the actual cytotoxic drugs, which does a good job of reducing tumor lysis syndrome. For people who do have a leukemia, they might have a very high circulating white cell count. As we say, it might be above 100 or even 300, 400. And in those patients, you might want to do an apheresis, a leukapheresis procedure. So obviously this is blood put through a centrifuge and how it should normally look, but we can put blood through a centrifuge and remove the white cell compartment and try to reduce down. This is a large amount of leukemic cells that now are out of the patient and being discarded, and those cells are now not going to cause tumor lysis. We've spared the patient from that. We definitely need to be thinking about just general kidney health. So if we can avoid nephrotoxic drugs, uric acid increasing drugs, that's all the better, and it will make it easier for the patient to utilize their kidneys' strengths to get rid of the byproducts. And we need to think about early renal replacement therapies as well. So renal replacement definitely has a role within tumor lysis syndrome. This is an example of the sort of criteria that UCLH use for patients who might need renal replacement therapy. It doesn't really totally overlap with a patient who's high risk for tumor lysis syndrome. From a tumor lysis perspective, you really want to sort of act when the patient is at all refractory to fluids and getting overloaded, when they have ongoing hyperkalemia, high urate, high phosphate, or low calcium. If you can't control the high phosphate levels with the fluids and the diuretics, then really renal replacement therapy is going to be the only thing that's going to help the patient get through that treatment without an AKI and potentially worse. We'll have a little bit of time to sort of talk about this with Nish when he does the next talk, but we do have specific guidelines that we use for patients who need renal replacement therapy, because our preferred method is using citrate anticoagulation, which then requires calcium infusions. And there's some, potential worry about the use of calcium in patients with tumor lysis syndrome. So we'll see whether Nish wants to mention that when he comes on next. So there definitely seems like there might be some benefit to bringing these patients down to ICU early. We've got high risk patients who are being given, who are developing AKI. And if we bring them down to ICU when they now have the AKI, their mortality is 10 times higher than if we brought them down without renal injury. So if we bring them earlier, could that then mean their outcomes are better? So I know we've just got a couple minutes there, so I'm just going to kind of skip forward through a case quickly where we've You can just see a little bit of a progression of what we might see happen. So we've got a patient who's got mantle cell lymphoma, and we're hoping to get to CAR T cell therapy, but is going to need some bridging to get there. The disease is very aggressive. And in the sort of background, they have been started on steroids, and they've gone home on allopurinol, and then they've presented in A&E with fast AF and fluid overload and metabolic acidosis and query sepsis. So they've been kind of stabilized on the unit. And at this point, this sort of 5th of April, we've got some blood tests prior to the administration now of chemotherapy. And we can start to see the trends of what can happen during a tumor lysis episode. We've got a rising creatinine. Our potassium is still static, but the phosphate is starting to move up from 0.9 to 1.3. The LDH is 1200, which tells us we're at real risk of AKI. The urate's under control, but what's really noticeable is how high the lactate is, 21. This is all being driven by the lymphoma. So we've carried on with treatment for the next few days, and things have got a little worse. We've managed to maintain a good urine output with hyperhydration and some diuresis and respiricase. And over the next few days, the creatinine starts to plateau and start to drop. The phosphate begins to come down. The lactate itself drops from 21, and 2 days later is 4. So this patient's been brought through this episode safely without requiring renal replacement therapy and having received the chemotherapy they needed. After TLS, you do have to do a little bit of potentially mopping up. It's only a condition that's going to last for a few days, but you might be left with a patient with significant fluid overload, hyponatremia, low albumin, inappropriate antidiuretic hormone, and really just to kind of bring it back, prevention is far better than cure in these patients. So appropriately assessing them and managing them to prevent TLS is going to be far better than trying to jump in with, all the therapies when they've already developed an AKI, and that the monitoring they need is quite close and quite subtle. But with the right monitoring, we should be able to spot things early. And there might well be a place for early ICU admission to manage these patients immediately prior to chemotherapy administration so that they can quickly move on to renal replacement therapy if they need it. And I think I will have to stop there. So thank you very much.
Fine. So thanks for the invite to talk. So I'm just going to talk a little bit about acute kidney injury in the hem-oncology patients. So next slide. So the outline really of this talk might overlap a little bit with what Gavin has talked about before, tumor lysis, but we'll talk about other causes of AKI and a bit about renal replacement and anticoagulation and the issue of calcium. Next slide, please. So acute kidney injury is a particular problem in the hem-oncology patients, and it's perhaps a reflection of how sick this cohort is. So next, and as you can see, the hem-oncology patients cohort has a very high incidence of AKI compared to other patients with different types of cancer, and this is due to multiple reasons. Next slide, please. And as you can see right at the bottom there, the hem-oncology patient cohort has a higher risk of stage 3 AKI compared to other cohorts, apart perhaps from very specific types of cancer to do with the kidney and the urinary tract. And this is due to lots of reasons. Next slide, please. And common things being common, these patients have an increased risk of sepsis and hypovolemia, but there are more specific problems in this cohort, such as tumor lysis and the use of chemotherapeutic drugs, which might be nephrotoxic, but also obstruction or direct invasion of the cancer within the urinary tract. Next slide. And so the issue of tumor lysis has been discussed at length, and I pretty much agree with everything that Gavin has said. It's the combination of metabolic problems, including high uric acid, high phosphate, which is released from dying cells or cell lysis, along with potassium, and phosphate binds to calcium. Therefore, you get a low ionized calcium level as well, and you get uric acid deposition within the renal tubule. So next slide, please. And as you can see there, this is in panel A. It's basically the uric acid crystals act as a nidus for the formation of calcium oxalate stones. And this doesn't just happen in the kidney, but it happens elsewhere as well. The reason why the kidney is particularly vulnerable to this sort of stones, and also things like cast nephropathy, is that within the renal tubule, there's high rates of solute reabsorption. So the concentration of solutes such as electrolytes and uric acid become incredibly high within the renal tubules, allowing it to precipitate because of free water reabsorption within the renal tubules. And you can see perhaps a bit of nephrocalcinosis in panel C, which is sometimes visible on the renal ultrasound in panel D, where you get loss of the corticomedullary differentiation. And in panel E, you can see that there's also soft tissue deposition of the calcium oxalate and uric acid, which starts off with uric acid. Next slide, please. And again, Gavin has spoken about the use of allopurinol and rasburicase in the management of tumor lysis, which I won't sort of dwell on. Next slide. And the issue of lactic acid in sort of hem-oncology patients is slightly different. So typically on the intensive care unit, we associate a high lactic acid with tissue hypoperfusion, often seen in sepsis, perhaps due to mitochondrial dysfunction in sepsis. But the tumor cells have a propensity to generate lactate because they undergo a lot of anaerobic or what we call aerobic glycolysis. In other words, they replicate very rapidly. They need a lot of energy. A rapid way of producing energy is glycolysis, and that creates lactic acid from glucose. There's deficient oxidative phosphorylation, so therefore the lactic acid is not metabolized in the mitochondria, and you get a high level of lactic acid in rapidly dividing tumor cells. It's the way they behave to generate energy. And that is not the sort of lactic acid that is responsive to any food resuscitation, etc. And quite often, as Gavin mentioned, the lactic acid in these patients is persistently elevated. Next slide, please. And again, and once again, so renal replacement therapy, when to start. So the typical criteria include those shown over there. We talk about high urea, potassium, etc., acidosis. But I think clinically, one of the things that is really important is not just the numbers at a particular point in time, but the trajectory of illness. And I think for most intensive care patients, including the hem-onc patient cohort, these criteria are still valid. There's no doubt. But what we do know about these hem-oncology patients is sometimes the rate of deterioration can be very rapid. And so if the potassium perhaps is rising rapidly in the context of oliguria, there's no need to wait for all these criteria before starting. The disease isn't going to get better quickly, and sometimes starting a little bit earlier is completely appropriate. That said, for by and large, in terms of renal replacement therapy for the general cohort outside of the very unwell hem-oncology patient, starting earlier than the traditional criteria is not associated with any increase in survival or better outcomes. Next slide. And so the question is really about which modality to use. There is hemodialysis and there is hemofiltration. And these two are slightly different in the way they clear small molecules or middle molecules, where dialysis really depends on diffusive clearance across a semi-permeable membrane and a countercurrent gradient, whereas hemofiltration acts via a convective measure where solutes are forced out across a pressure gradient through a filter membrane. Next slide. And again, please. And the consequences of these are really in terms of what these different modalities can remove. So if you wanted to remove something very small like potassium very rapidly, small molecule diffusive clearance, in other words, hemodialysis, is far more effective than hemofiltration, because small molecules go across the countercurrent gradient more effectively in a semi-permeable membrane. However, things like phosphate, which are raised in hemolysis, are more along the middle molecule spectrum and are less effectively sort of eliminated via dialysis and more effectively eliminated via hemofiltration. And same goes with uric acid, which is slightly bigger than phosphate. And things like the beta-2 microglobulins, which are raised in things like myeloma, are not effectively removed by either modality or very, very little. So I think most intensive care units tend to use hemofiltration. That's the traditional mode of doing things. And some use hemodiafiltration. If you did have the option of sort of increasing the rates of dialysis in diafiltration, and you had a patient with high potassium, that would be ideal, rather than just increasing the rate of filtration. Next slide, please. So regional citrate anticoagulation, and press next again, please. So we use citrate as an anticoagulant. There's two reasons for this. The first reason is that in the general IT population, citrate is associated with a longer filter half-life compared to things like heparin. That's one reason. So better anticoagulation in terms of filter lifetime. The other reason is that it's regional. In other words, the anticoagulation with citrate happens only within the filtration circuit. And with the use of heparin, it's systemic. So a lot of our hem-oncology patients tend to have very low platelets. As part of their bone marrow failure, they also tend to be very coagulopathic. And so for these reasons, citrate in terms of regional anticoagulation is far more preferable. So there's a lower risk of sort of bleeding complications compared to using heparin. And what citrate does, it binds to calcium and therefore prevents the clotting of blood, because calcium is needed for blood clotting. And so what we do is we put put citrate into the filtration circuit before it hits the filter. It binds to calcium. And when so the ionized calcium within the filtration circuit is incredibly low, typically about 0.25 millimolar to 0.4 millimolar. And when the blood is returned to the patient, we replace calcium within the circuit to make up for the calcium that is bound. There are some citrate that is removed by the filtration process, but there is also some citrate that enters the patient's circulation. And the fate of this citrate is that it initially sort of breaks down from trisodium citrate into citric acid and bicarbonate as a byproduct. And the citric acid is then metabolized in the Krebs cycle. And that's a picture of Krebs himself, who described the process. And most of that happens in organs with high mitochondrial content, mainly the liver. So people with liver dysfunction may have problems with citrate metabolism, and you tend to get a buildup of citric acid. Next slide, please. And so there's the issue of citric acid accumulation versus toxicity. So as I mentioned, in the normal metabolism of citrate, you produce bicarbonate as a byproduct. So you might get a slight alkalosis if there's a bit too much citrate. However, if there is citrate accumulation because it's not being metabolized, what happens is the citric acid in itself accumulates and you tend to get an acidosis. And with that, your total to ionized calcium ratio will increase because you have a lot of citrate in your circulation. The ionized calcium is very low, and therefore your total to ionized calcium ratio will increase above 2.5. So if you, in summary, if you're worried about citrate accumulation, you'll notice an acidosis, you'll notice an elevated total to ionized calcium ratio. And in this case, you might be better off trying to avoid citrate or using an alternative. Whereas if there's citrate overload, what you tend to find is your total to ionized calcium ratio is within the normal range. You have a bit of an alkalosis and you just have to reduce the amount of citrate that you're giving. Next slide, please, and click again, please. So there's the issue of calcium assessment with citrate. So if you're giving a patient, if you're assessing a patient's calcium level, we're more focused on the ionized calcium, because that's what's biologically active. And we have what's called adjusted calcium. So most of your, or half your calcium, approximately half your calcium in your circulation is bound to albumin. And so in patients with low albumin, we tend to correct for this lack of albumin in terms of the corrected calcium, as you can see by that formula. And click again, please. Now, this formula doesn't work when someone has citrate in their circulation. So in patients on citrate anticoagulation, as I mentioned, they do have citrate within their circulation. And this is not accounted for by the formula for adjusted calcium measurements. So quite often what you find is in patients on hemofiltration with citrate, when you look at the adjusted calcium results given by the lab, they tend to be quite high and alarmingly high, usually about, up to 3 millimoles per liter, but it's not necessarily an accurate assessment of their ionized calcium. So, what we don't do, say, for example, in tumor lysis, even though the calcium is low, we don't tend to replace it because it increases the rate of crystal formation. But what we shouldn't do is we shouldn't look at the adjusted calcium in someone in filtration and say we're giving too much calcium, because it's not an accurate measure. What we should be doing is looking at the corrected calcium. Next slide, please. And in relation to sort of hemofiltration or removal of solutes in tumor lysis or other forms of AKI, people have talked about using high flux hemodialysis to try and remove, well, in this case, the light chain load in myeloma, because as I mentioned, light chains are filtered by the kidney. That's a normal process, but they do precipitate when the concentrations are very high. You get carcinopathy in myeloma. There have been various studies, and this is just one example of a study looking at the potential of high cutoff hemofiltration or hemodialysis for removing casts using filtration. And the long and short of it is there's no strong evidence at all that using high flux filtration reduces the risk of AKI in this cohort. Next slide, please. So in summary, AKI is a particular problem in the hem-oncology cohort with worse outcomes compared to other solid organ cancer patients. Tumor lysis is a very specific or perhaps more specific problem in this patient cohort. And the use of renal replacement therapy is not uncommon. And there are just a few pitfalls with regards to the assessment or interpretation, perhaps, of lactate levels, but also the use of citrate and the assessment of calcium levels on hemofiltration. And at present, the best we've got so far is our standard hemodiafiltration or hemofiltration that we use in ITU. There is no other different type of renal replacement modality that has added benefit over what we currently do. Thank you very much.
Thank you very much, Nish.
Thank you,
There is a question for you in the chat box. So the question is, could you please clarify the calcium/corrected in the context of citrate?
So basically, if someone is on citrate for hemofiltration, the most accurate measure is using the ionized calcium on a blood gas. So that's the biologically active calcium. The adjusted calcium is meant for a patient who has a low albumin, not on hemofiltration. So normally you and I will have two components of calcium. We have ionized free calcium and we have albumin-bound calcium. That's what we've got. In our patients, the albumin level can vary, and therefore we have an adjusted calcium level based on the patient's albumin level. Now, in patients with citrate, on hemofiltration with citrate, they have three components to calcium, not two. They have ionized calcium, they have albumin-bound calcium, and they have citrate-bound calcium, because a bit of citrate does go into the circulation and is, as I mentioned, metabolized by mitochondria, etc. Now, the formula for using adjusted calcium does not factor this third component or compartment of calcium in. So therefore, the use of this formula, adjusted calcium formula, for someone on citrate is no longer accurate. So if you have someone on citrate anticoagulation for hemofiltration, the use of adjusted calcium is no longer accurate, and therefore the most accurate and useful measure of how much calcium there is in the system is the use of ionized calcium.
I was diagnosed with Hodgkin's lymphoma in 2020, and I finished treatment and was in remission, cancer-free the same year. I found it quite easy, and especially when there was a lockdown, I wasn't missing out on anything because everyone was at home as well, and everyone had bad haircuts, so mine didn't look so bad when it was all falling out, and I was like, oh, this is nice. I'll just sit on the sofa for the whole time. So I found that really easy, but the whole COVID approach to it, with being transferred from UCLH to my local hospital to keep me safe, and like the change in care as well, that part was a little bit scary, especially when I was the youngest person in the room, that everyone sort of looked at you like, why are you here? And I'm like, because I've got what you've got. Was all outpatient. I was never admitted.
What age were you at that point?
23. I was actually studying to be a nurse when I was diagnosed with Hodgkin's. So I was taking a year off to transfer to a university closer to home. And when I applied to go back to university, I got told, well, you've got cancer instead. So when I finished treatment, it was still COVID and lockdowns happening, so I just stayed home and started my own business instead. Do silly little drawings and illustrations that people would buy. So when I was in remission, I started doing a lot of workouts to try and get my strength back and get back to a healthy weight, but I was noticing that I wasn't getting any stronger, I was just getting weaker. After I'd work out, I'd need to sleep, and I was just tired all the time. So I called my haematologist and said, like, I'm really, really tired all the time. Like, I get that it's a long recovery and it wipes it out of you, but I'm not feeling any better. And he was like, well, let's get you in for a blood test. And then the blood test was like, I feel like I'm going to do a bone marrow instead. I was like, oh, okay. And I sort of thought from there, something must be going on that's a lot more serious. And I did what everyone shouldn't do and Googled, why should you have a bone marrow biopsy? And it came up with leukemia. And I was like, yeah, I think I've got leukemia. And then I was diagnosed a week later. From beginning treatment for leukemia, I was in hospital for 6 months, but I would have like a week off between each cycle to come home and hang out with the dogs and just relax a bit. So that was nice, but it was long stays. It'd be like a month stay every time. So I'd finished all of my chemo for my first cycle and I was feeling fine, and I was like, this is going to be so easy. And then it's hit me all in one day, and I just gradually got worse and ended up going on oxygen, but then the oxygen wasn't enough. And I remember my PICC line failing, so I had to have another one put in. And when the PICC team came to put it in, I asked for, and I think it was lorazepam because I was really anxious. And from taking that to waking up in critical care, I have no memory whatsoever. In my notes, it says neutropenic sepsis and pneumonia. So both of them at the same time sent me down there. But everyone was telling my partner and my dad, she just needs a little bit of oxygen. We can't give her what she needs on the ward. It's just a precaution. And then when I got out of it a few months later, they was like, no, we sent you down there because you nearly died. And I was like, what's that? I had no idea. And I was like, oh, okay. I had a meeting with someone called Wendy from critical care who actually read out my notes for me so that I could, because I have memories, but I'm not sure if they're real or not. And my partner and dad don't like to talk about what happened. So I can't really ask them, and I'm not going to force them because it's not nice.
Yes.
I think the 21st of April I was taken down, and then on the 27th I went back to the ward. I only remember bits and pieces still. I remember my last 2 days before I went back to the ward. But other than that, I just have bits and bobs, and even then I'm not sure what's real or what's not. I remember I've told so many nurses as well, was I ever holding your hand and like doing like a blood curdling scream? And they went, no. And I was like, I can really remember like screaming my lungs out. They was all like, you were sedated most of it. You had a CPAP machine on. How would you even scream? And I was like, yeah, but that's just something that's in my head. And they was like, well, it probably didn't happen, but if you need to talk, we're here. So I was told by Dr. Beth Payne, you need to have all of your lines out, so like catheter, of that, you have all of that taken out. You need to be able to walk independently and be completely off of oxygen. And my goal when I was first admitted to the hospital for my chemo was to be home in time for my birthday, which was the 6th of May. And it was 2 days before my birthday that I managed to get home, because I was like, right, I've just got to walk independently, I'm off then. And yeah, I just forced it and went home pretty much 2 days after I got back to the ward from critical care. They went pretty smoothly, yeah. I had infections every single cycle. And during my second cycle, I had platelets, and I'm allergic to platelets. But my steroid that I have before it didn't work. So it started closing up my throat and getting me really puffy and hives. And I started to freak out and panic because everyone was rushing in to put an oxygen mask on me again. And I was like, oh, this is just like critical care. And it really panicked me. And it wasn't what would have helped when you need to calm down. And it's just sort of feeling a little too close to home. Yeah. September 2022. So I'm a year and 6 months into remission now, and I still get bone marrow biopsies every three months, just to check that all the levels are okay. And I still have to walk sometimes with a walking stick because I'm still a bit weak, because I kind of forgot how to walk when I was in critical care. So every now and then, if I'm a bit weak, I have to use a stick. But I've got a really cool, pretty one, so I don't feel embarrassed.
Nice.
And I still have dreams about being in there. And I have really bad fatigue from it, but I think it's just a mixture of 2 cancers and being really sick in there that makes the fatigue quite bad. The one thing that was really, really, like, still to this day I'm so thankful and grateful for is they included me in everything that was happening. Even if I wasn't completely with it or understanding what was going on, they would tell me what was happening. They would talk me through it. They'd explain everything they were doing to me, and they would just really include me in my care. And a lot of times I would start to get upset. And I remember one night a nurse came in to me crying and was like, "What's wrong?" And I was like, "I'm just scared." And I had the CPAP machine on, and I couldn't really talk much with that on. And I remember putting in my notes on my phone, "Am I going to die?" And she went, "Don't be silly." And she stroked my head and she sung to me. So, and like wiped my tears away, sung to me, stroked my head till I fell asleep. And like even now, it's like, it just means so much to me that they went above and beyond, and they just put what they were doing aside to just take that moment for me, and it really did mean so much.
Basically, it all started beginning of 2019, where I've always been borderline anemic, where I've been on iron tablets. And I spoke to the doctor and said that you keep prescribing me iron tablets, I still feel the same. So she put me in touch with a consultant. So I went to see the consultant, and she basically wanted to do a bone marrow biopsy, which they did. I think it was in the summer of 2019. And October is when she called me in to say I had myelodysplastic syndrome. Never heard of it, didn't even know what it was. They find it more in people at 70 and above.
Yeah.
So probably why my doctor didn't pick it up. So, and also they needed a bone marrow biopsy to see it. So her explaining myelodysplastic syndrome was it's a form of blood cancer. So we'd have to go through the route of doing a stem cell transplant because I was at the age that I could take one. So my chemo started because that was COVID time as well. So chemo started in June 2020. And my transplant was booked for November 2020. That was all fine. In between, I had sepsis, I had pneumonia while going through chemo. But I was isolating at my parents' house, so I was away from my husband and my two children. And the actual transplant itself was 6 weeks process. You had to go 2 weeks beforehand, so they do the whole full-on body radiation, chemo. So your last set of, I think I've got a timetable from day 14 to day 0, and day 0 is the day your transplant day. Not November 20th was my transplant day, and my day to go home was Christmas Eve. And yeah, so I was packing, and my mum was having a conversation with me, and she was like, well, she tells me now that I was speaking very slowly and I wasn't really, paying attention to what she was saying. My speech was very slow and delayed. So they called the haematologist and said something's not right. Can you go and check on her? Apparently, when they came to check on me, I was having seizures, and I don't know whether they put me in a coma or I went into a coma. I'm not quite sure about that, but I was in there until mid-January, and they found out it was encephalitis. So basically, it was a virus that attacked my brain. I've actually been left with epilepsy now, so I've got that to manage, which is just for any medication. Luckily, I've only had 3 seizures since then. Yeah, and I came out of hospital, and no, it was a week before my birthday. So yeah, beginning of February, I came back out of hospital and recovering since then. So I'm 3 years this 2024. So I'm 4 years this year. 5 years I will be coming off the medication. The acyclovir and azithromycin, I think that's what they're going to be able to take me off. But the epilepsy medication, I've been told I will stay for life. Weirdly, I remember being in the ambulance on the way back to UCLH thinking, why am I in an ambulance what's going on. I was confused to what was going on. And my sister-in-law was telling me that you don't even, when we spoke to you, you didn't even remember that you were diagnosed with this and what was going on. That slowly all came back. But I don't remember any of the, I only remember being back in the ambulance on the way back to UCLH because they had to move me from UCLH intensive care to Queen Square because of the COVID. Okay. The wards were overpacked with COVID patients and I didn't have an immune system, so they needed to move me. And that was obviously a brain hospital, so I think that worked. I think it's just an absence. I think my mum and dad used to be, because I've got 4 siblings, and they all used to be on FaceTime, and the poor nurse had to hold the screen up so they could talk at me, try and get some sort of movement, some sort of recognition. I think my mum said once she's kept calling my name, and my eyes fluttered, and she was so overwhelmed that I did that they've got some sort of reaction out of me, and it was her voice that did it. But I don't remember that. Yeah, no one could visit me while I was doing my transplant. My husband came because it was all isolation. So he came when my transplant was actually having. I actually have a video call of it, a video film of it. And then before I was leaving the hospital, my sister came to stay with me for 4 days, and my husband stayed with me for 5 days. And then I went home with him because I was like, I need to go home. I can't be here any longer. So they were happy with me to go home by then. Yeah, I mean, I had young kids. My daughter was going through her A-levels, and that didn't go too well because she was just in her room isolating all the time, not talking to anyone. And my son, who was very clingy to his dad, so he still is actually, and he's 14. Yeah, so I've written a few articles for Anthony Nolan actually, just to highlight the basically highlight the thing around the awareness around stem cells and donating, because I know there's not a great uptake in the Asian community, especially because there's not that much awareness around it. So I'm working a lot with them, and I think the nurses that looked after me were amazing. I mean, I can't fault them. They work so hard and they're so amazing, always cheery. You might have a bad day, but they'll bring a smile to your face. So the only person that didn't have a smile was for my physio, who used to, bless him, make me do all the exercises straight, and I had all these pipes and tubes coming out of me. He goes, no, you have to get up and walk up and down. He had me walking up and down the corridor. I was like, oh my God, I'm going to kill you. He goes, yeah, only if you get the strength. He was hilarious.
Great. Thanks, Gavin, for inviting me to give a talk. So I'm going to be talking about HLH, or macrophage activation syndrome, as it's also known. So my name's Gohel. I'm one of the consultants at UCLH. I'm a haematologist. And although this day is for critically ill haematology patients with HLH can present to any speciality, including general medicine, but they often end up on ICU or high dependency units. So happy to take any questions at the end. So what is HLH? So HLH stands for Haemophagocytic Lymphohistiocytosis, which is quite a mouthful, but all it actually is trying to convey is there is an overactivation of the immune system with hyperinflammation, and that the immune cells, which are responsible usually for clearing the body of debris and bacteria and pathogens, are actually so hyperactivated that they start to consume patients' own red cells, megakaryocytes, and other immune cells. It always has a trigger, so HLH is not a diagnosis by itself. There's always something driving the HLH, whether that's an underlying lymphoma or a rheumatological condition or an infection. There's always a trigger, and one of the things we often spend a long time doing is trying to find out what that trigger is. There is an increasing awareness that it needs early treatment with immunosuppression. So all of the end organ damage and what drives patients into the intensive care and the high dependency unit is organ dysfunction, which is mediated partly by cytokines, because the immune system is so activated, but partly because of end organ damage because of the HLH. It has an extremely high mortality, and the mortality hasn't really shifted. Now the mortality is twofold. Well, actually, it's multifold. Partly it's due to the HLH itself, partly it's due to infective complications, which we'll discuss later, and partly it's due to the underlying trigger. It has previously been considered rare, but I think there is a greater awareness of HLH throughout the UK, and I think that's been driven by a number of things. One is that there's a lot more education going into it, such as the study days. Secondly, the COVID-related hyperinflammation really put hyperinflammation into the forefront of people's minds, and so people are much more aware of it and looking out for it. And with more and more haematology units delivering CAR T-cell therapy and bispecific antibodies, and as a result, are seeing more cytokine release syndrome and ICANS, there's a greater appreciation of overactivation of the immune system. The median age is 35, but it can present at any age and to any speciality. So, as I've said, it's a hyperinflammatory state or a cytokine storm, and its defining characteristics are a fever. Now, the fever is often unremitting and doesn't really shift with paracetamol or antibiotics, and often there's no clear bacterial or viral trigger for the fever. It's associated with falling counts, so low platelets, neutrophils, or red cells. It can be any of them or all of them, and high ferritin. So we often say that if you have the 3 Fs, so a fever, falling count, and high ferritin, that you need to be very aware of HLH. It gets its name from what happens within the bone marrow, as well as other organs, including the liver and the spleen. And what you see is that the macrophages, which usually are sort of just eat up the dirt and the debris within the bone marrow, start to eat up red cells, and I'll show you a picture of that. The HLH can be primary, and that is often caused by a genetic driver. And that is common in children, and young infants. And there's a genetic abnormality which leads to overactivation of the immune system. And the definitive treatment for those patients is an allogeneic bone marrow transplant. The other triggers, the commonest trigger for secondary HLH that occurs without a genetic defect is malignancy, of which lymphomas are the most common cause. But we are seeing more and more patients with leukemia having a hyperinflammatory phenotype. Can also be caused by infections, especially viruses such as EBV, autoimmune conditions such as Still's disease, and there are certain drugs, including antiepileptics, which give a HLH type picture. So in your normal immune system, there's often a trigger. The macrophages are activated to eat up the pathogens. They destroy the antigen, they destroy the pathogens, and there's a feedback loop when all of the bugs have gone away and the immune system calms down, which sort of dampens everything down. So there's a nice negative feedback loop. So macrophages get activated, the immune system clears up the problem, and then it sort of self-resolves. In hyperinflammation, such as HLH, what happens is that you lack the negative feedback loop. So rather than the macrophages sort of dampening things down, they sort of lead to a spiral of more and more cytokines, more and more inflammation, more and more activity within the bone marrow, leading to pathological overactivation of the immune system and HLH. So how to recognize inflammation? So I've mentioned the 3 Fs, so an unremitting fever, and often patients present with renal impairment and on dialysis. Often the fever is hidden by the dialysis. Doesn't tend to respond to paracetamol, but it's something to bear in mind. Falling counts, platelets often tend to be the first sign, and a rising ferritin. It is associated with a number of other laboratory and clinical parameters, which we'll go through in subsequent slides. So I'll go through this quickly because I want to focus on them in something else. So how do you diagnose HLH? So I've mentioned, the 3 Fs are a good sort of trigger to trying to recognize it. So there's two main ways of diagnosing HLH. The slightly older way is with these HLH criteria. So in 2004, there was these criteria to try and better define what HLH is, but this was mostly used in the pediatric setting. So we mentioned the fever. Patients often have splenomegaly or hepatomegaly, low blood counts. One of the issues with HLH is patients often have a high fasting triglycerides, as well as a low fibrinogen. The ferritin is high. Now, this is a relatively low level of ferritin. Often in patients with HLH, we can see ferritins up between 50 to 100,000. Not all laboratories do a ferritin that high, and some laboratories only give an upper threshold, and so will say the value is greater than 3,000. It's often useful for the laboratories to dilute it down and give you a precise value, if they will. So the other diagnostic criteria are tissue hemophagocytosis, often seen in the bone marrow, or can be seen in the liver. And then these two tests, which is decreased NK cell function, which is very hard to do, and a high soluble CD25 or soluble IL-2 receptor. And 7 and 8 are really hard to get done routinely and often have a long lag time, which means that they can't really be used. One of the things is, although this criteria has a ferritin of more than 500, if your ferritin is more than 10,000, there's a 96% specificity for HLH. And certain hospitals will have an automatic trigger if the ferritin is more than 5,000 to alert the rheumatologist or the hematologist that there is this patient in the hospital who may have a HLH. Not all hospitals have that, and there are pros and cons of having that sort of alert system. So that's what we tended to use. We now use something called the H score, and this is a weighted score looking at all of these parameters. So is there underlying immunosuppression, the maximum temperature, whether there's hepatosplenomegaly, the number of lines of cytopenias, the red cells, platelets, or neutrophils, how high the ferritin is, triglycerides, the fibrinogen, the liver function, and whether there's hemophagocytosis on the bone marrow aspirate. Now, you can the cutoff for having a diagnosis of HLH is 169, and you don't need the bone marrow to say someone has HLH or not. Although hemophagocytosis is in the name HLH, there can often be very marked hemophagocytosis, or contrary, very little hemophagocytosis, but the patient still has HLH. It's useful if it's there. It's useful to know what's going on in the bone marrow, but it plays a relatively small part of the total score. No one is expected to remember this. There's lots of online calculators where you just put in H score and you just put in these parameters. And so often it's useful to just monitor what their H score is doing over the subsequent days to know, just to see whether there's a trigger of, is this patient, more likely to have HLH or not. So how do you, if you found a patient, you've screened them, they've got the 3 Fs, you've looked at their H score, it's very high, you're worried that they've got HLH going on. How are these patients treated? Well, the mainstay of treatment is steroids. So corticosteroids, we often give very high doses. So a gram of methylprednisolone or 500 milligrams of methylprednisolone if they're elderly for 3 consecutive days. The good thing about steroids is they're very good at shutting down the immune system. The bad thing about steroids is they can often mask the underlying trigger, or if there's an infection, it can make it worse. The other agent we have is anakinra, which is an antibody treatment against which blocks interleukin-1, and we can use that as a steroid-sparing agent. So in patients where you think there's an underlying hematological driver, we often give anakinra first and avoid the steroids so that we can try and get the biopsies sent off. And as soon as the biopsies are sent off, we start the steroids. IVIG is also a useful adjunct. And it's, there is mixed data about whether it is of benefit, but in patients who are critically unwell, provided they can tolerate the fluid load, IVIG is a useful adjunct. And these are good holding measures, which you can use by themselves or in combination, which allows you to find what the underlying cause is, be it rheumatological, infection, malignancy, The other thing is that both steroids and anakinra at the doses we use are extremely immunosuppressive. So a lot of the toxicity that patients have with HLH is actually due to opportunistic infections. So anyone starting HLH treatment should be on antivirals, anti-PCP medication, and antifungals from the start. We've lost a number of people who we've managed to control their HLH who then had rampant fungal infections and died. If this doesn't work, then you can move on to etoposide. Etoposide is a very good chemotherapy drug for shutting down activated immune systems. If there's CNS involvement, you can think of intrathecal methotrexate, and you can also add in cyclosporin or JAK inhibitors. But we'll talk about that in a bit more detail in subsequent slides. So what are the top infectious causes of HLH? So the herpes virus, so EBV and CMV, either in the context of primary EBV or in EBV reactivation, are common causes of HLH. It's rare, but can occur. And so we screen all patients presenting with HLH for not only serology, so whether they're IgG and IgM positive, but also if they've got detectable virus circulating. One of the issues is that when you have HLH, because the immune system is so dysregulated and it can't control latent viruses, so we sometimes see EBV levels, DNA levels rising in patients with HLH, and it can be quite difficult to tease apart whether the rising EBV is the actual trigger that's started off the HLH, or whether the EBV is rising because the immune system is so dysregulated and it's allowing escape. And sometimes we treat the EBV, sometimes we monitor it. It's a sort of fine. It's a decision that is sometimes not always easy to make. Dengue and COVID. The other things are visceral leishmaniasis, and it's surprisingly common in Southern Europe. So taking a good travel history from patients, it may have just been a weekend away, but if they've been to the south of Europe, then especially if they're immunocompromised, think about leishmaniasis. Histoplasmosis, especially in patients who are HIV positive. You've got to be aware of false positive beta-D-glucan tests, which is what we used as a screening test for fungal infections, because it can be positive if the patients have had IVIG, and we always try and make sure we send off all the virology testing before patients get IVIG because it interferes with subsequent testing. And there's a few rarer things such as murine typhus, which the infectious disease team know a lot about. And we occasionally have patients with TB who present with HLH. Now, patients with TB, when they start anti-TB medications, can also have a immune reconstitution type syndrome, which is similar to HLH, but it can also tip into HLH type picture. So this is the comprehensive diagnostic data set, and it is published in Lancet Rheumatology now, and it's also available on the UCLH HLH website. So just type in UCLH HLH into the website. It'll come up with a website where you can get lots of HLH information. So we have an initial panel of tests, which is all the standard things that you would expect. 3 sets of blood cultures and microbiology, all the virology that we've discussed to make sure that we're not missing anything. We send off a soluble CD25 because it's useful to have. Not all centers will be able to access that. And then once you've had your first panel of tests, if there's still things which aren't quite clear, we have a much more extended panel of tests to try and really determine what's going on. It can often take weeks, if not months, to try and find out what the trigger of an underlying HLH is. And often what we've got to do is you've got to treat the HLH with steroids, anakinra, plus minus etoposide, get patients better, even without an underlying diagnosis. And then when you start to wean off the immunosuppression, you can then see if whatever's caused it flares up again, and then try and catch it a second time. So just to reiterate, infectious complications are a very significant cause of death. And if you get an infection, you have a much worse survival probability, which is not the most unexpected thing, but it's very marked. And we see quite a lot of fungal infections, especially in patients who subsequently died. One of the reasons I'm talking is that hematological malignancies, especially lymphomas, are the commonest cause of secondary HLH, so those that occur in adults without a genetic cause. It's mostly lymphomas. Hodgkin's and T-cell lymphomas are more common, but it can occur with any subtypes. The hematological driver is not always obvious. So in some people, they'll present with HLH and they'll have lots of lymph nodes and a big liver and spleen, and you're like, oh, this is going to be lymphoma. You do a biopsy, you manage their HLH until you've got the diagnosis, and then you can treat the underlying lymphoma. In some people, they may have very, very little disease, if any. It may just be a slightly enlarged liver and spleen, and you're not sure whether that's a lymphoma there or whether that's just because of the HLH. There is a rare type of lymphoma called intravascular B-cell lymphoma, which often presents with HLH, but is only really identified by deep skin biopsies and can present with neurology. And so it sometimes takes a bit of hunting. The key is not to let the hunt get in the way of the underlying treatment for the HLH. It's to treat the HLH and then get to finding out what the cause is. Bone marrow is not needed for the diagnosis of HLH to look for haemophagocytosis, but it's often helpful to find out what's going on in the bone marrow, make sure there's not a hidden lymphoma or leukemia, and tissue sampling is key. So we have a much lower threshold for undertaking splenic biopsies and using PET scans to help guide us. It's hard sometimes when patients have a lot of steroids to know when to whether the appearances on the PET scan mean that things should be biopsied. Steroids often make things disappear on the PET scan, but we have a low threshold in patients with HLH because we know the outcome is so poor of doing liver splenic biopsies. And in this study of patients with PUO, not necessarily HLH, splenic biopsies were very useful in identifying what the underlying cause are, which in 75% of patients. Often we do an initial PET scan just to see if there's anything clear. If there's nothing clear to biopsy, we often wean the steroids whilst they're getting better and off ICU, and then repeat the PET scan to see if there's a target. So I mentioned intravascular lymphoma. So in patients who present with HLH to UCLH, we have a low threshold for doing deep skin biopsies because they're very useful in looking for intravascular lymphoma. These are done at, and this is irrespective of whether patients have a rash. And, it's not, the yield is low. I'm not saying that you will get a high yield from it, but it's a relatively non-invasive procedure. The caveat being these aren't superficial skin biopsies. The dermatologists have to get through to the subcutaneous tissue to take a biopsy to try and get the blood vessels. But you do get an unexpected diagnosis of intravascular lymphoma in patients with HLH, which then directs your treatment for that. So this is just a picture of a macrophage eating up this cell, which it shouldn't be eating up. Patients with HLH often need lots and lots of blood product support. So this is happening throughout their bone marrow, and it's eating up the precursor red cell forming cells, eating up the megakaryocytes and the neutrophils. So they may need lots of blood product support, including lots of platelets. One of the hallmarks of HLH is dropping fibrinogen, and I often worry when patients' fibrinogen is dropping because I worry that is a sign that they're right on the cusp, and these patients often need fibrinogen replacement. We use fibrinogen concentrate, but you can use cryoprecipitate. Patients are often neutropenic, and it's always difficult to know whether they should get a GCSF because there is some evidence that in some patients, if you give them GCSF, it can lead to a rebound episode of hyperinflammation. So we tend to be a bit more cautious, and if they've got an obvious infection and positive blood cultures, or they're looking very septic, we give GCSF more easily, but otherwise we try and hold off. Things to think about are steroids. Will they mask an underlying lymphoma? If patients are critically unwell, you just have to give the steroids and then look for the lymphoma later. Etoposide is a very useful agent, but it can't often be given quickly. There are some people use cyclosporin as an adjunct. More and more places in the rest of the world are using JAK inhibitors, so ruxolitinib and baricitinib are drugs that we use across hematological conditions as well as rheumatoid arthritis. and it's useful at shutting down the immune system, but we don't have ready access to them, but they can be very useful in patients who failed all other treatments for their HLH. In secondary HLH, especially in patients with hematological driver, treatment of the underlying malignancy is the best way of treating the HLH. You might be able to get it under control with steroids, anakinra, and topicide, but the only way you're really going to make them better is if you treat the underlying lymphoma. So there's not too many graphs, but I just want to show this graph because it's important. So in patients with a hematological malignancy who present with HLH, and you can define that in a couple of ways, but if they've got a raised ferritin over 1,000 and present with hematological malignancy and HLH, their survival is only 40% at 500 days. We don't do soluble CD25 routinely, but if you did their soluble CD25 and that was raised along with their ferritin, then you can see that it's an even worse outcome. So these patients don't do well, and you've got to be pretty frank with them, especially if they end up on a critical care unit, that their chance of being alive at a year is probably 20%, if not less. And that's irrespective of what the underlying driver is. So primary HLH is a defect due to granzymes and perforin, and commonly presents in childhood. We have had a couple of patients in their late 20s and early 20s who've been diagnosed with primary HLH, and they have a mutation affecting the granzymes or the perforins, which leads to autoinflammation. They tend to be picked up when they're children, but they can present later. You can do testing for the granzyme release and the perforin expression, and then you do genetic sequencing of their blood to see if they've got these mutations. And as I've said, the definitive treatment for them is an allogeneic bone marrow transplant. Other things to think about. So often a lot of people say, well, surely they've just got sepsis and you're just overdiagnosing HLH. And I think we are recognizing it more, and I think we are calling things HLH, whereas previously we would just said patients are just unwell or they're just septic. But I think if there's no clear cause and they fulfill the criteria, we are understanding more about an aberrant immune system that's overly activated and making people unwell. Other things are, there's a condition called TAFRO, which is very rare, which is a variant of Castleman's disease. So Castleman's disease is a hematological condition where the lymph nodes are enlarged in patients, and it often leads to overproduction of cytokines. And these patients can often present with a HLH type picture. You can get CAR T cell related HLH, and I know you've got a CAR T cell talk later, so I'm not going to go too much into it. But it is related to, again, hyperactivation of not only the genetically engineered T cells, but also the host immune cells. And it can also be highly refractory to steroids and anakinra. So it's important to bring together a group of people, because often with HLH, you need more than one person involved. So at UCLH, we have a MDT, which discusses patients with HLH. It occurs almost on a weekly basis, and it's got input from rheumatologists, critical care, infectious disease, neurology, hematology, and virology. Again, if you search UCLH HLH on via Google, then it will come up, and there's a referral form, and we're more than happy to discuss cases at our MDT, and we get referrals from across the specialities and from across the UK, Ireland, and even some cases from Europe. And with that, I'm happy to take any questions.
Thank you so much, Zach. There are a few questions in the chat here. So the first one is there a difference between HLH and cytokine release syndrome in terms of symptoms?
So cytokine release syndrome, we tend to use much more when we're talking about biological therapies in terms of CAR T cell and bispecific antibodies. I think the difference is in HLH, you don't really have that trigger known. You know if someone's had a bispecific or CAR T cell therapy. There's lots of overlap, and cytokine release syndrome can lead on to a HLH type picture. So if you did a bone marrow on people with CRS, then you'd see some hemophagocytosis. So it's just the extent of the inflammation and how much end organ damage it's giving you. HLH is very similar to macrophage activation syndrome. So the rheumatologists call it macrophage activation syndrome. Hematologists call it HLH. They're both overactivation of the immune system with pathological end organ damage. And not really, there's no real difference between HLH and macrophage activation syndrome in terms of symptoms. It's just two names for the same condition, just named slightly differently depending on which speciality it is. We don't routinely measure IL-6 before we start anakinra. Not every center can measure cytokines. If you can, it's useful, but it doesn't really help guide whether to give treatment or not. So do you have set criteria to give someone etoposide if they have low counts already? So the biggest thing with etoposide is not the low counts. So the low counts are because of the pathological hyperinflammation. And often you just need to give them the etoposide to turn the hyperinflammation off, to stop the bone marrow eating itself, to allow the counts to recover. So it's not the counts which limit the etoposide. It is mostly what their liver function is doing. So a lot of these patients have impaired liver function, and if their bilirubin is high, you often have to give slightly lower doses, and then we have lots of discussion about the optimal dose of etoposide to give. But it's not really the counts, it's more the liver function. And our threshold for giving etoposide has got lower with time, because we often sort of waited too long because we thought, oh, we'll give the steroids more of a chance, we'll give the anakinra more of a chance. But I think if they're deteriorating despite having a good trial of high-dose steroids and a good trial of anakinra, you just need to go in with the etoposide. Is there an imminent study of looking at the possible benefits of renal replacement therapy in removing cytokines? I don't think there are. Certainly, that's not something that we've often discussed. We try and keep people off the filter with the interventions we use as much as possible. And certainly the patients who are on renal replacement seem to do equally poorly to the ones who don't have renal replacement. You can definitely have the references that are used in this presentation. How do you manage patients with HLH post an allogeneic stem cell transplant who is suffering with GVHD? We don't tend to see that much HLH. So usually if they have HLH, you worry that their leukemia or the lymphoma is back, and that's what's driving the inflammation. I think it's very similar. For GVHD, you need to dampen the immune system to stop the donor immune cells attacking the host. In HLH, you need to dampen the immune system to stop it attacking the host. So it'd be similar. It's maximizing immunosuppression as much as possible without leading to infections. What we sometimes use in patients where we're really struggling, if anakinra and etoposide and everything isn't working, is we ask the hospital whether they'll fund a JAK inhibitor. We use baricitinib because it's a quarter of the price of ruxolitinib, and it tends to work very quickly. And it tends to work within 24 to 48 hours if it's going to work. Some places use tocilizumab, which is a way of blocking IL-6. There's other places which use siltuximab, which is another antibody which blocks IL-6. And there is, in the pediatric setting, there is a drug called emapalumab, which is available for primary HLH, and that blocks interferon gamma. That's not available for adults, and the data for secondary HLH is not as good as for children. So IVIG can definitely affect beta-D-glucan. I think it can also affect galactomannan levels. So we try and make sure all of the viruses and microbiology testing is sent off. Anything which is antibody-based. Yes, there are patients with HLH who are critically unwell on ICU where you've managed the initial hyperinflammation, they slowly improve, and at UCLH, if there's no clear hematological driver, the rheumatologists take a lead and they manage them as an outpatient. And what we do is we slowly wean off their immunosuppression. We try and get people off steroids first. We don't like steroids going on for too long, partly because of the infection risk and the other osteoporosis risks. And then what we do is we wean the anakinra after the steroid. So we get them off one agent and then slowly get them off the other agent over the course of a couple of weeks. We'd monitor what their inflammatory parameters were doing. And if we still haven't got a cause for their hyperinflammation, we would at that stage do another search. And often what happens is we have patients where we've done that and they rebound in back, straight back to A&E resus and straight back to ICU, where you've got to start everything again. And it's that balancing act of trying to find out what the cause is. They tend to have a hematological driver underneath it all. So the last patient who presented like that, we found a T-cell lymphoma after doing a splenic biopsy, and but it can often take a while to wean them off. So if we think they've got a lymphoma and we haven't diagnosed it, I follow them up and slowly wean their immunosuppression. When patients are critically unwell, we give the anakinra intravenously, especially if they've got low platelets, rather than subcut. When the platelets are consistently above 50, we switch to subcut injections. They're not the nicest injections to give. They do sting a lot, so we do try and limit how long patients stay on them. You can give it IV as well as subcut. It has a relatively short half-life, so if you're going to give it intravenously on critical care units, we split the dose into either twice a day or 3 times a day. The maximum dose of anakinra that we give, it tends to be 8 milligrams per kilogram in divided doses.
All right, so just to follow up with that. So within the kind of UCLH perspective, what kind of proportion of patients would end up with a hematological driver versus rheumatology or infectious or something else?
I'd say 70% will end up having a hematological driver. About 10 to 15 will be infection and 10 to 15 will be rheumatological. So the biggest rheumatological driver tends to be Still's disease, which is a diagnosis of exclusion. So that's why the rheumatologists are quite involved in our service. We have a slightly skewed outlook of HLH because we tend to be an accepting center for HLH from lots of other hospitals. So and so we see a lot more refractory HLH where sometimes we never quite get to the diagnosis. So unfortunately, we have plenty of death certificates which say HLH, but we can't find out what the underlying driver is. But I'd say that would be a rough assessment of how far we go. It really depends how unwell they were in terms of the parameters for follow-up after discharge. We tend to keep a fairly close eye on them with a sort of weekly review, either in the hematology clinic or rapid access outpatient clinic. And then you can sort of lengthen it a bit depending on how stable they are or not. The other thing is that we are the HLH MDT is very friendly, so we have our own email address and website. So if you do have any questions, then you can either send me an email. Gavin can pass my email address on to you, or we're happy to take referrals through there's a pro forma that has to be filled in. Our MDTs every Monday at 11:45 and alternate Wednesdays at 5:30 to try and have 2 times where different teams can attend. And yeah, we're happy to discuss cases. There's no such thing as a simple case, and sometimes all we really do is just confirm that local centres are doing the right thing rather than magically give an answer which tells them what the diagnosis is or doesn't.
Right. Thank you very much, Sat, for your time. That was really fascinating.
Cool. Thanks all. Enjoy the rest of your day. Thanks for having me, Gavin. All the best.
Hi, everybody. I'm Kate Stringaris. I'm one of the transplant consultants here at UCLH, and I also look after leukemia patients. And I'm going to talk to you today about post-transplant complications and how that is relevant for intensive care patients. So first of all, I'm going to talk to you a little bit about what is transplant, what are the main complications, and then what are the outcomes overall for transplant patients, because I feel like perhaps in ICU you see a particularly poor subset of our patients. And so I just wanted to give you a bit of a overview about how our patient group do in general. So what is a transplant? So it's a hematopoietic stem cell transplantation. We used to all call it bone marrow transplant, but we actually very rarely use bone marrow sources of stem cells anymore, because in the olden days, the only way to get stem cells out of someone's body was to give them a general anesthetic, lie them on their front, and rather brutally extract with a huge syringe great liters of bone marrow, which we then put into the patient. But donors don't have to go through that experience anymore. We just give them 4 injections, which they can give themselves at home, of GCSF, which makes the stem cells come out of their bone marrow into their bloodstream, and then they can just sit on the apheresis unit on the 4th floor of Macmillan Cancer Centre in Huntley Street, and then they just stay there for a day, and the stem cells are taken out of the blood. The machine filters them into a bag, which then gets frozen or given straight to the patient. And most of those and all the rest of the blood components that we don't need go back into the donor, and the donor's usually back at work the next day. So it's a much more straightforward procedure, which makes it much easier to get people to put their names on the bone marrow register, which is great. So I digress. So what is hematopoietic stem cell transplantation? So basically, as I said, stem cells are removed from the donor, and that can be a sibling, ideally. But if we don't have a sibling with an HLA match, and each one of your siblings would be about a 1 in 4 chance of being an HLA match, which is what we need to use them as a donor, then we might use an unrelated donor or a half match or a haplo donor. We don't really use the patient's own cells anymore for leukemia or for myelodysplasia, which are most of the transplants that I'm going to talk about today. So essentially, the patient will come in, they will receive some treatment to destroy what's in their bone marrow already as much as possible. And if they've still got a little bit of hematological cancer in there, then hopefully it will destroy that too. But most importantly, it will destroy the stem cells that are in the bone marrow already. And then we give them stem cells back from the donor, and that just goes in as an IV infusion. And so it's not an operation. And essentially, some patients actually find that transplant itself a bit of a anticlimax because it looks a bit like a bag of platelets. What happens during the period when they're having that, before they get their cells, they're in for about a week, and you can either give a patient a reduced intensity transplant or what we call a myeloablative or full intensity transplant. And we make the decision about what type of treatment to give to prepare the stems to the patient for the stem cells based on age predominantly, as well as cancer type. And so really, for the majority of these transplants that are giving cells from another person to a patient, or allogeneic stem cell transplants, we are basing what type of conditioning on age. And that's because ideally the best way of curing a patient is with as much conditioning as possible, and then giving them a healthy bone marrow to regenerate those cells. And so we do that in patients under 40, where we give them total body irradiation, which is very high doses of irradiation, and we give it alongside cyclophosphamide in the majority of patients. And what that does is completely get rid of anything that's in their bone marrow. And what we find is that if we, for some reason, cannot give stem cells to that person, then their bone marrow will never recover, and they will be forevermore aplastic, and that will be a fatal situation. So it's really important that you only give that type of intensive conditioning to people who are going to be able to take it, and that, in our experience, is pretty much everybody has to be under 40. Above that, patients just cannot tolerate that sort of treatment. But over 40, we give a more reduced intensity plan, and this is usually 3 drugs: fludarabine, melphalan, which are the 2 doing the heavy lifting, and then Campath, which is basically something to destroy the T cells in the patient, but they also hang around in the patient so that as the donor cells come in, they're also helping to destroy some of those donor T cells, which might cause a graft versus host disease effect, which I will talk about in a minute. So after the cells go in, that patient will be, it will take about 2 weeks for the cells to start bedding into the marrow and reproducing and creating normal, differentiating into normal blood cells. And the neutrophils usually take between 10 and 14 days for most of the reduced intensity transplants. It can take a little bit more for some of the other type of transplants, but so that 10 to 14 days is when these patients are most vulnerable to bacterial infections, particularly, and also fungal infections. But the lymphocytes take a lot longer to recover, and then very much longer to be normal in function. And so these patients are prone to viral infections for a very long time. And some say that those immune systems are really never completely normal after a stem cell transplant. And so sometimes we substitute melphalan and cyclophosphamide for busulfan in some illnesses, and ATG is another immunosuppressant that we sometimes use. Methotrexate we can also use to prevent graft versus host disease, and then most patients will be on these 2 drugs after transplant: cyclosporin and mycophenolate, which again reduce the risk of graft versus host disease. So that's kind of what's happening. But I think I'm going to talk now about who gets a transplant. And so essentially today I'm going to talk about adult patients, but we do transplant children, and essentially most of the problems that can happen after a transplant in adults can also happen in children, although children are more robust in some ways and perhaps less robust in others. So this is the list of all the diseases that we transplanted between 2017 and 2021 at UCLH. I'm going to not look at the autologous transplants because that's what we do for lymphoma and myeloma, but it's quite a different type of process. And really, autologous transplant is just a way of giving very high dose chemotherapy and then helping that patient recover. Allogeneic transplant, which is what I'm going to talk about today, is really what's happening with those donor cells is that not only are they just helping the bone marrow recover, but they're also providing something called a graft versus tumor effect. And this is a very particular way that they manage to produce probably the majority of their curative effect in our patients who are having non-myeloablative transplants. It also leads to, unfortunately, some of the main side effects, in particular, the graft versus host disease, which these patients could get. So you can see in green here that the vast majority of patients who are having allogeneic stem cell transplants here and worldwide are having it for acute leukemia. So these are patients who have poor risk acute leukemia. So what we know is that based on treating lots and lots of patients in the past with just chemotherapy, there's a subset of patients who are very likely to relapse if we just give them chemotherapy, even if we're giving them 4 cycles, if they've got AML, for example. And so we base our decision making on what their genetics are in the actual leukemia cells, and we can predict if they've got, say, a 25% chance of relapse. We would say that's a reasonably low risk. It sounds quite bad, but it's not too bad. And so we might say, well, if you've got a 75% chance of cure without having a transplant, let's just go with that. And then we perhaps would only transplant you if the disease relapses at some point in the future. But so if you have poor risk genetics in your leukemia cells, then we would say, well, your chance of relapse is more like 75% just having chemotherapy. And those are the patients that we would say, let's see if we can find you a good donor, and we'll just give you a couple of cycles of chemotherapy to get you into remission, and then we'll proceed straight to a stem cell transplant. And transplant patients are different to the typical malignant hematology patient. First of all, usually the burden of disease is low or negligible in these patients. So we give them some chemotherapy to get them into remission. And the reason we do that is transplant just doesn't work as well if you go into a transplant with a lot of leukemia on board. So we're doing it to prevent relapse in the majority of patients rather than as part of their sort of frontline treatment. There are centres that do it in patients who still have a lot of leukemia on board. Imperial is one of them, and there's some centres in Germany, but it tends to be, they tend to not do so well, so we don't do that here. But what that means in terms of transplant complications is that tumor lysis syndrome, which is something that happens in a lot of malignant hematology patients when we treat them, isn't really an issue in transplant because we've already got rid of the bulk of their disease. Secondly, they're different to other hematological malignancy patients because they're much fitter than average, because they have to have passed a barrier of good organ function to be able to be eligible for a transplant. So not everybody gets there. We have an age cutoff of 70 because what we find is that patients over 70 just do not tolerate the intensity of a stem cell transplant. But up until the age of 70, we would assess everybody based on making sure that they've got a decent cardiac function, everybody gets a mugger prior to transplant, and a good GFR. And then, you know, there's other practical things like, are they going to come to clinic, and are they going to be able to stay in a hospital bed for a month, and things like that, which actually, you know, and are they mentally able to tolerate the whole process of having to take immunosuppressive tablets after treatment, after the transplant. So all of that needs to be thought about before, because I think if it's not sorted out before, then you can just end up with patients not managing to survive the process because, for example, they just don't want to take their post-transplant medication, and then they end up dying of a horrible infection or dying of graft-versus-host disease. And I think we need to ascertain before we go in that they're going to be able to adhere to the plan. The third thing, which I think is perhaps different, although we should be doing this with all our hematological malignancy patients, but I think with transplant it's very formalized in that we have a special transplant clinic on a Friday afternoon where everybody who's coming up to transplant gets consented in a particular way, where we go through, as we would any treatment plan, about what's going to happen, but we explicitly discuss the possibility of intensive care unit stay during the transplant. So they know that this might be coming up before we go into the treatment. And fourthly, we have a very clear expected time to recovery with transplants. So depending on the conditioning, the majority of our patients are getting reduced intensity conditioning, say, with the regimen of melphalan, fludarabine, and Campath. We know that 10 to 14 days is the average time that patients are going to take to recover their neutrophil count. I think that is really important when you're thinking about managing these patients in ITU who come in with an infective problem. They're neutropenic, but we know that that conditioning means that say they come in on day 8, we know that in 2 to 6 days they're going to have neutrophils, which makes a huge difference in terms of what being encouraging to support them for at least until they get neutrophils, even if everything else is not doing well, because there's a very clear time plan. It doesn't always work like that. There is a risk of graft failure, but we could be fairly clear that that usually happens in the majority of patients. And we would do things like give granulocyte infusions, for example, on a temporary basis until they engraft, if that was appropriate. So moving on to what are the complications of transplant? Well, so we have this thing called non-relapse mortality. So still, unfortunately, one of the big things that patients die of going in after a transplant is that the disease, the leukemia, comes back. And this happens in about 3 out of every 10 patients, although it varies depending on the type of leukemia. But in blue here, the non-relapse mortality is what most of patients come to ITU with, and this accounts for this happens in about 10 to 30% of patients who actually die during the transplant or the early post-transplant period. And we counsel patients and predict this based on age, based on organ function, based on the type of leukemia, based on how good the donor is. But the main causes of it, of people coming to ITU and dying, or not coming to ITU and dying, is graft versus host disease, which I'll come to, infection, secondary malignancy, and organ failure. And that could be kidneys or lungs, most commonly. And cardiac, of course. So graft versus host disease is a complication which happens depending on the type of transplant, but on average, about half of people are going to get some sort of graft versus host disease. And it's essentially where T cells from the donor, as the donor cells regenerate in the patient's bone marrow, those T cells start circulating, and when they identify patient tissue, they recognize it as foreign and start an immune response to that tissue. So it's almost like an alloimmune, but it's like an autoimmune condition. But in the context of transplant, we call it alloimmune because those cells are coming from a donor. And the 3 main organs that graft versus host disease affects is the gut, where it causes diarrhea most commonly, or it can cause upper GI problems like nausea and anorexia. The skin, which is very common and causes a rash of varying degrees of severity. It's very common just to have a bit of dry skin, but the palms are the most sort of classic place to get a GVHD, although we often do not see it there. And essentially it can be anywhere, but it's typically this sort of macular papular rash that you can see here. The back is quite common, so it's always important to check someone's back in clinic. And then that can be mild, it can be patchy, it can be confluent all over the body, or it can be kind of quite severe, ulcerative, unpleasant GVHD, which can be turned into a chronic process, and it can be very ulcerative and unpleasant. And then the third organ that's most commonly affected is the liver, and this is essentially just picked up on liver function tests. There's various patterns. Classically, the bilirubin was thought to be the main thing that goes up, but actually we find different patterns, and it can be all sorts of different combinations of liver function going off. So we used to biopsy everybody to diagnose GVHD, but what we find is that we usually get a kind of report 2 weeks later saying, oh, inflammatory, could be this, could be that. And it's apart from there's apoptotic bodies you sometimes see on a biopsy, but essentially it's quite difficult to diagnose GVHD in the time you need to from a biopsy, and really you need to start some immunosuppressive treatment with steroids pretty much same day ideally. So we actually don't even biopsy really anybody anymore unless they've got sort of chronic issues with, say, diarrhea, which we haven't got to the bottom of, they haven't responded to steroids, and then later down the line when we want to exclude infections, and then we might biopsy. But up front we don't routinely biopsy people anymore to diagnose this. But just on that, as the treatment is steroids, we've got patients who are therefore immunosuppressed because we've given them this intensive conditioning. Their lymphocytes haven't recovered, although they have neutrophils, we're then giving them a lot of steroids to treat graft-versus-host disease, and so they're sort of triply immunosuppressed when they have graft-versus-host disease, as well as having had a transplant. And the graft-versus-host disease itself is immunosuppressive. It's immunosuppressive to the bone marrow. So these patients are very vulnerable. And they're vulnerable particularly to the second most common, well, probably the most common cause of complications post-transplant, which is infection. And that can be bacterial, fungal, viral. We get very profound immunosuppression, as I said, from the conditioning. And then we can also get very unusual infections. We screen routinely all our patients twice a week with blood PCRs for CMV, EBV, and adenovirus. And the reason we choose them is because if we pick it up low level in the blood before it causes organ damage, we can do something about it because we've got treatments for those ones. HHV6 we don't routinely screen for, but we have it in mind in the differential when we're thinking about patients with unexplained symptoms, which could be attributable to HHV6. And bacteria and fungi, I'm sure you will know about how to manage them. So other complications of transplant, so particular organ dysfunction that can happen in our patients. We see side effects from conditioning, so those drugs that we give at the beginning. Busulfan is one that could cause seizures, and sometimes patients need to go to ITU to manage that. The radiation that we give can cause terrible mucositis, and that can be, patients can need NG tubes or TPN, not uncommonly. You can get infusional reactions with Campath, which can be very, very low blood pressures particularly, and sometimes they need inotrophic support, although not usually. Usually we manage it with hydrocortisone, Piriton. And then blood pressure changes with the actual stem cell infusion itself, and that can often be high blood pressure. We can usually manage that on the wards. Our nurses on the wards are really highly trained and skilled at managing this stuff, but occasionally these patients do need to go to the intensive care. And then we have sometimes seen alkylator-induced CCF from the transplant conditioning, so cardiac failure. Liver failure is another thing that we do see with our patients. There is a process called veno-occlusive disease, which can happen in transplant patients. And that's where essentially they gain weight. And we think it's due to small microthrombi in the liver. And we treat it with basically anticoagulant type drugs, something called defibrillide. And but that's all. I mean, it's essentially supportive care, but that can cause a huge weight gain, and it can be fatal in some patients. So that's one other reason that some of these patients may go to ITU or and may need temporary organ support. So what do we know about transplant patients going to ITU? Well, this is just a study that Emma Morris and Will Townsend published over 10 years ago now, but I think the type of conditioning we do is very similar. So I suspect that these results are going to still be very similar now. And it looked at about 164 allografts, and which of these, and of who went to ITU, 3/4 of them were myeloablative and 23% were reduced intensity. And interestingly, the myeloablative, despite being younger, because they must all have been under 40, had twice the risk of intensive care unit admission. And their median days in ITU were 4. So actually, most of these patients just came in for sepsis, had some inotrophic support or respiratory support, and then went home. Back to the ward, not necessarily home. 50% of them did need mechanical ventilation, and 1/3 of them survived. So it's a bit grim, but I think, you know, a third of people surviving is better than some studies where, and I think when I was training, we were really, the ITU teams were very not enthusiastic about admitting any of our patients, because I think it was essentially thought that none of them survive, but 1/3 of them is actually not too bad. And if they do get into that 1/3 that survive, subsequent long-term survival is really good. So, and that's actually the same pretty much in terms of mortality rates among patients who are having transplants that didn't go to ITU, which is reassuring. So which patients are high risk who are having transplants? Well, unrelated donor transplants are higher risk than sibling transplants, and the better your HLA match is, the less good your HLA match, the less good your chance of surviving your transplant. And the transplant-related mortality or non-relapse mortality goes down about, goes up, the mortality goes up about 10% with each mismatch that you have in your HLA. So less good donors are less good. Older and more unfit patients overall are going to do worse. And then the big one, which we don't really do here very much, but we may be doing soon, is umbilical cord blood transplants, mainly because as a donor source, they're much more immature. They take a lot longer to engraft, to get their neutrophils back after a transplant. We don't use these very often, but there is a study that's going to open soon nationally, and I suspect it will open here, looking at these types of transplants. So those patients are very, very immunosuppressed, and they have longer periods of immunosuppression. So that's a very high risk group internationally. There is, interestingly, a study which is being done up in Manchester where they're expanding those umbilical cord blood stem cells ex vivo and then putting them back in the patient, and those are doing really, really well. They're engrafting about day 7, so even quicker than our normal transplants. So that's something that may come up in the future and be less high risk, so it'll be interesting to collect those data. So just looking at our transplant outcomes, so although a lot of patients do really badly, particularly if they get sepsis, organ failure, terrible graft-versus-host disease, overall, as a proportion of our whole group of patients having transplants, that is small. And under 40s, you can see here patients with AML who are having myeloablative transplants, so that really intensive conditioning. Our event-free survival for those with sibling donors is 79%, and our unrelated donor transplants are getting 72% event-free survival at 5 years. So, and it's just plateaued out. So if you get through that initial awful bit with all these complications, then most of these patients do really well. And even with relapse, if they're going to relapse, they tend to do it in the first 3 years. In fact, they tend to do it in the first 2 years. There's a handful that relapse in the 3rd year. And after that, we actually just send patients back to their GP with clear instructions about monitoring for long-term side effects like an increased risk of skin cancer and cardiovascular disease. This is looking at relapse and non-myeloid relapse mortality, and that's just reiterating what I just said. In the over 60s, so this is patients between 60 and 70, because we don't transplant anyone over 70. You can see that the results are not as good as you might expect. This is partly because the leukemia is often higher risk of relapse, and also these patients are overall less fit. Comparing the early 60s to the late 60s, actually there was no difference. So that's reassuring that it's really quite safe to transplant someone up until the age of 70. You don't need to cut them off at 65. Comparing SIBs and unrelated donors was interesting because what we found, and that's been corroborated internationally by various studies, is that sibling donors here in red at the bottom right do much better than having an unrelated donor transplant. And these are graphs that Kirsty Thompson, our transplant lead, has kindly lent me. And then in the 40 to 60 group versus the over 60s, you can see here that the 40 to 60 years do have a lower risk of non-relapse mortality there on the right. So that's the under 60s in blue and the over 60s in red. And on the, sorry, that was on the left. On the right, you see that the over 60s do have a slightly lower risk of relapse as well. So at UCLH, our transplant outcomes, they send us this every few years based on all the data that all the transplant centres send to a centralised data collection centre to make sure that everyone's doing what they should be doing, and they compare them to each other rather brutally. And we're coming out quite well at the moment. So that's us in blue, and this is
sorry, that's us in red, and that's everybody else in blue. And so we're coming out quite well in terms of survival, which is reassuring. But I mean, the caveat to that is that some other centres would perhaps transplant people over 70. So I think, as with all kind of league table stuff, we have to take it all a little bit with a pinch of salt. So future of transplant, we're starting to transplant adults now with sickle cell disease. This is another group with a lot of organ dysfunction. We've already opened a trial this year, so that will be an interesting group to see how they do. We are doing various post-transplant modifications to reduce relapse, which I won't go into. New ways to avoid and treat graft versus host disease. We've got new kinds of grafts, which I've mentioned. And I'm just going to finish with a case study. So this is a 47-year-old lady who had high-risk myelodysplastic syndrome, which is like a precursor to acute leukemia. And if we think patients are highly likely to develop acute leukemia, we will transplant them in the MDS stage. And she had a reduced intensity condition sibling transplant. And then on day 34, she became really confused with fever. And she had an MRI, she had a normal CT head, and then an MRI, which showed an involving encephalitis. Her CSF was normal initially, and then later, so we put her on, she started fitting. We put her on some Keppra, some clobazam, and valproate. Eventually, she was still fitting, so several days on ITU. She was treated with antibiotics. Everything was coming back negative until later on. It was over Christmas, so unfortunately, the labs were not doing the normal runs. But eventually, we got an HHV6 low positive on her CSF, and we had been treating her with high-dose acyclovir just for a possible viral encephalitis, but we switched her to foscarnet, and she got remarkably better. And I just saw her actually 4 years later in transplant clinic, and she's doing really well. So back at work 4 days a week with a bit of anxiety and slightly less good memory than she had before, but considering that she was on ITU, intubated and fitting for several days, and then asleep for longer than that, just encephalopathic, she did remarkably well. And that's her there just recently, and that's her in the white there, having just come back from holiday in India. And she's very grateful to all the ITU team for looking after her. So I think I'm going to stop there. Any questions?
Thanks, Kate. That's really, really good. And it's always nice to end a presentation on such a happy note. There is a question in the chat for you. What is your opinion about some patients whose white cell count is already going up before day 7 and GCSF is not even started yet? Is that a good sign or a bad sign?
Post-transplant?
I believe so, yes.
I mean, it's very unusual for that to happen. I think I couldn't say if it's a good sign or a bad sign. It would totally depend on what it was. I mean, theoretically, it could be very early engraftment, but it would be very unusual with the protocols that we use that anyone would be having donor cells coming up at day 7. So I would be worried that it would be leukemia. But again, that would be very unusual in transplants where you're going in with 0 leukemia detectable in the peripheral blood. So I'd need a bit more information really to be able to answer that question.
Thank you. Wes's question, I don't know if you want to put some information in the chat. In the meantime, I'm going to ask you the next question. Do you think that sickle allografts in adults will be overtaken by gene therapy autografts in the future?
Yeah, so I think they might be, for sure. I mean, the Bluebird study looks really promising. Initially, there was a couple of issues initially, but I think theoretically it could be really promising. Yeah, I mean, autografts are generally less risky because you don't have that risk of graft versus host disease. You don't have to use immunosuppression in the same way. So
particularly for sickle cell patients who have a lot of other organ issues with their lungs and their kidneys and their brains, having often had strokes. I think, yeah, I mean, it would be very promising. I know there was some issues with some leukemias, which these patients got on the trial, and so it was halted initially. But I think it's difficult to tease out whether that was anything to do with the gene therapy, or whether it was the fact that sickle cell patients do actually have about a 10 times increased risk of getting an acute leukemia, probably just because of their active bone marrow that's constantly proliferating. So I think there's more work to be done, but I think theoretically it's promising, yeah. But in the meantime, we're certainly doing transplants very successfully. Internationally, they're being done. I was in America and we were doing them a lot, both in sibling donors and also from haplo, so half matched donors, which is really important for that population, who often it's quite difficult to find an unrelated donor. So you might be more likely to find a half matched donor from a parent or a child or a cousin. So it opens up transplant as an option for cure in a lot of these patients who otherwise have quite a difficult time.
Thank you, Kate. I think we might have time for one more question. There are a few more in the chat. If we answer this one, and then afterwards, if you won't mind, just directly in the chat,
sure,
that would be lovely. So the next one is it possible for a patient who is being worked up towards transplant to develop GVHD?
No, so it could only be after the donor cells have been infused, and then those donor cells have found their way to the patient's bone marrow and started regenerating normal cells. It's impossible to get a GVHD before a transplant. If you get, I mean, there's so many other reasons why these patients are going to have diarrhea. It's more likely to be, infective or something else. Yeah, it's purely a post-allograft complication.
Thanks very much, Gavin. Thanks for inviting me. This is a kind of personal talk about the sort of my experience of this subject generally in ITU, but I think it particularly relates to intensive care. But before we, I've sort of put this picture up because it's really about the decisions we make in these difficult situations. I've always wanted to have some conflicts of interest, but I've never really had any. Anyway, I want to start by talking about what I've noticed quite often happens when I'm on a ward round in ITU and we get to a patient that's particularly stuck and sick, and we don't seem to be making progress with, or they're got lots of problems. And haematology patients obviously often fall into this category. I've noticed that quite often in this situation, one of the people on the ward round, often a senior registrar or one of the nurses, will start to drop hints to me. And the first is often, I can't really see this person ever getting out of here, followed by, and even if she does, well, she's not really going to have any decent quality of life, is she? And if I don't pick up on that hint, it starts to progress slowly. Often you say, well, aren't we treating the family here, not the patient? They just don't understand. It's very sad, but they really just don't get the situation. And then if I'm still not biting on this hint, it often escalates. I mean, I just don't know how we ended up here. This is a nightmare. We shouldn't have admitted this patient. They shouldn't have come to ITU. They were never gonna do. And if I'm still persisting, still not taking to the hint, it escalates again. I really think, Jim, you need it's time to draw a line in the sand, to tell them how it is, to lay down the law. And again, if that hasn't, it starts to get sometimes more straightforward. Well, it doesn't matter anyway. You know, you're off in a couple of days, and when Dr. Blah comes on, they'll stop this nonsense. And then it can, you know, lots of different factors can come into this. It's a complete waste of taxpayers' money. The haematologist will still be giving chemo in the morgue. These are, you know, people obviously don't. This is at the more extreme end, but you know, there can be very strong feelings about what we're doing to people and whether it's the right thing. And more recently, I've started to think actually this actually speaks to a little sort of narrative, a little drama that plays out around patients, you know, difficult patients that are either on intensive care or potentially looking to come to intensive care. And in that little drama, stereotypically, the intensivist has a particular role. And I think our role is twofold in terms of that sort of stereotypical picture. The first is that we look on our position as someone who is there to defend the ramparts of ITU, to stop, you know, these armies of hematologists and oncologists with their patients who really shouldn't come to ITU, getting into ITU. And it's our role is to ensure that we don't use ITU for inappropriate patients. And then the second aspect of our role is this realism thing. That's a realist painting, and it's our role to distinguish the theoretical from the practical. So although this might theoretically be someone who could benefit from ITU, actually our role is to look at the reality and say, are they really going to benefit from ITU before we admit them, or are they still going to benefit if we carry on? And we do that with in various degrees on a spectrum. Like all of medicine, I think we're on a spectrum from, at one end, intensivist doves who are more likely to admit people when perhaps their chance of benefiting are lower, and perhaps more likely to carry on with invasive support when the odds are looking less good, right up at the other end to hawks who are much more likely to be to say, actually, I don't think this is a good use of intensive care, and are more likely to perhaps to withdraw support earlier on people who are not doing well. And within the intensive care community, I think there are, again, stereotypically, some adjectives that go with the doves and the hawks. And perhaps the doves are looked on as slightly weak, perhaps a little bit more defensive in their medicine, a bit more worried about being criticized, about being complained about, a bit less willing to make difficult decisions, unwilling to take on arguments either with families or other specialists. Whereas at the other end, the hawks are often thought of as brave, as realists, as tough, you know, as not afraid to do what the intensive care community think is the right thing. Now, of course, you could, and other people might look on these, look on different adjectives to describe these people. One might think, well, maybe the doves are actually, you know, thinking very hard and deeply about this. Maybe they're questioning the sort of norms and questioning the received wisdom and thinking a bit outside the box. Whereas the hawks, you know, could potentially be on occasion perhaps too confident in their view about whether someone might benefit or not, and perhaps a little bit rigid in their thinking and how they look on their position. And of course, within that narrative, within that drama, we're not the only actors. We're not the players in it. There's obviously the patient is a key member of that in that narrative, but often they are not able to voice their opinion because they're either unconscious or they've lost capacity. But very often there are two other groups of characters, groups of protagonists. There's the family, who will have often, or almost always, views on what the decision should be about the loved one who either needs ITU or is having ITU. And then there's the primary physician, in our case today, the hematologist, who again will have strong views about whether this patient might or might not benefit from ITU. And of course, their influence on how this drama plays out doesn't just depend on what those views are, it also depends on who that people is, who the family are, how eloquent they are, how well they can put their argument together, how far they want to take their side of the argument. And of course, the same with the physicians, how eminent they are, how influential they are, how strong-willed they are. Now, all of that sounds a little bit cynical and a little bit perhaps reductionist, when of course in reality, usually in this drama, we're all trying to do the same thing. We're all trying to work together to get the right outcome for the patient. And we're doing that by balancing the 4 medical ethical principles. The principles of autonomy, i.e. allowing patients to decide for themselves about what treatments they have. Beneficence, doing good, always trying to do good. Non-maleficence, avoiding doing harm. And justice, being fair and offering the same treatment to all people who may benefit from. And we're doing this using our experience, using compassion, collaborating together, and then trying to come up with a decision that is both in the best interest of the patient, i.e. what we, as far as we can tell, the patient would want, and also what is clinically appropriate, i.e. what might work, what might achieve the physiological result that we hope it will achieve. And so in a best case scenario, and very often, we all work together and we agree on what is in the best interest and what is clinically appropriate. But of course, in coming to that decision, there are an awful lot of hurdles. And I want to just briefly look at some of those hurdles. And the first is the ethical frameworks we work within. So all the people playing into this narrative may come from different ethical backgrounds. They may be utilitarians, they may believe in doing the greatest good for the greatest number. They may be deontological, they may believe in much more of a duties and rules and obligations based structure for making their moral decisions. They may make decisions in a virtue-based ways, i.e. the decision you make is one that a virtuous person would make. And all of these things may slightly influence the way the conclusions people come to in different clinical scenarios. There's then, of course, we work particularly in London, but in the whole of the UK, in an incredibly diverse community. And lots of different people will come from different faith backgrounds, and their views on the decisions we make in these difficult situations of people coming to intensive care or staying in intensive care may be very influenced by the teachings of their particular faith. And then, of course, as the clinicians, we have to decide where we are on the moral universalism versus the moral relativism spectrum. I.e., do we sit nearer the end where we think there is one moral right and that other views about what is morally right we should ignore? Or do we sit right at the other end of the spectrum with moral relativism, where we believe that any moral position should be listened to and taken into account? And of course, there are problems at both ends of that spectrum. With the moral universalism, there's a great danger that you'll be intolerant of other perspectives, whereas with complete moral relativism, there is a risk that you'll take in points of view that are based in fiction and actually should be ignored because what they're based on is not legitimate. And within all that moral framework, when we're trying to make these decisions, we're doing it in an uncertain world. We don't know, in a lot of cases, when we've got a sick patient either wanting to come into ITU or looking to come into ITU or already in ITU on multiple organs on support, whether they can or might recover or not. We try to do scores on them, we try to look at all the factors involved, but often we are left with a big element of doubt. And that doubt isn't just about whether they can survive or not. It's also about more than that. So it's about how much harm they will suffer for what chance of surviving. So how much pain and intensive care they should go through, or they should be put through, for a 10% chance of surviving, a 20% chance of surviving. Where is the balance in that debate? And not only that, of course, what do we mean by surviving? What quality of life do we deem worth all that suffering in the end? So what gives life value? And of course, that is incredibly individual. We all have different views on what makes a life valuable to a person. You know, you might be someone who believes that just life itself, it's the intrinsic presence of life has value. You might be someone who believes in the instrumental value of life, i.e. the ability to do things is what gives life value. You might believe in the relational value of life, i.e. the value, if you're valued by others, then that makes your life valuable. And each of us is different in the way we think about what makes a life of value. And that, of course, puts the doves and the hawks in a different frame. Because now we might think, well, perhaps actually the doves are people who need more certainty before they make a decision about whether a treatment is the right one to pursue, an intensive care treatment is the right one to pursue, whereas the hawks are happier to work and to operate in a less certain world. Or perhaps the doves are more happy to deal with doing harm to patients until they're sure that there isn't a chance of benefit, whereas the hawks are actually more worried about harm, more worried about suffering, and rate that higher in their balance of whether something is the right thing to do or not. And of course, on top of that, we've got this situation that it looks differently from where you, depending on where you're standing. So this situation, as we said, it's got 3 different players around the patient. You've got the relatives. Now their position, of course, is that they know the patient the best. They may have known the patient for 50 years. So they're most likely to know what the patient would want in a certain situation. But of course, they've got weaknesses to their position as well. One is that they're not medically trained. They don't understand the medicine, what lies ahead for the patient. And 2 is, of course, they're at risk of bias because they're so emotionally involved in the patient, their ability to be objective may be compromised. You've then got the physician, let's call them the haematologist in this situation, who know the patient quite well, know the underlying disease very well, so they've got those advantages. But on the downside, they're not intensive care doctors, they're not people who are used to managing multiple organ failure, and also they're at risk of sunk cost fallacy. So they have invested an awful lot in a line of treatment for that patient, and for them to then change tack and accept that actually perhaps this line of treatment is no longer the best one can be very difficult. And then you've got the third group, the intensivists, who don't know the patient so well at all, potentially don't know the disease, the underlying disease so well, but on the other hand, they do know intensive care well, and they're perhaps able to be more objective. And the key reason for raising these is that all 3 of those people have strengths and weaknesses in their position. They've got something to add to the debate, to the discussion, but of course none of them are in possession of this sort of ultimately good position, if you like. And then you've got the enemies of good decisions, and these are the enemies of all good decisions. So you've got this issue about how you make moral judgments. Do you try and do it using reason, using logic, as Descartes and Kant would say, or do you use intuition and emotion? Now, a lot of us would say, well, we should use reason, we should be logical about this. But of course, if you do that, it goes against your intuition and your emotion. That's incredibly uncomfortable and can make us feel very morally distressed. And looked on a slightly different way, the psychologist Kahneman looks at this difference between intuition and logical or reasoned decision making in terms of thinking fast and slow, the dual processing of how we make decisions. So do you make a fast decision where you follow your intuition, which is an incredibly strong emotional pull, or do you use slower thinking where you try to be more rational in how you make the decision? And again, we just need to try to be aware of the fact that often we are very strongly influenced by intuition, and it can be very difficult to go against them. So we might think, well, we should make decisions as groups because that will mean we'll get lots of points of view. We'll make a more reasoned, a more rational decision. But of course, there is a risk with groups as well, in that you can fall foul of groupthink. And the problem here is that in groups, the person who speaks first, the leader, tends to have a vastly increased influence compared with the rest of the group. So whatever they say first, particularly if people respect them, people are very much likely to agree with. And actually, in some groups, you can get a more extreme decision than you would do from any of the individuals on their own. So groups can be very helpful, but they're not without their problems. Then there's the whole issue of biases. And we're all victim to biases all the time, and medicine's no different. And one of the classic biases that we always talk about in medicine is confirmation bias. So the fact that we are likely to cite and favor evidence trials that confirm what we already thought. And this is a massive problem for us because it means that we just reinforce our original views by handpicking the papers that agree with us. But of course, it's not the only bias. There can be many other biases. And I want to just, as an example here, there's implicit bias, this influence of irrelevant factors to our evaluation. And these are subconscious factors. So we don't think logically that they're relevant. We know they're not relevant, and yet at a subconscious level, we are influencing by them, even if we don't believe that in our conscious mind. And those come to things like gender and race. Even if we don't believe consciously that they're of any material importance, subconsciously we may well be being influenced by them. And then finally, the final enemy of good decision generally is noise, this random effect of irrelevant things. And the great example of that is halt: hungry, angry, late, and tired. And we know that if you are any of those, or even more so, all of those things, your decisions will be different to if you are not any of those things. And the classic example where this has been shown is if you are in court and your trial, your judge is making their sentence before lunch, you are likely to get a much harsher sentence than if you have it when they've been fed and it's just after lunch. Completely random, irrelevant factor, but affects the decision that the judge makes. And the problem with these enemies of good decisions is they're unexamined. We're not aware of them influencing us, and they're cultural. They massively depend on our background. I hope that I've made it sort of the point that the decisions we make are very influenced by many things that we really should be aware of. But does that matter? You know, is there a big variation in the end in the decisions we make, or is this just a sort of exercise in theory? You know, do we vary in our decision making? Does that variation impact patient care? Does it impact outcomes? Does it impact resource utilization, patient satisfaction? And I ask that question partly because we know in the UK there is no financial incentive to the decision we make. Doesn't affect our pay packet whether we bring someone to ITU or not. So we don't have that huge influence on it. But are we doing what we think we're doing, and are we doing the same as our colleagues? Well, if we start with a variation to begin with, I think there is some evidence that we are very variable in the decisions we make. And this is a study comparing 3 ICUs, one in America, one in USA, one in UK, and one in South Africa. And they looked at how many of the deaths on the ITU were after withdrawal of life-sustaining treatment compared with all the deaths on the unit. And what they found, and this has been reproduced, is that in the UK, about a third, just a bit over a third of deaths are after withdrawal of life-sustaining treatment. Whereas in the United States, it's less than a quarter, somewhere between a fifth and a quarter. Now, in the UK, you'd say, oh, well, that's because in the States, they're paid to carry on and they go on far too long with people who have got no chance of surviving. But if you go and ask the USA doctors, they say, oh, well, in the United Kingdom, they're far too willing to give up. So I don't know which is right about that. I don't know if that affects outcome, but it does show that there is a difference, and that's been repeated many times. And it's not just between countries. This study is a little bit old now, but I think it's been, there are more recent studies that back it up. And they looked at 12,000 patients in the UK in ITU and looked at rates of withdrawal of active treatment against deaths. And they again showed that in the UK, similar to the other study, a third of all the deaths in intensive cares are after withdrawal of active care. But what was interesting was that there was a massive variation between one unit and another, right down to less than 2% of the deaths on ITU were after, on a unit were after withdrawal of active care, up to nearly all of them were, 97%. Now, some of that will be because units have different patient mix, have different, might be elective surgery, might be a hem-onc unit, might be a medical unit, etc., etc. But even when they corrected for that, there was huge variation. And they looked at factors associated with whether you were likely to have care withdrawn. And some of those are as you'd expect. If you're older, if you had comorbidity, if you'd had CPR, you were more likely to have withdrawal of treatment. But I found it very interesting that you are more likely to have withdrawal of treatment if you're a medical patient than a surgical patient, or if you're an emergency surgical patient as opposed to an elective patient. And those were independent factors, and they slightly point to me that we're more happy to withdraw treatment when we don't feel in some way responsible for the patient having got into that position. i.e. the medical patients and the emergency surgery, they're there because of, in inverted commas, bad luck. Whereas an elective surgical patient, we have had some sort of influence in them being in that position, so perhaps we're less likely or less willing to withdraw. You then get onto the issue of withdrawal versus withholding treatment. Is there a difference between, once I've got someone on a ventilator, taking them off it, compared with actually not putting them on it in the first place? And this is a study from COVID, an opinion piece from COVID looking at that. And essentially their conclusion is that ethically, there should be no difference between withdrawing a life-sustaining treatment like a ventilator and withholding it. Because in both cases, you're talking about a future treatment. So the current situation of the patient doesn't make any difference to whether it's appropriate for them to have that treatment in the future. Therefore, whether they're on the ventilator at the moment or not should not influence your ethical position on whether they should have it tomorrow. Unfortunately, or interestingly, legally, that's much more knotty, because if you've got someone who isn't on a ventilator and you deem that it's an inappropriate treatment, then you don't have to give it, and the lawyers will back you up in that position. So it's quite easy legally to withhold a treatment on the grounds that you don't think it's clinically appropriate. But if you've got someone on a ventilator and it's keeping them alive, then potentially withdrawing it is more difficult legally if say the family disagree with you. And my experience with the lawyers is they'll be much more reticent about saying you're okay to go against the family's wishes and withdraw the treatment. So although ethically they are equivalent, in real life, in legal difficulty, they are not the same. And that issue of them being not the same has consequences, because it potentially means that if we look on withdrawal as more difficult to do than withhold, then there is the risk that we will withhold on people more often to avoid problems with withdrawal down the road. So we're less likely to give people who we think have got a low chance of benefiting from ITU what we call a trial of ITU, because if that trial doesn't seem to be working and they don't seem to be responding quickly, we'll be worried that we won't be able to withdraw the ventilator, and then they'll be stuck on ICU using up precious resource for a prolonged period of time. And of course, that means that we may well end up in an inadvertent, illogical rationing situation where we're using beds for someone we don't think it's appropriate for because we can't withdraw. And so we're therefore potentially more likely to withhold. So there's some really thorny issues about whether withdrawal and withhold in real terms are different. So does this impact outcome? Does how aggressive we are in ITU impact the outcome of the patients? Well, this is really difficult to tell, and there's no randomized controlled trials, but there is this study looking at post-cardiac arrest, which I think is interesting to us from an intensive care perspective. So they looked very recently at 26,500 out-of-hospital cardiac arrests and looked at how many of them had withdrawal of life-sustaining treatment on intensive care. And the vast majority of these would be for the fact that it was felt their neurological outcome was so poor due to hypoxic brain injury that they shouldn't continue. It wasn't in the patient's best interest. And they found that about a third of them, or just under a third, had withdrawal of life-sustaining treatment, sorry, more than a third. And interestingly, 6,000, so more than half of those, had it very early. And what they showed with what that was is a huge variation again from unit to unit based on non-clinical things, as into whether and when you had withdrawal of life-sustaining treatment. Now, this is important because the national guidelines are that you can't really prognosticate neurologically within the first 72 hours. So people are being withdrawn on early, even though it's not really early and long enough to prognosticate neurologically. Unsurprisingly, the patients who were withdrawn on had a higher hospital mortality. That's difficult to interpret, of course, because it depends whether you think we don't know how the long-term neurological outcome of the patients who survived. So you might argue that the people who had a higher mortality, actually that was in their best interest. But I think this is important because it does show that when we make decisions to withdraw or withhold treatment, we're not just accepting the inevitable, we are also often ensuring the inevitable. Be that right or wrong, I'm not making a judgment about that. I'm just saying that we have to accept, again, this issue of uncertainty about what the outcome might be. Fascinatingly, with this study, looking back at biases and noise, they found that you were more likely to have withdrawal of life-sustaining treatment after cardiac arrest if you were from a deprived background, if you were female, and if you were white. None of which I assume can be of any clinical relevance. But of course, again, we don't know which side of this, and there'd be massive arguments about which side benefited. So then there's this, the other argument we hear a lot is that the difficulty for the public is they don't really understand ITU. They don't know how miserable it is, how unpleasant. And so physicians, so particularly, intensive care physicians and doctors generally, they wouldn't, when they're coming to the end of their life, they would not go for all the horrible, invasive, nasty treatments. They go for a much more try and get home and avoid horrible, invasive treatments. And there are surveys showing that that's what physicians believe they will want in the future. But this study from Canada looked at what physicians actually do compared with non-physicians in the last 6 months of their life. And they looked at 2,500 physicians versus, I think, 7,500 non-physicians. And actually what they found was that physicians don't make any different decisions to anyone else, essentially. So they're actually, if anything, more likely to die in ICU than non-physicians. There's no more likely to die at home. They're more likely to visit ICU in the last 6 months, have a feeding tube than their non-physician matches. They are more likely to get palliative care. They opt for more chemo. They use more opioids. And this really makes me think, when it comes to it, do we really know the decision we'd make for ourselves? Do we know our future selves as well as we think? And this, again, leads me to question how much of a panacea advanced directives are. I'm not against advanced directives. I think they're a great thing if you want to do them, but I think we have to accept that they're not a panacea, and we don't always know what our future self will want. A 20-year-old's view of what is an acceptable life changes very much when they're 40, when they're 60, when they're 80. And we all have to be aware that how we'll react when it actually comes to us is very difficult to know. Yes, birthing plans possibly demonstrate that. I'm going to skip through this because we're a bit short of time. This is just to say that obviously, ideally, when the patient has capacity, We like to allow them to make the decision. We like to be able to give them the information for them to weigh it up and make a rational decision. But there is a school of thought that actually says it's very optimistic to expect patients facing life and death decisions to be able to make rational decisions using the rational actor model. And the reason for that is that when we do that normally every day, we use our experience, our previous experience to make a rational decision, a complete understanding of the situation, and previous trial and error. Now, if you're facing someone with, the existential life and death decisions, they haven't got any of that to fall back on. So expecting people to be able to make rational decisions is really difficult. They've got no experience, they've got no trial and error. They've often either got incomplete knowledge of the benefits and harms of intensive care, or they're overwhelmed with knowledge. And often there is no rational conclusion. So these people argue that actually we should use more of a value awareness model, i.e. allowing people to be as rational as possible, but then accepting that there are limitations to that and approaching it slightly different. But we won't get into that in detail now. So I'm going to conclude now because I know we're running out of time. What should we do about this? I hope that I've shown you that our decision making when we're trying to work out who and whether to admit people to ITU and whether to continue with their invasive treatment is very difficult. But what should we do about the way we make these decisions in the future? There's lots of variability, there's lots of unknown, there's lots of influences, there's lots of uncertainties, but there always are in medicine. Does that mean we should change, or does it mean we're doing the best we can? This is just how it is, and we are good people, and we just have to carry on muddling through. Well, I think there are probably not, and I think there are two things, two answers to that question for me. The first is, I think we should be more systematic in the way we make these clinical, ethical, and legal decisions. And this flowchart is from the neurological, the textbook that the Queen Square Hospital write in the decision-making chapter. And I think it's really nice. It goes back to our ethical principles, but it just gives a little bit of logic, a bit of rigor to the way we make these difficult decisions about invasive treatments. So they say there are basically 5 steps to the procedure. The first is to respect autonomy. So has the patient got mental capacity to make this decision, or have they made a clear advance directive? If they have, then we should follow that autonomy or directive as much as we can. But if they haven't, then we should first look at beneficence. So what are the benefits of the proposed treatment? Can they work? Can they achieve their sort of physiological goal? If that's the case, then we move. If it's not the case, then we should not offer that treatment. If it is the case, then we should look at the harms based on the risk of that treatment. Do the benefits, as far as we can tell, outweigh the harms? If they don't, then we should again not offer the treatment. If we think they do, then we should continue down the algorithm. Is this a reasonable use of resource? Is this a just treatment? Is this acceptable within NICE guidelines, or it's a reasonable use of the national health resource? If it is, then finally we should go back to autonomy and recheck that the patient wants this. Is it in their best interest from all we can tell? Not just if they got an advance directive, but from what the relatives think. And if that's the case, then we go ahead with the treatment. Now, I think that's a really nice way just to make our decision making around patients coming to ITU more rigorous. But of course, it doesn't get over all the issues that I've dealt with, that I've been talking about up to now in the talk. And so there's a second aspect to our decision making on ITU, and that comes in 2 parts. And I promise in my last 2 slides. The first is that we have to acknowledge a whole load of things when we're making decisions about difficult, complex patients coming to ITU. The first is that we don't know. We sometimes know, but often we don't know whether someone's got a reasonable chance of getting better. We must accept that we've got biases. We all come from a background. We play roles in the hospital in this drama. We have different views on what gives life value. There are limitations what patients can do. There are limitations to us all making advanced directives. I don't want to make an advanced directive, and I very much respect people who do, but I don't, and I think there are a lot of people who don't. And also, we can't expect patients to be able to make really lucid, clear decisions always. We should allow them to try, but we should also be cognizant that it's hard. We have to accept that the NHS is a limited resource. Justice is one of the 4 pillars. We have to accept that there's conflict often between the pillars. Autonomy and beneficence don't always go arm in arm. We have to accept that withdrawal and withhold in practical terms aren't always the same thing, even if ethically we think they are. And we have to accept that all the people involved have incomplete knowledge, from the family, from the haematologists, from the intensivists, and all of them have got strengths and weaknesses, and we've all got to be cognizant of each other's strengths and weaknesses. And finally, I think we have to accept that the way we do it at the moment is never going to be always to offer what people want, because of all the conflicts above that. And so we find difficult ways through these issues. Now, my final slide, and this is a sort of just a possibility for the future, and something we don't at the moment, but maybe with all that in the background, we need to have a bigger discussion as a country. Maybe we need to think, what do we want NHS ITU to do? Maybe we need to accept that we're dealing with society here, not just with individuals, and we have to think about how we want to spend the ITU money. And in order to do that, perhaps rather than just let people like me make this on an individual basis, we ought to get some sort of citizens' assembly or group of experts together, medical economists, ethicists, intensivists, and for them to look at these decisions, look at all the legal, ethical, financial issues, and then think about how and by whom these decisions could be made in a more formal way. And so that perhaps in such in an uncertain, variable environment, we should get some guidelines together to try and reduce that variability, to increase the objectivity of the decisions we made, and therefore perhaps improve the fairness and transparency nationally. Now, of course, that's a lot to ask, and maybe we don't want to open that can of worms, but I just put it out there as a food for thought. Thanks very much. Sorry, I've overrun a little bit. I do apologize.
Hi, thank you, Jim. Really, really interesting presentation. We have a couple of questions in the chat for you, if that's all right. So the first one is, what are the main reasons for withdrawing treatment in the Hem-onc population, would you say?
I think so. I think in many ways they're the same as the general population, i.e. they are when we feel that the burden of treatment has outweighed the benefit. So as we see someone with a disease with a limited, a prognosis of say 30% cure in someone who isn't in organ failure, who then goes into organ failure and is unable to have their treatment, and then doesn't respond to organ failure, i.e. bounce back relatively quickly from an infection or whatever it is, that we get to the point that actually we're saying we're now in a position where we've got established organ failure in someone with a reduced physiological reserve and a survival chance of 30% in the best scenario, and that adding up leads to a situation of us feeling that the burden of them having this treatment outweighs the benefit. Now that's a very subjective decision, and it's not. But of course, either way you make that decision, you can be doing harm. So you've got to be very cognizant, not just of the chance of them surviving, but also of the harm we're doing. And I think that's where these discussions become really difficult and really complex. And the longer, of course, someone's on intensive care, perhaps not receiving their chemotherapy or whatever it is, the longer their recovery from that intensive care is going to be, and the lower their chances of surviving the disease. And so that's the equation we get into, I think.
Thank you very much. I think we might have time for one more question before we go for break. So, do you think that would AI make better decisions than humans eventually, considering the multiple biases and ever-increasing complexity?
That's an easy one to finish with. So, I mean, I suspect AI will make better or more rational, evidence-based decisions than and accurate decisions than medics and clinicians, let's say, in almost all areas, I suspect. Now, there's going to be two aspects to that, I think. So yeah, I think it'll be, so I think we should use AI when it becomes available, because I think it will remove a lot of biases and all those things and will give us more accurate decisions. But there's two aspects that it won't deal with. One is that I suspect the public will be much less forgiving of AI than they are of humans. So, you know, one of the aspects about driverless cars is that even if they cause far less accidents, when there is an accident, it's going to be all hell will break loose. And I think the same will be true for reporting radiological scans and making decisions in ITU. The second issue is, of course, that the human aspect of this. And so while I think we could be benefited by AI helping us reach our conclusion, of course, a vast amount of this decision making is about communication, is about trust, is about empathy, is about understanding what a patient would have wanted, about how a family are coping. And of course, that bit, which, you know, the heart of which for me is with the nurse at the bedside, is never going to be replaced by AI. And I think however good AI gets, and the medics are going to be absolutely vital in finally making that decision and trying to do it in the most humane and collaborative and compassionate way possible.
Thanks, Jim. That's great. There's a couple more questions in the chat. Could you please answer them directly?
Sure.
Thank you very, very much, Jim.
Thank you.
Thank you, Jim.
The symptoms first started. I first started having some symptoms in sort of April 2018, and had various different rashes, illnesses, extreme tiredness came up, and it kind of coincided with I'd actually had a work trip to Africa. So a lot of the symptoms were potentially linked to a tropical disease. So a lot of the thinking initially, my glands were up, but they did also go up and sort of come down a bit. And that whole discussion was around, well, if it was lymphoma, they wouldn't have gone down. So I had multiple discussions around tropical diseases and tests and investigations before eventually going into Northwick Park Hospital and seeing a tropical disease doctor there who said it didn't follow any of the patterns of a tropical disease, but he basically admitted me that day and said we need to find out what's wrong. And then after, I think I was in there for about 10 days, but they took a biopsy out of a lymph node and said it was lymphoma. That then obviously went on to identifying which type of lymphoma it was, which actually took a few weeks to have the full diagnosis, and that turned out to be it was AITL, so angioimmunoblastic T-cell lymphoma. So it was obviously not the common non-Hodgkin's, but it was obviously quite aggressive, because I was very ill at that point.
Right.
So they admitted me in, and I started with chemo. So basically, I had 2 different lots of chemo at Northwick Park. The first one reduced my lymph nodes by around 25%, but not significantly enough. The second chemo dose, and again, I can't remember what chemo dose what it was that I had, that had no impact whatsoever. That just sent me into a chemo haze where I completely lost reality. So we knew that brentuximab was obviously a short-term treatment for and wasn't ever going to be a long-term treatment. So I was initially under discussions for some clinical trials that were happening at Northwick Park.
UCLH.
Sorry, UCLH. There were some clinical trials which were happening there for some CAR T treatment. And that was one route we were potentially going down, but then it was decided that probably a stem cell transplant was probably the better route to go down, certainly initially. So my brother, fortunately for me, was a 10 out of 10 marker match. Okay. So he was my donor, obviously knowing that there was sort of that 100-day high risk period that didn't hold. The grafts for that didn't hold, and I kind of knew that before. I knew I was, my bloods weren't improving significantly, and
you didn't have any graft versus host.
No, I had no graft
really
versus host disease.
Reaction to...
I then, during that time, I mean, I had almost 0 platelets. And the target, I was going in Monday, Wednesday, Friday, and having at least 1 or 2 bags of platelets transfused in, at least 1 or 2 bags of plasma, red blood cells transfused in as well. Every time I was in, I had numerous times when I had infections, and I was in for 10 to 14 days. Yeah, I had basically, I went into intensive care, and that was basically because of a very high dose or high activation of the Epstein-Barr virus, EBV.
It was about 5 months after his transplant that he had this ICU incident.
I mean, they said the viral loading was
millions, wasn't it?
Extremely high.
Okay.
So I mean, so from that side, I apparently messaged, I was, again, because I'd gone in with an infection to the hospital, as I'd done on multiple times. I'd messaged Sue to say, yeah, they're taking me down to ICU, but I don't even remember ever sending that message.
So they basically said to me he's gone into multiple organ failure. It was unlikely he was going to survive, but they'd taken him down to ICU. They weren't sure what to do, but he did have some stem cells left over. So they said, look, we're just going to infuse those. It's either going to cure or kill, but we're at the end of what we can do. So they infused these last lot of stem cells into Stu. I mean, Stuart was sort of not conscious of what was going in the sort of the second day he was in there. You couldn't communicate with him. He wasn't able to communicate. He was on the highest sort of dialysis possible. He was extremely critical, as the consultant had put it. And this went on for, well, it's the whole of July, wasn't it? The whole of August.
Yeah, basically
about
5
weeks. And numerous times I was called in for palliative care meetings, sort of end of life meetings. They didn't think he was going to make it. But the ICU consultant, I think there was 2 that we saw. I mean, they were amazing. And one of them said, I'm going to go in, because they kept talking about putting him on a ventilator. But they obviously didn't want to do that because that was high risk of him not coming off. So one of the consultants said, I'm going to sit with him for an hour one evening, and I'm going to watch him, and I'm going to see whether I think he needs to. So he did do that. And the next day he said, look, he doesn't need to go on one. I think, we're okay. And he kind of explained that it was like he was on a treadmill running, and basically what had happened is they put it up to the steepest hill possible, and now he was running uphill. That was how hard his body was working. We went and saw him every day. I mean, the nurses were phenomenal. I mean, they had to work so hard with him. At one time, I think he had 13 different lots of things coming in.
The pumps.
The pumps. It was just, I've never seen anything like it. It was scary because obviously, you know, he was on the edge of death, but he kept on fighting. And yeah, the nurses just worked so hard, I couldn't believe it. And what was really good is sort of monitoring him for all day, every day, basically. So every time something changed, they would be ministering something else. So it was always sort of coming up, right, do that, do this, give him that. And then miraculously, and they had to put these like boxing gloves on him because he tried to pull out his central line because he was quite distressed. But it was really good as well because they were asking me my opinion on Stu. So kind of what would he want? Would he want us to fight for his life and give him a chance? And I said, yeah, absolutely. If there was a chance, if there was hope, then you've got to do it. And at one stage, he seemed really uncomfortable with his stomach. And I said to him, I think he's hungry. So they started to give him food and that really helped. Obviously, not by tube, not food to eat. But yeah, I mean, then I went one day, sort of 5 weeks later, and I was standing outside with Stu's dad at the time, and he was sitting up, sort of beckoning us in the room, and we just looked at each other, and it was like, you know, what's going on? It was a miracle. And they'd taken him off some of the drugs, obviously, sedation.
That was the turning point, was it?
Absolutely. I mean, he was so thin, he was so weak. But I could actually talk to him. So it's not being able to communicate that was the hardest thing for me, because I was guessing what he needed. You know, he didn't like his feet covered, so I was taking the blanket off his feet, so his feet were out, and it was kind of trying to work out how to keep him comfortable from what I knew. And that was the turning point for us and for you, wasn't it?
Yeah. But I think what was really good was what Sue sort of mentioned this was that the doctors and the nurses, they were getting Sue's input into how I was, but also they were obviously, the intensive care staff obviously knew how to treat me, but then they were in really close contact with my consultant as well, who was obviously has the lymphoma expertise. So between them, they were making the right decision rather than it all being on the lymphoma side or all being on the intensive care. No, that they worked together, and that was a real strength, I would say, that we saw at UCLH.
And what I really, really liked was the nurses would talk to Stuart. I'm just going to take a sample, Stu. You know, even though he wasn't responding, they kind of still treated him like a human with respect and dignity, and kind of letting him know what was happening. I'm just going to do this. I'm just going to do that. I'm going to give you this. Is that okay? And I really like that side of it because, you know, I think he could hear, because at times he did say things, but it was nice that he was treated as a human rather than sort of, a slab of flesh that's just lying there. I really like that. Yeah, that was really,
and
really nice.
From my side, I mean, obviously, again, I say I don't remember sort of those 5.5 weeks, but I had very, very vivid dreams during that period. Some of which I could then, once I sort of knew what the treatment they were doing, I could sort of relate to how I'd incorporated what I could sense into my dreams. But then also I would say during that period, I can't say exactly how many times, maybe 4, maybe 5 times during that period, I'd obviously become semi-conscious, and I was aware that days had passed since I'd sort of previously become conscious. So I was sort of, again, aware that days and days were passing. But mostly it was just very, very vivid dreams that I had during that period.
And he earned himself a lot of brownie points because the first thing he said when he woke up was, "Seeing you is the best thing ever." And I said, "Wow."
Oh.
And I've lived on that. Yeah. I've lived on that ever since.
The last 5 years. he keeps bringing it up. But yeah, no, that was, then the next question was, what day is it? And he was like, he'd lost a whole month and a bit, and he goes, and he said, what, September? And I said, yeah.
Care when I was having all those transfusions, they were trying to keep my platelets above 20. I know you said it while I was in intensive care, I think they went down to 1, was it 1 or 2?
You had all bloodshot eyes, didn't you, where they bled? At one stage, they thought he'd had a brain bleed, and they had to scan to see, but luckily he hadn't.
So yeah, it was really, and that was all really down to the Epstein-Barr virus, which was, I say, because of that viral load, which that's what had caused me to have that intensive care stay. I mean, when I first sort of came round in intensive care, I don't know if it was the following day or the day after. I mean, it took 2 nurses to sort of just lift me out of the bed and put me into a chair, and I sat there for
10 minutes,
5-10 minutes, and said, "I'm so tired, I need to go back to bed." Maybe it was a bit shorter than a few days in intensive care before they then put me back onto the ward. And then obviously I went home. I think probably about a week and a half after that, and
was told to eat everything and anything that he possibly could to try and build his strength back up, which was the best news for him ever, wasn't it? In fact, he said that, and we said to him when he was still in hospital, said, "What do you want to eat?" And he goes, "Can I have a McDonald's?" And I think you managed like a quarter of a McDonald's
Big Mac,
because that's all he could eat. But
there was a lot of discussion as to whether I should have a second stem cell, because I think they normally like to leave at least 12 months between the stem cells. But my consultant could see how unwell I still was, and really pushed for it. So I actually had my second stem cell 11 months after my first one.
In January, straight after Christmas, wasn't it?
January 2020. Which obviously, in hindsight, looking at the COVID situation, was
perfect.
Very fortunate from getting it in just in time.
So we already had the masks and the sanitation and everything.
Yeah, we had,
and everybody just joined us. So we'd already been living like that for a year.
During that whole time of doing all my illness, all the things where they said to me, we need to be careful here because people have a lot of reactions to these things. I seem to sail through. And each time they said that no one ever reacts or has any problems at this stage, were the ones where I tended to have the problems.
Right.
And that included actually just the day before my second stem cell transplant. They wanted to, obviously, previously I just had one anti-rejection drug before my stem cell transplant, but the second time, because they'd given me a stronger dose of chemo, they wanted to give me 2 different anti-rejection drugs. And I, this is quite a story in that they, obviously, because it's a very slow infusion for the anti-rejection drugs, it was over an 8-hour period, I think it was. They started the pumps at 6 in the morning. I knew how because I've been in hospital so many times, I'd restarted my centrifusion pumps and knew how they all worked. They started these 2 anti-rejection drugs coming in. I asked the nurse for some anti-sickness tablets because obviously I'd had 6 days worth of chemo. So she left the room to get some sickness tablets for me. Obviously, because the infusion was very slow, after about 2 minutes, obviously the infusion actually hit my bloodstream, and I knew I knew straight away that something was wrong. And then so I managed to
stop the pump.
I stopped the pump. I managed to get out of bed and get to the door, the corridor, and basically said help. But no one was there because it was 6 in the morning. I got back into bed. I pulled the emergency button, and I was unconscious.
And they had to do CPR on him. So I got a call the day before he was due his stem cell saying, were you back in?
No, they were taking me down to intensive care.
So he's back in intensive care, saying Stuart's in intensive care. And I said, what do you mean? He hasn't even had his stem cells transplant yet. And he'd had this anaphylactic shock to
one of the anti-rejection drugs.
Oh my word! It was, but amazingly that he came back from that.
Yeah.
I just remember feeling really sick, thinking, "Oh my word, this is just ridiculous." And they all stood there, wouldn't they, with all the adrenaline. This is.
Yeah. So because I'd had the 2 anti-rejection drugs again, this is where I sort of almost didn't follow the rules as such, in that they knew one of the anti-rejection drugs was the same as I'd had previously, and they did say that is one of the drugs that sometimes people do react to. But the second anti-rejection drug, which was the new one to me, they said they've never had anybody react to this drug ever before. Wow. So then there was this big debate all day. Which one had I had this reaction to? So therefore, they knew they needed to give me something, because I had I'd had 6 days of chemo. They needed to get the stem cells in me, and they couldn't do that without me having an anti-rejection drug. So they
used the one that they'd used previously.
They decided to go for the one they used previously. They decided they didn't want to do that at sort of 6 in the evening in the hospital, when the hospital was starting to shut down. So they decided to do that the following day in intensive care, to give me the drug, sitting there with like 6 needles of adrenaline, as sort of a backup to the backup to the backup of adrenaline, just in case.
And with the resuscitation trolley sitting there. It was a bit of an anticlimax.
Well, as you said, they did say this was the biggest. Hopefully it was, and it was the biggest anticlimax ever.
He was absolutely fine, and it went ahead the next day, didn't it? But it wasn't. I mean, when we saw the consultant, when we first got diagnosed, the consultant said to us, there were 2 things. She said, A, your life's going to be hell, and I'm really sorry, and it was. And 2, our aim is to cure. So I kind of just took that hope and just went with it, as awful as it was. It was like, right, they're only to cure, so let's just go with that. And I kind of knew that if he survived or if he didn't survive, I knew there was absolutely nothing else that could have been done for him, because everything had been done that was actually possible.
So with the second stem cell, they used a slightly different chemo. They used a slightly more aggressive chemo regime beforehand, and touch wood, it held. It's held really well.
It's 5 years in January, isn't it?
It'll be 5 years this January. I mean, it took me just over a year before I was able to even think about going back to work. I mean, it genuinely. I spent a year at home recovering. And I've had many people say to me, "Well, weren't you bored during that time?" And you just don't feel well enough to feel bored. And it was only sort of when I started to feel bored was when I started thinking, well, no, maybe I'm ready to go back to work. And
I run, so he started running with me, and we do 5K, don't we?
Yeah.
2 or 3 times a week, and
Pilates to get my core strength back as well.
I took him to Pilates, so that we do that 3 times a week, so that because he lost all his muscle strength, obviously. So we were talking about doing the marathon maybe next year.
Oh wow! Okay.
So we want to. Because Stuart ran the marathon before he was ill a long time ago, and I said, well, maybe we should just give it a go, and just a bit of a celebration, really, of where we're at in life.
Right. Hi, everyone. So I'm Perla Eleftheriou, one of the haematology consultants at UCH, and the topic today is acute complications in sickle cell disease. Unfortunate that it doesn't project very nicely, slide I can see, but you can see here that there is an acronym that we have currently introduced about 6 months ago with the help of NHS England with the aim to help to remind people who deal with acute emergencies in sickle cell patients to focus on very important key things. So the acronym is ACT NOW. So A stands for analgesia, and we all have to give analgesia within 30 minutes in line with the NICE guidelines. Within 30 minutes of coming to A&E or presenting to an acute healthcare setting. C stands for compassion, T for the necessary tests and the identification of trigger factors for those complications. and for notify, because all those people who come with sickle cell complications need to be assessed and treated by specialist hematology teams with expertise in sickle cell disease, but also to notify the next of kin or advocate if necessary. O stands for oxygen and W stands for watch, and that is to say, monitor the patient carefully. So we're going to go through some basics around the pathophysiology of the disease, just to remind ourselves what this is about, and then talk about the main acute sickle cell crisis. So just a reminder that there are a lot of different genotypes which give rise to sickle cell syndromes. The most common one and the most severe one is the homozygous sickle cell disease genotype, so SS, followed by the compound heterozygote, for example, SC, S-beta thalassemia, and there are some other rarer combinations of genotype, of genetic mutations. Important message here is that regardless of the genotype, you can have a phenotype which is not expected depending on the genotype, and that there is a lot of heterogeneity really between the different severities of sickle cell disease, and there is a strict genotype-phenotype correlation. What I mean by that is that you can have an SS patient who is relatively well off and doesn't come often to the emergency care, doesn't have a lot of acute complications, but you can have the other end of the spectrum, whereby you can have an SS patient who's very unwell with strokes in young age, leg ulcers, acute chest syndromes, and so forth. Right, the pain is the most common presenting complaint, but also other features include organ damage, which is gradually happening on the background, even in the absence of any obvious symptoms, and anemia. Those three are the cardinal features of sickle cell disease. And our patients can have acute as well as chronic complications. And of course, the focus today is on the acute complications. And under this category, we have the painful crisis, which is the most common acute complication. We have the acute chest syndromes, splenic and liver sequestration crisis, stroke, priapism, and on the other side, on the chronic complication side of things, people can have any complications you can imagine, starting from the top going to the bottom. So cognitive impairment or chronic neurological impairment due to repeated strokes or previous stroke, pulmonary hypertension, sickle retinopathy, liver disease, increased risk of gallstones, and infections because of the functional asplenia, avascular necrosis of the joints. Right, so we define the type of an acute complication depending on the actual presentation, symptomatology, and the main categories of acute complications are those in front of you. So the vaso-occlusive crisis, the aplastic crisis. Aplastic crisis refer to the complete cessation, suppression of erythropoiesis in the bone marrow, sequestration crisis, whereby the red blood cells, the sickle cells, are suddenly pulled into the liver or spleen, hemolytic crisis, and infections. So if we want to now look at it, look at all those categories in a bit more detail, because of the time restrictions, we might have to concentrate just on the vaso-occlusive crisis, which are indeed the most common presenting complications. So under this category, we have the simple, that is to say the painful vaso-occlusive crisis. We have dactylitis, acute chest syndrome, Gohel syndrome, stroke, and priapism. And let's talk about them in a bit more detail in a minute. So taking first the simple vaso-occlusive crisis, this is characterized by excruciating, not being able to control pain at home in bones and joints, but predominantly this type of pain affects the long bones. And it can be everywhere in the body. It can be on one particular anatomical side, and every crisis is different, and every patient will experience a different thing. That's the most common reason for our patients to come to A&E. And at the time, and that's why it's called simple, which is a bit misleading, but that's because at the time when it happens, it's not in itself dangerous. It can, of course, it is associated with a lot of suffering for the patient, but it can actually lead to bone infarction and acute chest syndrome very rapidly. And therefore, this simple adjective used can be a bit misleading when it comes to how we monitor the patient and the significance we put on this type of crisis. So we have to be mindful. So this graph shows you in broad terms how a crisis is developed. So we have the prodromal phase, which lasts a couple of days, classically, where the patients are feeling that there's something happening, a crisis is coming up. And then during the initial phase, which lasts another 2 or 3 days, the pain peaks rapidly. And then we have the established phase where the patient is in established painful crisis, and that typically lasts about a week, but it can take a bit longer. And then the resolving phase follows, which can take up to another week to completely resolve. So another very important take-home message is that when a patient presents to A&E with pain, there is no really there are no tests, clinical tests or laboratory tests or radiological tests that can be used to determine whether this individual is in pain because of his sickle cell disease or not, or in fact at all if they're in pain or not. So really the gold standard for pain assessment remains the patient's or the family's report. So bear that in mind, please. When you take the history, ask, is that the usual pain? What's usual? What has triggered this pain? What are the normal steady state hematological markers and vital signs for the patient? Of course, the vital signs need to be thoroughly assessed at the beginning, and don't stop by just evaluating the patient for pain. When they present with pain, ask them about other things. Be very suspicious that there might be something else accompanying the pain. So ask for atypical pain, for breathlessness, for any unusual headaches, or any sort of behavior change. If you have the family there as well that you can ask, or anybody who escorts the patient, look if there have been any seizures, any confusion, any chest abdominal pain, and do examine or ask for priapism, which is excruciating penile erection, which very often accompanies a simple painful crisis in our young males. They will not necessarily volunteer this to you. When you assess the pain, it's important to use pain scales, pain scores, to identify the intensity at baseline, which is a great way to then subsequently monitor how you're treating your patient. Ask about the exact location, how long the pain has been going on, and as mentioned before, what has aggravated, what has triggered this crisis, and what usually helps the patient. So physical examination, absolute key. And then another important message is that almost universally in the UK and internationally, all patients who are treated for hemoglobinopathy, for sickle cell disease in specialist hemoglobinopathy centres should have an individualised patient key record, which summarises their baseline oxygenation and baseline hemoglobin, and gives guidance to the emergency doctors, but also to the doctors in the intensive care unit, in the acute medical wards, and hematologists, how to treat the patient in A&E, as well as when they're admitted on the wards, with particular reference to, of course, the opioids, because this is how you treat the pain in sickle cell patients by and large. At UCH, our first line is morphine subcutaneously. The dose is 0.15 milligrams per kilogram. That's the thrust guideline. That is to say, that's what you need to follow if your patient doesn't have an individual patient key record. second line is oxycodone, and third line is fentanyl. So we are all familiar with EPIC. So in the left upper hand corner, you can see the flag. This is where the patient key records were sitting. You can see if you hover over that flag, you'll see a lot of FYIs. So this is where the red cell disorder, so the sickle cell pain protocol was sitting. But now, although a few are still there, the majority should have been transferred to the UCP, the Universal Care Patient Record, which you find under the London Care Records, again on the left side of the EPIC, of your EPIC screen, which I'm sure you're familiar with. So make reference to the patient key records. Right, so what do the NICE guidelines tell us? They recommend, it's mandatory that we follow them, of course, and we are auditing our services everywhere in relation to the compliance, and we're not really doing that great nationally. But the NICE guidelines dictate that we should administer potent analgesia, so that is to say in the form of a strong opioid, within 30 minutes of patients coming through the doors of A&E. And it doesn't stop there. It makes it very important to for us to follow other recommendations, such as continuous assessment and monitoring of the patient to ensure that we have achieved adequate pain control, and that we indeed use individualized plans. So we know that delays in initiating and continuing good, proper, potent analgesia are associated with prolonged hospitalizations and more complications, and that's why we are strong advocates, and the NICE guidelines support this. In A&E, apart from what we talked about, or when we say A&E, I include any emergency assessment location. It could be that they are admitted on an acute medical ward for something else. Let's say they have a UTI, but then what about if they develop an acute, sickle complications on the wards? All this that we're talking about applies to any emergency assessment anywhere within the healthcare system. So apart from what we said, also vital is to take blood tests at the time when you're dealing with an acute complication and see what the hemoglobin is, what the reticulocyte count is, what the total white cell count is, and look at baseline functions like the kidney and the liver function, and not to forget the group and save in case we need to intervene with a blood transfusion to reverse the complication or to stop the progression. Blood cultures and chest x-ray according to the situation, so have a very low threshold to look for infections, because these patients are immunocompromised because they don't have a functional spleen already by the age of 15 or 16 because of the ongoing sickling in the splenic vasculatures, which render the spleen atrophic. And yes, chest x-ray, if you are worried that the patient might be having an impending, developing essentially an acute chest syndrome, so acute sickling in the chest, or that if you think that they might have a chest infection. Right. Key things in red. So in an emergency, acute complication, whatever is going on, you need to think about certain management lines. So number one is fluid replacement. By and large, the majority of the patients, unless they are in heart failure, would benefit from quite vigorous intravenous hydration, and antibiotics and oxygen treatment are the other two that you need to think about. So they're all on prophylactic penicillin lifelong. However, if there is an acute infection being suspected, then septic screen and start empirical antibiotics early on according to what your suspicion is. In terms of the oxygen, all patients should be kept well oxygenated. There's no proven benefit that giving oxygen to everybody, if they don't need it, if they're not hypoxic, that it adds anything to it. But of course, even if they're not hypoxic, if they're on high doses of opioids back to back, especially if they're on a PCA, it's good practice to keep them on low oxygen maintenance. But the next take-home message is this one, that these patients are very oxygen sensitive. That is to say, they might be saturating 100% on 1 or 2 liters now, and if you remove the oxygen, they might be down to 85 or 90%. So if you don't measure the oxygen saturations on air, you're risking missing an acute chest syndrome, which is the #1 cause of death in sickle cell patients. So it's fine to put them on oxygen and support them, but when you do the measurements, the oxygen saturations, please stop the oxygen and record the oxygen saturations on air. So dactylitis, another type of vaso-occlusive crisis, essentially it's a painful crisis, but the characteristic is that it affects the bones of the hand. So this is very typical in small children. So it's typical up to the age of 9, 10, and then it becomes a bit less frequent. And the problem with this is that if the children keep having those dactylitis events, they can actually end up with significant arthropathy in their joints. Now, Gödel syndrome is characterized by significant pain in the lower abdomen mainly, and localized alleys, and this is due to sickling in the bowel and the mesenteric microcirculation. So when you hear the bowel sounds, they will be either absent or very silent. So again, it's important to recognize this complication because often, thankfully, recently not that often, but if you don't recognize it, you're risking surgeons taking the patients to theatre thinking that they need to operate on a mechanical ileus. So be vigilant about this symptom, about this complication. Usually the treatment is conservative with hydration, analgesia, and sometimes we have to intervene with a top-up transfusion. So chest syndrome is the second commonest cause for presentation to an acute healthcare setting, or the second commonest acute complication. Usually this is caused by underlying infection in the lungs or fat embolism due to previous painful bony crisis, but is the most common cause of death. So it can easily escalate into respiratory failure, and patients can die from it if we don't recognize it promptly. And the patients classically have well-established acute chest syndrome. They would have, oh, can you still see my slide? Sorry.
No, you've just flicked to the teams in the background.
Yeah, so that happened automatically. I didn't touch anything. Let me just see. What about now?
Yeah, fine.
Yeah. So these bilateral infiltrations that you can see there.
Perla. Just one thing. I think you're still in the you're not quite in the presenter mode, so it's just showing some of the bits on the side. Yeah, that's it.
Yeah, yeah. So this patchy in bilateral infiltration on the chest X-ray is something that you can see. Oh, sorry, I'm sorry. What time do we finish? I'm sorry, is it 20 past? Yes?
20 past, and we're trying to have sort of 5-10 minutes for questions. Thanks.
Yes, perfect. So this is a classic presentation. This is a classic radiological finding that you see in a well-established acute chest syndrome. So this is already very severe, right? Now you can see unilateral patch infiltration or just affecting one lobe only. So you don't have to see this full-blown abnormal chest X-ray. And the other thing to say about this is that you can have somebody who's presenting with chest pain, breathlessness, temperature, cough, which are the classic symptoms and signs of an acute chest syndrome. You do their X-ray and it's entirely normal. You repeat it after a couple of hours and you can see this. So it's a very rapidly evolving complication. And this is a definition of it. So a new infiltrate on the chest X-ray associated with any of the symptoms that I just explained. Right, detecting it, it's crucial because you can let your patient die if you don't detect it promptly, because if you don't detect it, we're not going to be able to treat it. If we do detect it promptly by regular monitoring of the observations, and in particular the oxygenation on air, by doing initially every hour, then going to 2 hours, then 4 hourly observations, then we can, if we see the patient going into an acute chest syndrome situation, dropping the oxygen saturations, we can intervene by doing either a top-up transfusion or a red cell exchange transfusion to remove completely the sickle cells and replace them with normal hemoglobinized red cells to reverse the picture. And those patients often need ITU support with Optiflow, for Optiflow or CPAP, or indeed if they are at very advanced stages of acute chest syndrome with type 2 significant respiratory failure, they might need intubations and ventilations. If we suspect acute chest syndrome, we need to start the patients on antibiotics to cover the chest, because we know that the most common cause is a chest infection. And whether the patient will be topped up or have an exchange transfusion, or indeed sometimes nothing, if the patient, because of significant transfusion reactions or significant alloantibodies, to the extent that we can't find the blood for, this is a decision made by a senior hematologist, i.e. the hematology consultant. So very early on, all the hematologists, if they are not already involved in the care, if they're under a different team, please involve the hematology registrar, who will then escalate to the hematology consultant as soon as possible. Right, so if we want to move to the stroke, which is the third very important complication, is so the stroke, don't necessarily wait for people to present with a classic hemiplegia or paraplegia kind of symptom pattern. They might, of course, present with that as well, but they can have subtle strokes with subtle neurological symptoms. Even a slight change in behavior should prompt you to do a CT head and make sure that they don't have a stroke. And the strokes in the sickle cell patients, which are the consequence of constant sickling in the circle of Willis and sort of blood flow problems, are of two types, so the thrombotic stroke and the hemorrhagic stroke. The hemorrhagic stroke is more something we see in the adults, whereas a thrombotic stroke, we see that more commonly in the children patients. What to do at the time? It's both a hematology and stroke team emergency, so we need to involve both. Usually what will reverse the picture, reverse the neurology and stop the stroke from progressing, especially if it's a thrombotic ischemic stroke, is an urgent red cell exchange transfusion. Sometimes, depending on the times of the stroke, the neurologists might take the decision to thrombolyze the patient unless there is a contraindication, but the mechanism of stroke in sickle cell patient is not the same at all as the atherosclerotic ischemic stroke that we see in the older non-sickle population. So rarely thrombolysis would be superior to the red cell exchange transfusion. What they need, these patients, is an emergency red cell exchange transfusion. And perhaps we have a bit more time to conclude the vaso-occlusive crisis, which is what I definitely wanted to talk to you about today. So we'll go on to the priapism. This is a penile erection, which is associated with extreme pain and is usually not related to sexual stimulation. It's very common in our young men. Almost half of them with sickle cell disease will at some point experience at least one episode of priapism. This is due to vaso-occlusive obstruction of the venous drainage of the penis. And essentially, the problem with these priapism episodes, if they are happening frequently or they last long, i.e. longer than 4 hours, that can lead to long-term erectile dysfunction and infertility. So this is a hematology and urology at the same time emergency, because the urologist, especially if the priapism is lasting more than 4 hours, will intervene with shunts or drainage of the penis to reverse the event, and then afterwards, to prevent it, they can give them medications to go home with, but at the same time we will support them with potentially long-term change transfusions or top-ups if just the medications are not enough to minimize the episodes of priapism. So I think since we want a few minutes to ask questions, I'm happy to stop here rather than going on to the rest of the acute complications, because what is much more common to talk about with the time we have today is a vaso-occlusive crisis. So Gavin, I'll be guided by you if you want me to carry on for another 5 minutes, or if you want to make it a conversation at this stage.
Yeah, I think we've got a few questions already in the chat, so maybe we could jump across to them if that's all right.
Yeah, that's great. Always lovely to have an interaction with the audience. Yeah, go for it. Right. Oh, do you want me to read them? Yeah. Just bear with me.
No, Perla, I can read them for you. It's okay. So our first question is, if a patient has received opioid analgesia from the ambulance, are we still going to give opioid analgesia within 30 minutes once they've arrived in the unit?
Very good question. That has caused a lot of debate. We have a lot of meetings with A&E. So myself and the A&E leads are meeting on a monthly basis about how to improve the time to analgesia time. Now, at the moment, what we said is that if the patient has had oral analgesia, like potent opioids, i.e. Oromorph and higher, not codeine or tramadol, then not to have anything in A&E for 60 minutes. But they had an injection and a parenteral opioid in the ambulance, then 20 minutes to have them from the time they had it. It's acceptable. So, and the majority of the patients in the ambulance would have a parenteral opioid. So by and large, what they had in the ambulance shouldn't make a difference really, because by the time they're brought to A&E and they triage and all that, at least 30 minutes would have passed anyway.
Thank you very much. Our next question is there any specialized psychological support to sickle cell patients due to the possible risk of addiction to strong opioids if the disease is not well controlled at some point?
Yes, great question. So we have a clinical psychology team who works very closely with us. We refer patients, obviously, if they're keen, to them. And a lot of our patients find this extremely beneficial. Because these psychologists are trained to deal with known problems that the patients have, but these psychologists attached to us are not there to support opioid tolerance. They are more there to sort of support in relation to patients feeling overwhelmed and anxious or low in mood in relation to what is going on with them, frequent admissions, loads of problems, worries around life expectancy, family issues, work issues, etc. In relation to opioid problems, which, yes, it's an iatrogenic problem essentially. We cause that because we have nothing else to give them when they come in with a lot of pain. We have very good links with the complex pain team, which consists of anaesthetists with an interest in pain, specialist nurse with an interest in pain, physiotherapists and psychologists all within the same team with an interest in pain, not just for sickle cell patients. This is a wider team, wider scope of work they do within the trust. And this psychology support offered through the complex pain team has an element of advising and supporting the patients through the opioid tolerance issue and sort of winning opioids and all that. And then separate to that, there is obviously at the national a chronic pain clinic, which is sort of targeted to the service of which is targeted to weaning of the opioids, not necessarily attached to a psychology team though. So we have a lot of different inputs. Nothing is ideal, and we face a lot of problems with people with chronic pain, and it's never easy to deal with it. And when they come in with pain, it's very difficult for them and for us to differentiate what is acute and what is chronic, and how to treat them. It can be really daunting.
Thank you, Perla. I think we have time for a couple more questions. So the next one is, we have had some patients with sickle cell that are pregnant. How do you recommend managing opioid use with pregnancy? Do you treat the same, or does it depend on how far along the pregnancy is?
Yes, so pregnancy and sickle cell disease are two things which do not like each other. so it's a very high risk situation to be pregnant and have sickle cell disease. That's one thing. Not every pregnancy is high risk in every sickle cell patient. We have some sickle cell patients who are much milder affected, and in those you expect less problems, but nevertheless it's a high risk situation to be in. Opioids is the least of the problems actually that we are worried about. So generally what we're worried about is in relation to the opioids, is high doses of opioids in the last trimester, because that will cause tolerance of the baby to opioids, and when their baby is born, they would face serious withdrawal problems, and would they have to be placed on opioids and gradually reduce them and stop them. So so we should be careful with opioid administration in the last trimester, but it's not that opioids for pain control during the pregnancy are not recommended, because if the woman has presents with acute painful crisis, they have to be treated for the pain, and the opioids are not going to cause a direct teratogenic or fetotoxic problem to the baby, but it's more the concern is around the opioid tolerance of the baby, in particular with high doses in the last trimester.
Lovely, thank you. I think that we might have time for one more. So how often do recurrent ED attendance patients need to have a blood test? Most patients in this category hardly go to the clinic for regular checkups.
So sorry, the question is how often they should have blood tests when they come to A&E, yes? Yes. Another very, very sensible question. So it's difficult to say that patients, when they come to A&E, even if they come frequently to A&E, because we have patients who come to A&E maybe once a week, once every couple of weeks, it's very difficult, and it would be unsafe to say don't do blood tests because they had them last week or last month, because you might be missing things, right? So things can happen. A patient can be fine yesterday, and today they can be in renal failure, or they might have dropped their hemoglobin to very low levels. You don't know. So it's all applying clinical judgment. This question came up in the last A&E and Haematology joint meeting we had a couple of weeks ago, and there are a lot of factors to consider. So one is the venous access of our patients. The veins are not great because they're being pricked all the time, and we want to save them for emergency treatments, especially for emergency exchange transfusions or top-up transfusions. So on one hand, you face this problem. On the other hand, it's the unpredictability of sickle cell disease and not do the blood tests, even if they present with bony pains. So I think it's a matter of judgment. So if they were in A&E yesterday, they had the blood test and they were discharged, and they come in today with a similar problem and there is not much new concern, and the veins are difficult, then we're not going to put a central line to do the blood test necessarily. But it's a difficult one, and it has to be judged according to the situation.
Thank you so much, Perla. There are a few more questions in the chat. Could you please answer them directly? It would be lovely if you could. Thank you so much.
In the chat?
Yes,
do you want
please,
me to put them in the chat? Okay. Thank you, guys. That was lovely.
Thank you.
Thank you. Bye-bye.
Yeah, thanks for inviting me to speak. My name's Mike Northend. I'm a haematologist at UCLH, and I work with the CAR T team. So I'm going to talk about acute toxicities of CAR T cell therapy today. And the main focus is about the toxicities, but I also thought it'd be useful to start with a bit of background about what CAR T cell therapy is, what diseases we use CAR T cell therapy for, useful to give some information about how effective the treatment is for when patients get through their acute admission. And then finally, I'll move on to go through the different acute toxicities of CAR T cell therapy. So firstly, to talk about what CAR T cell therapy is. So this is something called a cellular immunotherapy. So this is using the cells of the immune system, typically to attack cancer. And for all of the licensed products that are available at the moment, this is using a patient's own white blood cells or T lymphocytes, and then modified in a way that allows them to recognize an antigen on the cancer cell called CD19. And CD19 is an antigen found on B cells, and so this is currently available as a treatment for B cell malignancies. So I say those things because actually CAR T cell therapy is being looked at for all sorts of different diseases, and so looking at different targets for different types of cancer, and also looking at using CD19 CAR T cell therapy for the treatment of autoimmune diseases. So while we've got a limited number of products and indications at the moment, it's likely to change very much in the future, and you might be seeing a whole different range of patients coming in for this treatment. And so this is a living drug, so it's a drug using cells. It can be infused into the patient, they can multiply and divide, and they can persist in patients for months and potentially in some cases years, and to continue to do the job long after the treatment is given. And this is just talking a bit about the process of how we get a patient to CAR T cell therapy. So the first thing is that we need to make sure that a patient is eligible for the treatment. And so we initially do that, make sure they've got the right disease, that they're fit enough for the treatment. We do an apheresis procedure where we remove T cells from the patient's blood. And these are packaged up and sent off to the company to be manufactured into CAR T cells. And the way this is done by, it's typically using a viral vector, so a virus to infect the T cells to insert the DNA for the chimeric antigen receptor. And the cells then start producing this receptor and expressing it on the surface. So once the cells have been transduced, so they've had this gene inserted by a viral vector, the cells are then grown up in a culture medium. So you've got millions and millions of CAR T cells ready to give back to the patient. And this process takes about 3 or 4 weeks while the cells are being produced. And during that time, we've got a couple of things to do with the patient. So we try to optimize patients. We think about things like prehabilitation and managing any comorbidities. And we also, for malignant conditions, think about bridging treatment. So this is where we give patients usually a cycle of chemotherapy, sometimes radiotherapy, in order to reduce the burden of the disease before they come in for CAR T cell therapy. And when this is all finished, we admit patients. We in UCH use an ambulatory care unit to give patients lymphodepleting chemotherapy over 3 days. So this is just to remove some of their normal white blood cells and make space for the incoming CAR T. And then on day 0, we infuse them with the CAR T cells. Then they're admitted to the regular hospital ward. And national guidance is that they need to stay in for at least 10 days following infusion, and typically it's longer than this. And we have a few diseases that we can treat with CAR T cell therapy at the moment. So we can treat diffuse large B cell lymphoma. This is the most common indication. The most commonly used product is Yescarta or Axi-cel. And more rarely, we use other products like Brexucell for mantle cell lymphoma or B-ALL, or Tisacel, also known as Kymriah for B-ALL. And I already mentioned that there are lots of different products and diseases which are under investigation and might become available in the coming years. And I just wanted to quickly mention, about the effectiveness of the treatment. So you might be providing care to patients in the acute setting where they're unwell with acute complications of CAR T cell therapy. So we know that diffuse large B cell lymphoma is the commonest indication for CAR T. And this is the most common type of lymphoma, more than 5,000 cases every year in the UK. And we know that about 70% of patients will be cured with first-line treatment, which is great, but it leaves about 30% of patients who will need further treatment. We used to give patients more chemotherapy, and if they responded, then an autologous stem cell transplant, but that only led to cure in about 20% of patients. And so this study, ZUMA-7, looked at second-line treatment of patients with diffuse large B-cell lymphoma and compared CAR T to the standard of care, which was more chemotherapy. And you can clearly see from the curves that there's a much high proportion of patients who receive CAR T who are alive without disease progression. And we estimate that about 40% of patients who receive the treatment will be cured in the long term. So now I'm just moving on to talk about the acute toxicities of CAR T-cell therapy, and I've got 5 main categories. So there's cytokine release syndrome, the neurological toxicities, that's called the immune effector cell-associated neurotoxicity syndrome, or ICANS. Infection is probably the biggest risk, despite all of these other inflammatory things. Infection is still the biggest risk for patients who have CAR T-cell therapy. Something called immune effector cell-associated hematotoxicity, which can affect the blood counts following CAR T, or it's also known as ICAT. And briefly, I'll mention the immune effector cell-associated HLH-like syndrome, which is similar to HLH and also CRS. And different CAR T products have different rates of acute complications. So the thing that we use most commonly in the UK is called Axi-cell. And we know that almost all patients who receive Axi-cell will have some grade of CRS, but it's actually unusual to have severe grade 3 to 4 CRS. But with ICANS, it's a different story. So about 60%, about 2/3 of patients will have any grade of ICANS, and about 21% of patients in the study, and it might be even higher in the real world, will get grade 3 to 4 ICANS following Axi-cell. So it's quite a significant problem, neurological toxicity. And then some other products like Tizacel for BALL has a much higher rate of acute grade 3 to 4 CRS. We also know that a good proportion of patients will have problems with persistent cytopenia following CAR T-cell therapy. Although the way they report this in different trials is different, and so it's a bit difficult to compare. But perhaps 20 to 30% of patients will have problems with persistent severe cytopenias. There are some things that we can look at baseline to kind of determine how high risk a patient is for receiving experiencing different acute toxicities. So we can look at the baseline inflammatory state with blood tests. We can look at the CRP, ferritin, D-dimer. There's a scoring system called CAR Hematotox, which takes into account some of these factors. I already mentioned different CAR T products have different risks associated with them. So Yescarta has something called a CD28 co-stimulatory signaling domain in the CAR T cell, and this is associated with much higher risk of acute toxicities, including ICANS, whereas some other CAR T products have a 4-1BB co-stimulatory domains, and that's like Kymriah, which has a lower risk of these complications. And other factors like the cell dose might influence that. We know that the type of disease and the amount of disease a patient has before they go into CAR T can influence that, and that's one of the reasons we give patients bridging therapy to reduce the burden as much as possible before they come in for treatment. We know that the patient performance status, their comorbidities and organ function can influence this, so we try to optimize it and select patients appropriately for the treatment. Patients who've received a lot of prior treatment, if they've got bone marrow involvement, might be at higher risk of developing hematological toxicity afterwards. And also I mentioned that we give patients chemotherapy to prepare them for CAR T-cell therapy. So higher intensity lymphodepletion might give the CAR T-cells more opportunity to expand once they're infused and increase the risk of acute toxicity. So the next thing I'm going to talk about is CAR T-cell therapy. So cytokine release syndrome. So cytokine release syndrome is an inflammatory syndrome which can occur after infusion of CAR T-cells. And so this is activated when the CAR T-cells start coming into contact with the target antigen, so CD19 or malignant B cells for the currently available indications. And so it initially happens, so the CAR T cell comes into contact with the malignant B cell. There's release of pro-inflammatory cytokines, molecules, and this activates other cells of the immune system like monocytes, macrophages, dendritic cells, and T cells, which release more pro-inflammatory cytokines. In the blood vessels, this activates the endothelium. It can cause loss of vascular integrity, capillary leak. Patients can get fluid overloaded, have hemodynamic instability, and they can also develop a consumptive coagulopathy. We often see patients having low fibrinogen levels as a result of that. And then finally, once all of this is going on and it's activated the endothelium in the blood vessel, there can be further release of IL-6, pro-inflammatory cytokines from the endothelium, which can feed back and continue this loop. So patients get a continuous feedback loop where the CRS is perpetuated. And CRS typically comes on between 2 to 7 days after infusion of CAR T cells, but some patients you can see very quick onset, even within 12 hours of the CAR T infusion, and in some patients it can happen even later, after beyond 7 days. And it can range from a very relatively mild syndrome where patients just have a fever, rigors, myalgia and arthralgia, through to a very severe syndrome where patients can have tachycardia, hypotension, shock, hypoxia, respiratory failure, arrhythmias, capillary leak, coagulopathy, and ultimately organ dysfunction. And we use this grading system, which is from the American Society of Transplantation and Cellular Therapy, and it's graded from 1 to 4, and there are 3 domains that we look at. So we look at the presence of a fever, the presence of hypotension, the presence of hypoxia. So to have grade 1 CRS means you have a fever without any of the other criteria. To have grade 2 CRS means you have a fever and you can have hypotension but not requiring any vasopressors, so responsive to a fluid bolus, and or you can have hypoxia, which requires low flow oxygen only. For grade 3 CRS, again, a temperature, you can have a requirement for 1 vasopressor and or high flow oxygen, and then patients with grade 4 CRS have a requirement for either more than 1 vasopressor or the need for ventilation with CPAP, BiPAP, or mechanical ventilation. And in terms of the management, so the first thing to say is that we, these patients will be neutropenic. They've just received chemotherapy before CAR-T, and we can't really distinguish a neutropenic fever and infection from CRS. So we treat all patients for infection. We initiate broad spectrum antibiotics according to neutropenic sepsis protocols. We give supportive management like antipyretics, and we also monitor things like the coagulation of fibrinogen and replace if the fibrinogen is less than 1. We look at markers of inflammation like CRP, ferritin, LDH to track the CRS, and we also look at the cardiac and fluid status by measuring NT-pro, BMP, troponin, and echocardiograms. So for most patients with grade 1 CRS, we would typically monitor initially, but for some patients who are a bit frail, have comorbidities, elderly patients, we might think about giving tocilizumab for management of grade 1 CRS. So tocilizumab is a monoclonal antibody which is targeted against IL-6, which is a pro-inflammatory cytokine. So a big part of CRS is a cytokine storm and all of these molecules being released, and tocilizumab targets this to reduce the presence of CRS. And we're able to give up to 3 doses of tocilizumab spaced out by 6 hours. So I said think about it for grade 1 CRS for patients who are a bit frail, but for all other patients, it would be the presence of grade 2 CRS, which would be the trigger to use tocilizumab. For patients who have grade 2 CRS, we think about fluid boluses, supplemental oxygen. We'd also think about their risk of progressing to a higher grade of CRS, and we think about engaging ICU outreach and the ICU team at an early point if we think there's a high risk of deterioration. And then for those patients with a higher grade CRS, we treat them with corticosteroids. So we typically use dexamethasone intravenously, 10 to 20 milligrams every 6 hours. We treat with this until the CRS resolves to grade 1 or lower, and then we rapidly taper. We know patients who are on corticosteroids for prolonged periods are at increased risk of severe infection, and so we try to stop it as soon as possible. For those patients with grade 4 CRS, we also think about methylprednisolone at a higher dose, and again, the same thing followed by a rapid taper on resolution. And obviously, those patients with grade 3 or 4 CRS who are requiring vasopressors or ventilation require management on ICU. Occasionally, it's unusual, we get difficult cases which might not respond to standard treatment, and we can think about some other anti-inflammatory medications like anakinra, an anti-IL-2 antibody, or siltuximab, although we rarely have to use these treatments for patients. I just really briefly want to mention the immune effector cell-associated HLH-like syndrome. So this, again, is an inflammatory syndrome, and you might have some experience of treating patients with HLH on your units. And so HLH following CAR-T typically comes on either at the same time as CRS or after CRS, and you can see from the graph on the right the different times where it might come on. So it might be, at the time of resolution, or it might be patients have had completely resolved CRS and get HLH later. And there are different criteria that are needed for it. So patients need a fever, they need to have a raised ferritin, and some of the other criteria they may not always be present, but are characteristic. So abnormal liver function with a raised ALT or AST, low fibrinogen. Patients, if they have a bone marrow biopsy, might have evidence of haemophagocytosis on that. And patients might have new onset worsening or refractory low blood counts. And the way we manage HLH following CAR T cell therapy is again with steroids and also with anakinra, the IL-2 antibody. The next thing we're going to talk about is ICANS, or the immune effector cell-associated neurotoxicity syndrome. So this, again, is an inflammatory-related syndrome following CAR T cell therapy, and the pathophysiology is actually not that well understood, but it typically comes on following CRS, and it's unusual to have ICANS independent of CRS. And so the thinking is that all of this endothelial activation and inflammation driven by the CRS disrupts the blood-brain barrier between the systemic circulation and the central nervous system. You can get the movement of CAR T cells from the blood into the central nervous system. You could get some of these pro-inflammatory molecules, cytokines from the blood moving into the central nervous system and promoting inflammation within the brain and spinal cord. And then you can also, if you get CAR T cells within the central nervous system and other white blood cells, you can get release of these pro-inflammatory molecules within the CNS. So it's not fully understood, but these are some of the theories about how patients develop ICANS following CAR T cell therapy. And again, it's quite a variable condition. So it's a syndrome which typically comes on 4 to 5 days after CAR T cell infusion, although late cases have been reported, and that's why we monitor patients quite closely for 4 weeks following the CAR T cell therapy. It can occur at the same time as CRS or following resolution of CRS, but rarely occurs independently of CRS. And the symptoms can vary from a relatively mild syndrome with patients having headaches and mild confusion or impairment of attention to expressive dysphagia, myoclonus, and then in severe cases, encephalopathy, depressed consciousness, coma, seizures, motor weakness, and in very severe cases, you can see cases of cerebral edema in these patients. And one of the ways we assess for the onset of ICANS is by daily assessing the ICE score, which is the immune effector cell encephalopathy score. And this is a score which takes into account different factors, including orientation, naming objects, following commands, the ability to write a sentence, looking for dysgraphia, which is a sensitive sign that the patient might be at risk of developing ICANS if there's a change in their handwriting, and also attention by asking them to count backwards from 100 in tens. And this score is out of 10, and we do it daily and look for any reductions in the ICE score, which might indicate the patient's developing ICANS. There's again an ASTCT grading system for ICANS, and it's graded from 1 to 4. So it takes into account different domains. So there's the ICE score, which is the first thing. And just to say that the ICANS grade is determined by the highest scoring factor. So, for example, if a patient had any seizure, it would automatically be grade 3, regardless of what the ICE score or the level of consciousness was. So we look at the ICE score, the level of consciousness, the presence of any seizures, the presence of any motor findings, so they've got any weakness or hemiparesis, and then also the presence of elevated intracranial pressure or cerebral edema. And in terms of the management of ICANS, so for all patients with receiving a product which has a significant risk of grade 3 plus ICANS, we give them seizure prophylaxis with levetiracetam. If patients have CRS at the same time, we can use tocilizumab for that. We should do fundoscopy to look for any signs of raised intracranial pressure and consider a neurology review. We think about doing neuroimaging, including an MRI, think about an EEG to look for seizure activity, and also a lumbar puncture, which might be mainly to look for any alternative causes, including CNS infection. And we also, I said, it comes up at the same time as this inflammatory syndrome, CRS, and we look at markers of inflammation, including CRP, ferritin, LDH, and fibrinogen. So for patients with grade 1 CRS, they can be observed initially, but for any patients who have grade 2 CRS, they need treatment with IV steroids, and we typically start with dexamethasone at a dose of 10 to 20 milligrams every 6 hours. And then on resolution of the ICANS, we do a rapid taper to reduce the risk of infection. And we involve our ICU colleagues in outreach early at the onset of ICANS. And then for those patients with grade 3 to 4 ICANS, we consider management on ICU. They're treated for patients with grade 4 ICANS with high-dose methylprednisolone, 1 gram IV, or if there's grade 3 ICANS with any evidence of raised intracranial pressure. Think about things like airway protection and ventilation for patients with severe ICANS, management of seizures, and then for those patients with raised ICP, think about things like hyperventilation, hyperosmolar therapy, and neurosurgery to reduce intracranial pressure. And then occasionally we get patients with ICANS which fails to respond to corticosteroids, and we can sometimes think about different treatments like anakinra, and all the evidence base for these treatments is quite weak. I just briefly wanted to mention early infection following CAR T cell therapy. So despite all of these other complications, the lead of non-relapse mortality following CAR T-cell therapy is infection. And especially for patients who are neutropenic and patients who are receiving corticosteroids, the risk is really quite significant. So we know about the risk of neutropenic sepsis and initiation of antibiotics for neutropenic patients who have fever. And we also know about the risk of atypical infection, including invasive fungal infections for patients who are receiving steroids and are neutropenic, and perhaps also the risk of increased severity of respiratory viral infections, including COVID. And one thing we know that we've seen in a number of patients is that patients who are neutropenic and on steroids for things like ICANS or CRS, they're at risk of cold sepsis, and these are patients who might not mount a fever because of the amount of immunosuppression that they're receiving, and couldn't suddenly have a severe deterioration, including circulatory collapse, raised lactate, and require urgent ICU admission. And so we're vigilant and we're very cautious about stopping antibiotics in patients who are on high doses of immunosuppression during this period. You might notice the patients you look after on a range of prophylactic medications. So we offer patients prophylaxis against different infections, including PCP, which we give before they receive CAR T-cell therapy and then at month 1 after they've received CAR T-cell therapy. We have prophylaxis against shingles, so with acyclovir. When patients are neutropenic or on corticosteroids, they need to be on fungal prophylaxis, and we typically use posaconazole unless they need an IV alternative like ambisome or caspofungin. Patients who have a history of hepatitis B need to be on prophylaxis with antiviral therapy, and we typically give anti-pneumococcal antibiotics for patients who are asplenic or hyposplenic. And the last thing I want to mention is just about the risk of immune effector cell-associated hematotoxicity. So we definitely see a variable pattern in patients who've received CAR T-cell therapy about how their blood counts respond following treatment. So you get a group of patients where they receive CAR T and their neutrophil count recovers really nicely within a couple of weeks, and that's fine. And you see another group of patients where their neutrophil count seems to recover following CAR T but falls again, and they get the consequent risk of infection during that second dip. And you get another group of patients who are called the aplastic phenotype, where they don't recover in a timely way, and it can sometimes be many weeks or even months before their neutrophil count recovers. And these patients have a high risk of severe infection. So we can use the scoring system, the CAR Haematotox, to score to predict the risk of this happening. And we also look at some factors in the patient before they receive CAR T-cell therapy to predict the risk. So it might be, the amount of chemotherapy they've had before, whether they have any bone marrow disorders like myelodysplastic syndrome, their age, and the type of disease they have, whether their bone marrow was involved in their disease before treatment, their baseline inflammatory state, so that's in a CAR Haematotox score like the CRP and the ferritin, whether they have any kind of inflammatory toxicity following CAR T-cell therapy like CRS or ICANS could increase the risk of this happening. And this is just briefly to talk about how we assess and manage it. So we think about different causes. We look at the hematinics, medications. We make sure that any inflammatory toxicity is well managed, like Haemophagocytic syndrome, CRS, ICANS. We treat any infections. We often assess their bone marrow to look for any other pathology. And we support patients with transfusion for red cells and platelets. We make sure they have the right prophylaxis for infections if they're persistently neutropenic. We treat the underlying cause. We can think about giving GCSF, so to stimulate the bone marrow to make neutrophils from day 14 onwards, as long as they don't have any ongoing inflammatory toxicity, as GCSF is thought to potentially increase the risk of this. And then in very severe cases, we can think about, whether they have any stem cells stored. We've never had to do it at UCLH, but in very severe cases, it can be considered whether a patient would need a stem cell transplant to rescue them from low blood counts following CAR T-cell therapy. So they're all of the toxicities that I wanted to cover. So just kind of to summarize, CAR T, it can be a highly effective treatment for some patients. It can be potentially curative for patients who, previously before the availability of CAR T-cell therapy often had a poor prognosis, and we can use it to treat diffuse large B-cell lymphoma, mantle cell lymphoma, and B-ALL. It's being looked at in different indications, so different malignancies, solid malignancies, autoimmune diseases. So watch this space. There'll probably be more of this treatment coming through in the future. We know there's a significant risk of short-term toxicity with the treatment, and we're very experienced at managing it. And these toxicities are usually reversible with prompt evidence-based management. So that's all of my slides. I'm happy to take any questions.
There are a couple of questions in the chat. So our first question for you is there a role to play for cytokine absorption therapies in high-grade cases?
I suppose most cases of CRS actually respond to medical management. So the standard treatment is medical with tocilizumab plus corticosteroids, and it's relatively unusual to get cases which don't respond to that. And we think about other medical management. I'm actually not aware of any work looking at the use of cytokine absorption therapies for management of CRS. But I suppose I can't remember any cases that didn't respond well to medical therapy. So that would be how we approach it.
Thank you. So I guess the next question is, at what point do you start assessment for CRS ICANS? Is it immediately after the CAR T has been infused or on the onset?
Yeah, so the onset of CRS can actually sometimes be really quick. So we have some patients where you infuse CAR T, and within kind of 12 hours, they're spiking temperatures and having CRS. So the way we manage it in our hospital is we start off with the initial lymphodepletion chemotherapy in the ambulatory care setting, and we admit patients on the day that they have the CAR T infusion after the cells have been infused. And that's because it's really from the point of infusion of the CAR T cells that we need to start monitoring for these toxicities. So CRS can come on very early. ICANS would usually be a few days, but we start really assessing and monitoring for these signs as soon as the CAR T cells have been infused. And I think maybe part of the question was also, what's the monitoring later on when the patients get to discharge. So there used to be an NHS England requirement that all of these patients had to be in the hospital or within an hour of hospital for 28 days following CAR T cell therapy, and that's been relaxed recently. So some patients can actually go home from day 10. But we're still vigilant for these toxicities until day 28 following CAR T. And in our centre, we have a clinical nurse specialist who'll call the patient every day and do this ICE scoring system to look for evidence of neurotoxicity. We ask that the patients have somebody with them all of the time until they get to day 28. And then, yeah, so I suppose the management starts immediately after CAR T infusion and goes on until day 28. And in terms of our follow-up of patients, I suppose I could mention that, we look for how well the CAR T cell has worked. So we do a PET scan 1 month following CAR T cell therapy to assess response. And then if that looks good, we'll do another PET scan at month 3 and we won't do any more. And we follow patients up in the CAR T clinic. Patients are at risk of late side effects of the treatment. And so we need to monitor for that, including late infections is probably one of the biggest risks. And so this question about whether AML, so there are no licensed products available for AML, but CAR T therapy for AML is being looked at in clinical studies. It's a bit more difficult to target than B-cell malignancies, but it's definitely something that's being looked at academically.
Thank you very much, Mike. Another question is potential superadded or concurrent bacterial infection a worry in giving tocilizumab? I know in COVID treatment, we usually avoid it if that's a concern. Is there a role for procalcitonin?
Yeah, so this is definitely a worry with the amount of immunosuppression that we use to manage these inflammation-mediated side effects. And I mentioned in my talk, so a lot of attention paid to CRS and ICANS, but really the biggest risk of dying early following CAR T cell therapy is infection, and so we need to be really vigilant about that. Yes, you're right that we're worried about the risk of bacterial infection with tocilizumab. Patients who get CRS are almost invariably neutropenic at the time, and they all start antibiotics when they start to spike a fever. So patients are typically well covered with broad spectrum antibiotics. And our approach is that when patients are still on immunosuppression, so usually steroids, and they're still neutropenic, we avoid stopping the antibiotics until they stop the immunosuppression and or the neutrophil count recovers. And that's because we've had instances of kind of severe bacterial sepsis in patients who don't mount a fever because of the amount of immunosuppression they're receiving. So yeah, infection's a big concern. Obviously, we do use these immunosuppressants. We have to manage the toxicity, but we have to always be aware of infection and make sure patients are well covered. And procalcitonin, it's not something that we routinely use. I suppose we use more clinical assessment in terms of infection, but I know some other centres might use this more frequently than we do.
Thank you. We have a couple more questions, if that's okay. So our next question is, does treatment of CRS negatively affect the impact of CAR T on the underlying disorder, for example, diffuse large B-cell lymphoma? Or similarly, is presence of CRS correlates with effectiveness of CAR T?
Yeah, so that's a good question. I don't think there's any negative impact of having CRS on whether or not you'll respond to CAR T, but actually I think the absence of CRS, I think maybe we have some data from our centre which hasn't been published, but we looked at, if patients don't have any CRS at all, we think actually it probably means that the CAR T cells are not expanding very well, and that actually might be an indicator the treatment might be less effective. I mean, I guess you can't be sure until you do a formal response assessment at day 28, but I think the absence of CRS would be concerning for a lack of CAR T cell expansion. And so it's almost, I guess you kind of want patients to have some mild CRS, and it's kind of reassuring when you see it that you can be confident that the CAR T cells are starting to expand, but obviously you don't want that to progress to severe toxicity.
Very fine balance that. Thank you. And now our last question is it true that when the patients didn't have any CRS symptoms in the first 10 days that the CAR T will not work? There you go. Pretty much the same.
Yeah, I guess it's the same question. I mean, I don't think there's any firm evidence that, it definitely means that the CAR T cells not working, but I think it's likely that, a complete absence of CRS might be associated with a lower chance of success. But I think I wouldn't say that's a definite rule, and that, patients could still have a good response to CAR T without having any significant toxicity.
Thank you very much. That's all the questions we have in the chat. Thank you so much, Mike.
Okay, great. Thank you.
Thanks, Mike.
See you later.